that are transforming the healthcare landscape. We would request all of you to kindly spare some time during the tea, coffee, and lunch breaks and kindly visit the marketplace. Thank you. Ladies and gentlemen, as you all can see on the screen, the Honorable Minister, sir, has arrived. We would request everyone to kindly take their seats as soon as possible. The marketplace that is being inaugurated by the Honorable Union Minister, Shri J.P. Naddaji, is a showcase of cutting-edge innovations and breakthrough technologies that are transforming the healthcare landscape. This vibrant exhibition brings together leading researchers, technology developers, and healthcare innovators displaying advanced medical solutions, AI-driven diagnostics, cost-effective health technologies, and state-of-the-art medical devices. The marketplace serves as a dynamic platform for collaboration and knowledge exchange, fostering affordable, accessible, and high-quality healthcare solutions for the future of India. We invite all our delegates to kindly explore the latest advancements that are set to revolutionize the healthcare sector during the tea, coffee, and the networking breaks. Thank you. As you can see on the screen, Honorable Minister going around the exhibition, having a look at all the innovations and technologies that are being displayed there. Post that, he would be joining us on the stage here for the inaugural session of ISHTA 2025. Once again, requesting everyone to be seated, all mobile phones to be either switched off or kept on to silent mode. Thank you. Now, ladies and gentlemen, Honorable Minister, sir, would be joining us on the stage any moment now. Ladies and gentlemen, may I have your kind attention? All those walking in now are kindly requested to occupy their seats as soon as possible, and once again requesting for all mobile phones to be kept on to silent mode. Thank you. May I have your kind attention? Ladies and gentlemen, Honorable Minister Sir would be joining us any moment now. All those who are standing at the back are kindly requested to occupy the seats. We request everyone to kindly be seated. And may I once again request for all mobile phones to be kept on to silent mode. Thank you. Ladies and gentlemen, let's put our hands together to welcome Honorable Chief Guest Shri Jagat Prakash Nadda ji, Honorable Union Minister, Ministry of Health and Family Welfare and Ministry of Chemicals and Fertilizers, Government of India. A very, very warm welcome to the Honorable Minister. Also joining the Honorable Minister Sir on the stage, we welcome Ms. Bansuri Swaraj, Honorable Member of Parliament, Professor Vinod Kumar Paul, Member Niti Aayog, Government of India, Dr. Rajiv Behl, Secretary Department of Health Research and Director General ICMR, Ms. Punya Salila Srivastava, Secretary Health and Family Welfare, Ministry of Health and Family Welfare. We welcome Mr. Amit Agarwal, Secretary Department of Pharmaceuticals, and Srimati Anu Nagar, Joint Secretary Department of Health Research. Namaskar and good morning. Honorable Chief Guest, Shri Jagat Prakash Nadda ji, Honorable Union Minister, Ministry of Health and Family Welfare and Ministry of Chemicals and Fertilizers, Government of India. Guests of honor, Ms. Bansuri Swaraj, Honorable Member of Parliament, Professor Vinod Kumar Paul, Member Niti Aayog, Government of India. Esteemed dignitaries on the days, Ms. Punya Salila Srivastava, Secretary Health and Family Welfare, Mr. Amit Agarwal, Secretary Department of Pharmaceuticals, Dr. Rajiv Behl, Secretary Department of Health Research and Director General, Indian Council of Medical Research, Srimati Anu Nagar, Joint Secretary, Department of Health Research. Special invitees, distinguished government representatives and policymakers, healthcare and medical professionals, researchers, academicians and think tanks, industry and technology leaders, representatives of international organizations and development partners, heads of academic institutions, eminent speakers, delegates, respected members of the press and media, ladies and gentlemen. A warm welcome to the inaugural session of the International Symposium on Health Technology Assessment, ISHTA 2025, on the theme Bridging Evidence to Policy Health Technology Assessment for Affordable Healthcare, which is being organized by Department of Health Research, Ministry of Health and Family Welfare, Government of India, in collaboration with World Health Organization, India Country Office and Center for Global Development. ISHTA 2025 is not just a symposium. It's a movement towards evidence-based healthcare policies that ensure affordable, innovative, and accessible healthcare for all. This symposium is a crucial step towards advancing health technology assessment as a key driver for affordable and accessible healthcare in India. Over the next 2 days, we will engage in insightful discussions on how HTA can bridge evidence with policy, ensuring that healthcare remains patient-centric, efficient, and cost-effective. The presence of policymakers, industry leaders, and experts will ensure that ISHTA 2025 serves as a collaborative platform for transforming health technology assessment into a tool for equitable and sustainable healthcare solutions. We are honored to have with us today Shri Jagat Prakash Naddaji, Honorable Union Minister, Ministry of Health and Family Welfare, and Ministry of Chemicals and Fertilizers. A visionary leader in healthcare and governance, is known for his dynamic vision, strategic policy making, and transformative contribution to India's healthcare and pharmaceutical sectors. Under his dynamic leadership, India's public health initiatives have witnessed unprecedented growth, with key reforms in universal healthcare access, affordable medicines, and indigenous pharmaceutical production. He has played a pivotal role in strengthening India's health infrastructure, particularly in expanding Ayushman Bharat, National Digital Health Mission, and immunization programs. A dedicated statesman with vast administrative experience, Sir has consistently worked towards making healthcare more affordable, accessible, and technology-driven, ensuring India's global leadership in health innovation and pharmaceutical self-reliance. We are honored to welcome our esteemed chief guest, along with distinguished guests and experts. And as is customary, we begin this prestigious symposium with the traditional lighting of the lamp, a symbol of knowledge, progress, and enlightenment. May I request Honorable Minister, Sir, and eminent dignitaries present on the dais to kindly do the honors of lighting the ceremonial lamp and formally inaugurating ISHTA 2025. And let's put our hands together as the symposium has been formally inaugurated by the Honorable Minister. And may this light guide our discussions towards meaningful insights and impactful policy changes in healthcare. Ladies and gentlemen, each wick being lit and passed from one to another symbolizes the sharing of knowledge. May I request for a group photograph, sir? We thank the Honorable Minister and our dignitaries for doing the honors of lighting the ceremonial lamp and formally inaugurating the symposium. And to set the stage for today's discussion, we invite Srimati Anu Nagar, Joint Secretary, Department of Health Research, to deliver the welcome address and share the remarkable journey of ISHTA-IN.
A very good morning to you all. Honorable Union Minister, Ministry of Health and Family Welfare, and Ministry of Chemicals and Fertilizers, Shri Jagat Prakash Naddaji, Honorable Member of Parliament, Madam Bansuri Swaraj, respected Professor Vinod Paul, Member Niti Aayog, Dr. Rajiv Behel, Secretary DHR and DG ICMR, Ma'am Punya Salila Srivastava, Secretary DOHFW, Shri Amit Agrawal, Secretary Department of Pharma, Dr. Rodrigo, WHO Country Head, our guests from 18 countries, and esteemed guests and participants. It is my proud privilege to welcome you all to the International Symposium on Health Technology Assessment. It is a great honor to welcome our Union Minister to the symposium. Sir, we are grateful to you for your esteemed presence. It reinforces the significance of our collective mission for providing world-class, affordable healthcare to our citizens. Sir, your leadership, vision, and unwavering commitment continues to inspire all of us. We look forward to your valuable insights and guidance today. We also take this opportunity to welcome our guest of honor, Madam Bansuri Swaraj, Honorable Member of Parliament. Ma'am, we really value your esteemed presence here and also keenly look forward to your contribution in shaping the future of our country. We also welcome Professor Vinod Paul, Member Niti Aayog, also in his capacity as Chairman of the ISHTA Board. Sir has ably guided us through this journey. We also welcome Ma'am Punya Salil Srivastava, Secretary, Department of Health and Family Welfare. Ma'am has steadfastly reinforced evidence-based decision-making, both in policy and action. We also gratefully acknowledge the presence and support of Shri Amit Agrawal, Secretary Pharma, and leadership provided to this department by Dr. Rajiv Behel, Secretary DHR and DG ICMR. Sir, health technology assessment in India has so far evaluated about 98 health interventions for their clinical and cost effectiveness. The recommendations of HTA have been used for evidence-informed decision-making, for pricing and procurement, and introduction of new health technologies, both in central and state health departments. Sir, it is our continued endeavor to partner and sensitize state governments on use of HTA, and we have many representatives from state governments, including the principal secretaries here. HTA branding of products has also increased the credibility of these products for their marketing, both inside and outside the country. Through this symposium, sir, we strive to showcase our successes and further strengthen our processes through cross-learnings and dialogues. In the end, I would again like to extend a very warm, hearty welcome to our Chief Guest, Honorable Minister, sir, and all the esteemed guests. I also wish all of you a very happy International Women's Day. Jai Hind.
Thank you very much indeed, ma'am, for your inspiring words and for highlighting the progress of HTA in India in strengthening the healthcare delivery. It is now our privilege to invite Dr. Rajiv Behel, Secretary Department of Health Research and Director General ICMR, to kindly share his insights on an ecosystem for developing health technologies for affordable healthcare.
Honorable Minister of Health and Family Welfare, Chemical and Fertilizers, Shri J.P. Nadda ji, Honorable Member of Parliament, Bansuri Swaraj ji, respected Dr. V.K. Paul, Member Niti Aayog, Health Secretary Punya Salila Srivastava ji, Department of Pharmaceutical Secretary Amit Agrawal ji, my colleague Anu Nagar ji, all the esteemed dignitaries in the hall, ladies and gentlemen, it is indeed my pleasure to add my welcome to you all for this very important event and symposium. I would only like to say three things to begin with, that the health technology assessment, as just was said by Anu Nagarji, is not only now a program, but it is working in India to get affordable technologies evaluated, as you heard. But it is part of an ecosystem. It is part of an ecosystem that India has taken forward from its unprecedented response to the COVID-19 pandemic. As you all know, India not only managed, but managed extremely well the COVID pandemic with technologies that were developed within India. More than 95 crore tests of COVID were done in India with technologies that were indigenously developed and validated within the country. Similarly, we not only manufactured vaccines, but we made new vaccines in India, including the one that was ICMR-assisted vaccine, ICMR-developed vaccine with our industrial partners, which was Covaxin, which was given to more than 10 crore people in this country. So after that, a big change has happened in the country. The level of confidence that has been inspired by under the leadership of our most respected Honorable Prime Minister of India, Shri Narendra Modi ji, and under the guidance of our Honorable Health Minister Nadda ji, we have taken great confidence that India can develop indigenous, affordable, and first in the world technologies, not only the technologies that are less expensive, but also innovative technologies. For those of you who have been outside in the exhibition, would see examples of that, that at least 2 or 3 of those technologies are probably nowhere else in the world. And this is the ecosystem that the Indian Council of Medical Research and the Department of Health Research, along with, of course, our partners in Department of Biotechnology, the Department of Scientific and Industrial Research, the Department of Health and Family Welfare, Department of Pharmaceuticals, are all together building this ecosystem, which will help us in getting these technologies to the people of India and to the people of the world. And in that, I place the HTA towards the far right of that, where it will be, once the technology is developed, what is its cost effectiveness vis-a-vis all the other technologies that are available. So to end with, I'd like to share with you that the Department of Health Research, in its plan for Viksit Bharat at 2047, in the first 5-year plan, our first goal is to develop affordable, indigenous health technologies which will be available to the country and to the rest of the world. And this includes not only the technologies that exist, but also frontier technologies such as gene therapy and cell therapy. So I see this symposium in that light, that HTA is a very important part of that ecosystem. Thank you very much for being here, and we look forward to hearing from our Honorable Minister and getting his guidance further. Thank you.
Thank you, sir, for your valuable insights on fostering an ecosystem that promotes innovation and accessibility in healthcare technologies. It is now my privilege to invite Mr. Amit Agarwal, Secretary, Department of Pharmaceuticals, to address on strengthening affordable healthcare in India.
Thank you. Honorable Union Minister for Health and Family Welfare and Chemicals and Fertilizers, Shri Jagat Prakash Nadda ji, Honorable Member of Parliament, Masri ji, my distinguished colleagues on the dais and distinguished speakers, distinguished audience, and colleagues from states and other stakeholder organizations. It's a pleasure to speak at this event, which is bringing together all stakeholders, public as well as experts, and from across the spectrum. Since his technology assessment by now has been duly anchored in the system, and it is very opportune that we take stock of what can we collectively do together to make the best use of this entire assessment approach in everything that we do. Just to, as I was reflecting, we've been individually talk to each other all the time in various programs, and as one reflects, there's so many ways in which it helps. So if we talk about researchers, industry, startups, it can help them identify what research and innovation projects to pick, which are the ones that hold the maximum value ultimately. For those who need to take decisions on procurement or buying, starting from individuals and households to governments, to other organizations, and to hospitals, it can help them decide what to buy. For those who make investments in technology which helps generate future products, whether it is governments through their programs or corporates or VCs, it can help them to identify where value lies, and again where the future therefore would lie, and what needs to be invested on. In government programs and policies, where should investment be steered which would be the best use of public health money, and in public health communication and policy interventions, in prescribing habits of doctors. In everything, HTA has a huge role to play, and this works best if all stakeholders are on the same page and think together for a whole of government, whole of society, whole of nation approach. And this symposium offers precisely that opportunity. In particular, as the Secretary for the Department of Pharmaceuticals, which has the mandate to promote medical technology, medical devices, and pharmaceuticals drugs, basically this department works in manufacturing enablement. That's a steady state technology. Then we have a major program, and we spent a whole of last week on the Pradhan Mantri Bharatiya Jan Aushadhi Pariyojana, PMBJP initiative for Jan Aushadhi Kendras, where we're making highly affordable not only medicines but products available. And an HTA-based training of doctors can affect prescribing habits, and public communication can help generate demand because HTA helps identify the right price point of what would be most efficacious for individuals and for treatment. And as doctors and consumers support demand, since PMBJP does it on a viability basis but extremely cheaply, the whole 15,000 going on to 25,000 network of JAKs can really pitch in and support that. Our department also, through the National Pharmaceutical Pricing Authority, is responsible for price regulation. And in that, there is already a provision that if there is innovation in a drug, while it is currently based on market-based pricing, that innovative drug can apply and seek a special price point. Now, today we do that on our own in the NPPA, but an HTA methodology can be very useful in evaluating what's the right price point. And in fact, it could perhaps work in the reverse also. If somebody has an innovative project which will require investment and effort, and if a price point is readily available through the HTA technology, they could give signal something, a willingness to go with a particular price point, thereby enabling investment and research in that direction. Similarly, the drug price control order under the National Pharmaceutical Pricing Policy includes provision for exceptional pricing decision. Again, if it comes informed by science, which is well established, decision making today, which goes through expert committees, etc., and maybe dilatory and uncertain, can become more predictable and thereby help promote innovation. And similarly, in NLEM, while drugs, the normal generic drugs are commoditized, but if there is innovation happening around them or medical device products, a subclassification of that, again coupled with the price point, if it comes from the expert sides, for which our department depends on the Health Ministry, both Department of Health and Family Welfare and Department of Health Research, ICMR, that would be hugely helpful for us. Finally, research and innovation. That's the game, that's the future. Treatments of the future, products of the future are going to look very different, and that is already happening in a big way. We have in that our own National Institutes of Pharmaceutical Education and Research. The research, this year we set up centers of excellence there, in each of them focused on certain areas. The selection of the projects which will be taken up in partnership with industry can be guided by HTA. And when the projects are evaluated and published, or even papers are published, incorporating an HTA element will add to the body of public knowledge and decision making, both in policy as well as in commercial decisions. And finally, we've just yesterday launched the EOI, the Expressions of Interest, for our promotion of research and innovation in pharma medtech sector, PRIP scheme, where we are going to support both industry and startups directly to the tune of rupees 4,250 crores. And in that, we had already internally discussed with the HTA organization of the Department of Health Research, and some of the learning from that we try to factor in while evaluating proposals. And as proposals come out also, we would be guided by HTA methodology in helping evaluate them, showcase them, and that can also result in market matchmaking. So to end it all, I compliment the Department of Health Research for organizing this summit and for giving us all this opportunity to engage with you. Thank you.
Thank you, sir, for sharing your thoughts on how we can make affordable healthcare for all through innovation and policy interventions. And now, ladies and gentlemen, to discuss the affordability and accessibility of health technologies in India, we are honored to invite Ms. Punya Salila Srivastava, Secretary Health and Family Welfare, Ministry of Health and Family Welfare. Let's put our hands together to welcome her.
Good morning and namaskar to everybody. A very, very happy Women's Day to all of you. Honorable Union Minister for Health and Family Welfare, Shri Jagat Prakash Nadda ji, Sushri Basuri Swaraj ji, our Honorable Member of Parliament, Professor Vinod Kumar Paul, Member Niti Aayog, Dr. Rajiv Behel, our organizer for today, Amit Agarwal ji, Anu Nagar ji, distinguished guests, esteemed colleagues, and fellow advocates for affordable care. At the outset, I would like to congratulate ICMR and their partners for organizing this symposium. Almost every day these days, we read heartening news about development of new technologies, new innovations by our enterprising youth, scientists, and entrepreneurs. And I think this symposium is indeed very timely. And it is indeed an honor and privilege to address all of you on this issue. As you are aware, under the visionary leadership of our Honorable Prime Minister and the guidance of our Honorable Health Minister, we have been working to ensure universal health coverage across the country. And one of the most pivotal steps in this direction has been deciding on the right interventions and integration of digital health technologies. In particular, digital health technologies, as you saw in the exhibition outside, or as you will see during the course of the day, have proven invaluable in bridging the gap in healthcare services between urban and rural areas. By using these technologies, we are improving the reach and quality of our healthcare services for all citizens, regardless of where they live. We are trying to strengthen and empower our primary health centers, our Ayushman Arogya Mandirs, our community health centers, our district hospitals by using these interventions. So what becomes very important is that we know what works and how to do it, at what price to do it, and what to prioritize. And it is in this context that ISHTA has proved invaluable to us. As we implement our various healthcare programs, it guides us in one, being evidence-based, in deciding what is safe, the cost effectiveness, and in supporting innovations. So what I would like to share at this stage with you is some of the digital initiatives that we have taken in the country. So whether it's programs such as telemedicines, electronic health records, AI-driven diagnostics, or other indigenous technology solutions, they have improved the efficiency as well as the accessibility of our healthcare services. And this has resulted in significant reductions in treatment costs, some of which has been shared in this exhibition with all of you. It has also helped us streamline our healthcare guidelines and benefit our public health programs and, most importantly, citizens. So one such initiative, which I'm sure many of you are aware, is the eSanjeevani, our telemedicine portal. It has revolutionized access to healthcare by enabling millions of people to consult their doctors and specialists remotely. And with the help of AI-based clinical decision support systems, physicians are assisted with differential diagnosis, which improves the accuracy of treatments and reduces the chances of medical errors. As of today, eSanjeevani has successfully facilitated 351 million teleconsultations, both direct and indirect, making healthcare accessible to millions of people right at their doorstep, especially in remote and underserved areas. The Ayushman Bharat Digital Mission has also played a pivotal role in providing easy access to medical records, which significantly improves patient care and follow-up. Under this mission, I'm happy to share that nearly 48 crore health records have been linked, creating a comprehensive database that ensures continuity of care across healthcare departments and helps citizens store their healthcare records over their lifetime. Under the tertiary care for cancer centers, we have implemented a hub and spoke model to provide cancer care across the country. This model connects district hospitals and medical colleges with central cancer care treatment centers, ensuring that patients receive high-quality care regardless of their location. Some of you might have read this year's budget announcement under the National Health Mission. We are supporting this effort by establishing district daycare centers, which will act as sub-spokes for cancer diagnosis and treatment. Whether it be ABDM, whether it be Sanjeevani, many of the measures which the HTA has undertaken will help us strengthen the link between the district cancer care centers, the tertiary cancer care centers, and even our Ayushman Arogya Mandir, where we are screening for cancer. The National Telemental Health Program, Telemanas, is further improving access to quality mental health care services across the country. As of 28th February 2025, the program has handled more than 19 lakh calls on this helpline, providing crucial mental health support to all those in need. The UWIN portal, which we developed by repurposing the CoWIN portal. It digitizes vaccination services for pregnant women and children and has made significant progress. So far, we have registered 8.97 crore beneficiaries, conducted 1.57 crore vaccination sessions, and administered 34.8 crore vaccine doses by using the UWIN portal. So in all of these interventions, HTA is playing a critical role, and I'm sharing these interventions with this August gathering in the hope that more interventions can come up which can support the endeavors that we have already taken. HTA has already rendered a lot yeoman service for our National Health Mission under the Pradhan Mantri Jan Arogya Yojana, as you will see in one of the exhibitors here. It has helped us devise, evaluate, and reduce the cost of our health benefit packages. So I really look forward to the outcome of this symposium, and I'm sure that the discussions today will catalyze in making our healthcare technologies truly accessible and affordable for every citizen. Thank you.
Thank you very much indeed, ma'am, for highlighting the critical role of accessibility in making healthcare truly inclusive. Ladies and gentlemen, we are honored to have with us Professor Vinod Kumar Paul, Member Niti Aayog, Government of India, a renowned public health expert and policymaker who has played a pivotal role in shaping India's healthcare landscape, spearheading transformative initiatives like Ayushman Bharat, National Health Policy, and Mission Indradhanush to enhance healthcare accessibility and affordability across the nation. We request Sir to kindly share his thoughts on strengthening India's health policy framework. Let's put our hands together to welcome our guest of honor.
Namaskar. Good morning. Honorable Union Minister of Health and Family Welfare and Chemicals and Fertilizers, Shri Jagat Prakash Nadda ji, Madam Bansuri Swaraj ji, Honorable Member of Parliament, Dr. Rajiv Behel, DG ISMR, Secretary DHR, Madam Punya Salila Srivastav ji, Secretary Ministry of Health and Family Welfare, Shri Amit Agarwal ji, Secretary Department of Pharmaceuticals, distinguished participants from 18 nations, WHO representative Dr. Afrin, other partners, colleagues and friends. It's a remarkable day today to celebrate the journey of an important, critical, pivotal institution in the health sector of India, namely the Health Technology Assessment India, which is playing an extremely important role in improving healthcare through providing information on effective strategies and technologies through the lens of cost effectiveness above all. ISHTA has evolved over the last 8 years into a very mature organization. And it is India's unique model of the institution. Over these years, and I've had the opportunity to be a part of the ISHTA family, I see 5 important achievements. Firstly, our organization has become robust thanks to the leadership of the 3 DGs, including Dr. Soumya Swaminathan, Dr. Balram Bhargava, and of course, Dr. Bahal, yourself. And the Government of India rightly decided to make ISHTA as a full-fledged office, attached office of the Department of Health Research. That's one achievement. We are robust in our organization, and our systems are working, the SOPs are in place. Second, the scientific rigor with which the analyses are being done are now profound and world-class. This took some time. We were into new areas. We value the inputs we received from other HTAs, in particular UK and Thailand, through WHO in particular. But as we evolved, our scientific rigor today is truly of global standards and embedded in the Indian context as it should be. Methodology, analysis, interpretations, linking it to cost effectiveness, matrices that apply to our own nation. So that's the second achievement. The third achievement is that ISHTA is not about one particular office where 15 people are there in Delhi. No. It's about the entire network of our scientists, public health experts, our statisticians, our clinicians, and others scattered all over the country. And that's our true strength. And we have a full-fledged network. You'll hear these details in the course of this symposium. That is our true strength. And now it's an emerging science. It's every day. The science of health technology assessment is now taking deep roots, and there is a huge capacity that is building up. And the fourth one, that we have seen its real use in health sector, health policy, and health programs. Madam Shalila mentioned its role in Ayushman Bharat Pradhan Mantri Jan Arogya Yojana. In fact, one of the big ticket levers that it allowed us to pull at the inception of Ayushman Bharat PMJ was the HTA inputs that came into the health benefit package, shall we say package rates. And ma'am has highlighted that over a period of time, we are gaining momentum in terms of our rigor, our real and appropriate costing to the packages. And this is our commitment to the partners who join the network of PMJ facilities, public and private, that the reimbursement that they get for serving should be optimally priced, not underpriced and not priced at the profiteering level. Finding that right balance has been a contribution of ISHTA, to which I must add the contribution, sir, that has been made to TB elimination program in particular, and also the very important curriculum of the country on sickle cell elimination, which was launched by the Honorable Prime Minister in 2023. So these are 3 major examples. And the 5th achievement is that in a federal system where health is a state subject, the uptake of these ideas, products, and partnership with the states has now started to bloom, which is so important because every state adds additional pathways of services, adapts the pathways that are generic in the nation, and indeed, at times, tries to do several new things in their own way, pushing the frontier further. And in that regard, therefore, acceptance by the states is extremely valuable. So these are the 5 achievements. But STA is about picking up the right things, right technologies, right strategy in preference to something which is less cost effective. It's a scientific process. We will never be in a world where everything can be done, every priority can be met, intrasectoral or across sectors. There will always be a need to rationalize resources. The richest of the nations are also rationalizing one versus the other. Having a scientific process to do so, based on evidence, based on analysis, based on intersectoral inputs, such as economic impact, social impact eventually, and so on, is the fabric, is the DNA of this institution. The nation has taken the call of the Honorable Prime Minister to lead this nation to the status of a Viksit nation, a developed nation, a Viksit Bharat at 2047. Viksit nations and emergent nations need strong institutions. And in that regard, sir, ISHTA is one of those institutions, sir, which will enable our path toward Viksit Bharat, playing its responsible role in one of the most important sectors of any nation, namely healthcare. The Honorable Prime Minister has said, only a Swasth Bharat can deliver a Viksit Bharat. Viksit Bharat is not by itself complete till we also have a healthy India. And in that regard, having an institution which on a daily basis is gaining strength is important, and we are very proud of the achievement. My congratulations to the team, ISHTA and Department of Health Research. I would urge that the teams that are representing the various parts of this network should really put in more energies, strengthen your capabilities. We are there to facilitate you. We want this science to evolve. I encourage you to pick up on PhD work in this area. I encourage you to write so that people globally notice our strength in this area. And one day, we will be the very best STA in the world. In 10 years from now, I have no doubt that we shall be the very best STA in the world, and that is a direction in which we will all move. We also potentially could have, sir, an international dimension, because India is a friend of the world, particularly the global south. I think time would come now, or may have already come, I would say, when we start thinking about this role for our nation, for our institution, which has now served the purpose for our nation, is serving the purpose of our nation continuously, to have an international outlook and international contribution that we all can make. In the presence of international experts in this area, we look forward to hearing your experiences, your expectations, your learnings, your best practices, so that we can embrace them into our own, very own health technology assessment system, organization, and the network that this nation has put together. Thank you very much. Jai Hind.
Thank you very much indeed, sir, for your insightful remarks and for emphasizing the need for a robust policy landscape for affordable healthcare. Ladies and gentlemen, we now move to a momentous segment of today's event, the release of some of the key initiatives. These initiatives mark significant strides in advancing healthcare accessibility, affordability, and innovation, strengthening our commitment to a healthier future for all. Each of these initiatives is a testament to India's dedication to evidence-based healthcare solutions and policy-driven advancements. The first initiative we unveil today is the ISHTA Technologies Compendium, which is a comprehensive document that showcases the latest health technology assessment studies conducted in India This compendium serves as a valuable resource for policymakers, researchers, and healthcare professionals, offering insights into cost effectiveness, affordability, and implementation strategies for innovative health technologies. I have the privilege now in requesting Honorable Chief Guest, Shri J.P. Naddaji, Honorable Minister, Sir, to officially release the ISHTA Technologies Compendium. And a round of applause on the release of ISHTA Technologies Compendium by the Honorable Minister. Thank you, sir. The next initiative that we unveil today is the Open Real-Time PCR Kit for Pulmonary Tuberculosis Diagnosis, QuantiPlus MTB Fast Detection Kit by Yuval Life Sciences. The Indian Council of Medical Research is committed to support the National Tuberculosis Elimination Program by developing and validating newer tools and interventions. One such test validated by ICMR is QuantiPlus MTB Fast Detection Kit, a low-cost indigenous open system RT-PCR test developed by Yuval Diagnostics.
आज का दिन हमारे लिए बहुत खास है क्योंकि हम मेडिकल इनोवेशंस पेटेंट मित्रा का भव्य शुभारंभ करने जा रहे हैं। यह आयोजन केवल एक समारोह नहीं बल्कि हमारे सपनों और प्रयासों की एक नई शुरुआत है। As we all know, the success of any great endeavor requires strong leadership and a dedicated team. With great pride and excitement, we are all set to unveil Medical Innovations Patent Mitra.
The Indian Council of Medical Research (ICMR) is India's apex body for biomedical research. Founded in 1911, ICMR operates autonomously under the Department of Health Research, Ministry of Health and Family Welfare. With a mission to advance medical innovations, ICMR transforms ideas into impactful products and processes for the public health system. However, many medical innovators face challenges in patent and technology transfer management. Limited awareness of patents, technology transfer, and lack of quality patent advisory support often hinders the translation of a patent to a product. To address these challenges, ICMR, in partnership with DOP, supported by DPIIT and under the guidance of Niti Aayog, has launched Medical Innovations Patent Mitra. This initiative provides comprehensive support for patent protection and technology transfer of medical innovations arising from ICMR institutes, ICMR extramural grantees and medical colleges and institutes across India. Innovators can register, submit applications for the requisite support to facilitate patentability assessments, patent filing, prosecution and maintenance, and transfer of their technologies for societal impact. This initiative shall position India as a global leader in biomedical innovation. Join our mission in empowering innovations that transform lives and revolutionize healthcare to achieve the goal of Viksit Bharat.
Thank you very much indeed. And we thank the Honorable Minister, sir, for releasing all these key initiatives. And ladies and gentlemen, now is the moment we all have been waiting for, and it is our great honor to invite Shri Jagat Prakash Nadda ji, Honorable Union Minister, Ministry of Health and Family Welfare, and Ministry of Chemical and Fertilizers, Government of India, to kindly deliver the inaugural address. Let's put our hands together to welcome Honorable Minister, sir.
Professor V.K. Paulji, the member of Niti Aayog, Madam Basuri Swarajji, my colleague in the Parliament, Dr. Rajiv Bahalji, the Secretary, Department of Health Research and Director General of ICMR, Mrs. Punya Salila Srivastavji, the Secretary, Ministry of Health and Family Welfare, Shri Amit Agrawalji, the Secretary, Department of Pharmaceuticals, Madam Anu Nagarji, the Joint Secretary, Department of Health and Health Research, innovators, representative of industry, distinguished guests, friends from the print media and electronic media, ladies and gentlemen. First of all, I convey my heartfelt wishes and congratulations to all of you on the occasion of International Women's Day today. We can see on the dais also, a good representation is also there. I wish all of you a very happy International Day. It's a matter of pride to see women contributing in shaping policies and driving progress in all spheres. I can confidently say that in the health sector, women are actively involved in a wide range of roles, from frontline workers like ASHAs and INAMs to key policy makers. I extend my appreciation and salute their dedication and impact in advancing the healthcare. Health is a priority for our government under the visionary leadership of Honorable Prime Minister Shri Narendra Modi ji. The Government of India is inclined to promote healthcare delivery, which is holistic, inclusive, preventive, promotive, curative, palliative, and rehabilitative. The preventive and the primary health care is being cared by a network of more than 175,000 Ayushman Arogya Mandirs under the National Health Mission. These Ayushman Arogya Mandirs provide comprehensive health care in the form of 12 packages of services, including free screening of non-communicable diseases like diabetes, hypertension, and 3 types of screening like cancer of oral cancer, breast cancer, and cervix cancer. Since 2014, there has been 101% of increase in the medical colleges. We have given a lot of emphasis to medical education. And I can say that 130% of increase has been there in the MBBS seats, 135% of increase is there in the postgraduate seats, and in a short span of a decade, we have now 22 All India Institute of Medical Sciences, a state of art. And we are trying to see that along with the doctors, we also have to see to expand our base, and the paramedics, staff nurse, frontline workers, we are giving training to them also and increasing their number in the same ratio. That is what we are trying to do. Here I would also like to say that to cater the secondary and the tertiary healthcare, we have done, as I said, about the 22 All Indians from Medical Sciences. We are now planning to create 75,000 seats in the next 5 years to come in the medical education. And in the last year, we have been able to enhance to the tune of 13,000. This year, we plan 10,000 more seats. And proposed in the coming times, we will be hitting the target of 75,000 additional seats in the medical education. If I talk about as Madam Salila talked about the universalization of health, Ayushman Bharat, the Pradhan Mantri Jan Arogya Yojana of Government of India, is the world's largest publicly funded health assurance scheme, which provides for secondary and tertiary hospitalization benefits up to rupees 500,000 per family per year, and 610 million beneficiaries, which is about 40% of the population of India. This is Ayushman Bharat. This PM Jan Arogya Yojana, along with the services provided under the NHM and other schemes of Government of India, have led to the decline of the out-of-pocket expenditure in a total expenditure of 64.2% a decade before in 2013-14 to 39.4% in 21-22, thus making healthcare more affordable and accessible. That is how we are working. Now coming to the Department of Health and Research. The Department of Health Research is focusing on improving affordability, accessibility, and availability of high-end drugs and medical devices to help India take transformative steps for healthcare innovations, pandemic preparedness, and development of indigenous medical technologies. MedTech Mitra, an initiative of ICMR and the Central Drug Standard Control Organization under the guidance of Niti Aayog, is a powerful initiative aimed to empower medtech innovators by providing crucial support for clinical evaluation, regulatory facilitation, and uptake of new products. 350 innovators have sought guidance and support in the MedTech Mitra in just 1 year, and I'm told that 100 more applications are there. So we are going in the right direction, that is what I can say. A country's position in the Global Innovation Index is influenced by the number of patents it generates. As per Global Innovation Index in 2024, India ranks 39th among the 133 countries. As one of the fastest growing markets in the terms of intellectual property filings, India is helping to drive a global increase in innovation and intellectual property protection, particularly in emerging markets. India's rising resident filings reflect the maturing domestic innovations ecosystem backed with the idea of Atmanirbhar Bharat campaign. Medical Innovations Patent Mitra is an initiative of ICMR launched today, which aligns with the MedTech Mitra initiative, is a testament of ICMR's commitment to the advancing medical innovation. With the launch of the flagship initiative, our country is taking significant leap toward in supporting our innovators. This platform is designed to provide crucial support to our scientists, researchers, and institutions, ensuring that their groundbreaking work is protected through patent and made available to public through seamless technology transfer. As per the Union Budget of 2025-26, rupees 998.6 billion has been allocated to the Ministry of Health and Family Welfare, reflecting 191% increase from 2014 to 15. This substantial investment highlights the government's strong commitment to enhancing healthcare and ensuring well-being of our citizens. We are duty-bound to ensure that every rupee allocated to health is utilized in the best possible way across the priorities of the health sector. Health technology assessment, the ISHTA, in an attached office of the Department of Health Research, is entrusted with the responsibility to assess the technologies, namely medicines, devices, and health programs for clinical effectiveness, and more importantly, cost effectiveness for strengthening evidence-based decision-making. Health technology assessment in India, resource centers are spread about in 19 states, which envisage a cover of all state central governments and innovators are assessing new and innovative technologies. Health technology assessment acts as an important mechanism for priority setting by which our health system can effectively achieve the government's goal of providing affordable and accessible, better quality healthcare services. I would like to mention a few examples to elucidate. Madam Selila has given 2-3 examples. I would also like to mention a few examples to elucidate how health technology assessment has helped in achieving these goals. Based on the health technology assessment, the cost of the test kit for sickle cell anemia screening has been reduced from rupees 350 per kit to rupees 25, which has saved thousands of crores of rupees. Similarly, ISHTA has paved way for introduction of more effective BPAL and BPAL-M regimens for MDR-TB, PSI-TB test for latent TB detection, and artificial intelligence-powered solutions for TB X-ray interpretation under the National TB Elimination Program. The health technology assessment in India has played a crucial role in optimizing healthcare costs and quality under the Ayushman Bharat PM Jan Arogya Yojana. Using cost data from 86 hospitals, it has supported the revision of 855 health benefit packages under the scheme. Additionally, health technology assessment in India, evidence-based recommendations have been incorporated into national clinical guidelines, including those of cervical cancer and infants' healthcare quality and accessibility. I am glad to note that health technology assessment and marketplace being demonstrated today is showcasing 50 health technologies, including drugs and diagnostics and medical devices programs, and procedures assessed and evaluated by Health Technology Assessment of India. I would urge to spread branding of health technology assessment for greater credibility of indigenous technologies, both inside and outside of the country. I am pleased that over 100 innovators and industry associations are actively participating, and I hope that they adhere the health technology assessment principles and benefit from the health technology assessment branding. I would like also that ISHTA to support the insurance agencies making the health benefit packages affordable and standardized. Health technology assessment plays a pivotal role in reinforcing the government's unwavering commitment to advancing healthcare delivery for all citizens, with a strong emphasis on inclusivity, affordability, accessibility, and high-quality healthcare services. Furthermore, it aligns with India's vision of Viksit Bharat, fostering a future of robust and equitable healthcare. I am confident that the deliberations and the discussions during the symposium will lead to an actionable insight that will benefit policy making and cost effectiveness in the healthcare. I once again wish the International Symposium a grand success, and thank you very much for giving me a patient hearing. Thank you.
A heartfelt thank you, sir, for your visionary leadership and for sharing a roadmap to make healthcare more affordable and accessible for all. And ladies and gentlemen, as we conclude this inaugural session, we extend our deepest gratitude to all esteemed dignitaries. And I would now like to invite Dr. Kavita Rajshekhar, Scientist F, Department of Health Research, to kindly say a few words of thanks.
Honorable dignitaries, esteemed guests, and distinguished participants, as we conclude this remarkable inaugural session of International Symposium 2025, it is my privilege to extend a heartfelt vote of thanks to all those who have graced this occasion with their presence and insights. First and foremost, I would like to express our deepest gratitude to our Honorable Chief Guest, Shri Jagat Prakash Nadda Ji, Honorable Union Minister of Health and Family Welfare, Ministry of Chemicals and Fertilizers, Government of India. Sir, under your visionary leadership and unwavering commitment to strengthening India's healthcare ecosystem, we are continued to be inspired for everything that we can do it for the healthcare sector. Thank you for sharing your valuable thoughts and your relentless efforts in making healthcare more accessible and affordable to every citizen of India. A special thanks to our guest of honor, Ms. Basuri Swaraj, Honorable Member of Parliament, for her esteemed presence and for supporting initiatives on innovations in healthcare. Our sincere appreciation to our guest of honor, Professor Vinod K. Paul, Member Niti Aayog, whose expertise and contribution in shaping India's health and technology landscape have been instrumental. Sir, your valuable insights into the role of HTA in evidence-based healthcare decisions has inspired us to climb this ladder of success. We are also deeply grateful to Ms. Punya Salila Srivastava, Secretary, Department of Health and Family Welfare, Ministry of Health and Family Welfare, for leadership in ensuring the accessibility and affordability of healthcare technologies reach every corner of the nation. A heartfelt thanks to you, Sir, Mr. Amit Agarwal, Secretary, Department of Pharmaceuticals, for highlighting the crucial role of pharmaceuticals in affordable healthcare. Your insights into synergy between health technology and pharmaceutical innovations will surely guide us in creating sustainable solutions. Our sincere thanks to Dr. Rajiv Bell, Secretary, Department of Health and Family Welfare, DG ICMR. He always emphasizes on scientific advancements aligned with national priorities, which will strengthen the healthcare system. We also extend our warm gratitude to Srimati Anu Naga, Joint Secretary, Department of Health Research, for her unwavering efforts in advancing health technology assessment in India. Lastly, to all the central and state government officials, international and national delegates, international and national speakers, resource center scientists, academicians, media representatives, all organizing partners, WHO and CGD, your participation, expertise, and enthusiasm are what has made International Symposium a transformative platform. We look forward to engaging discussions and impactful outcomes in the sessions ahead. Thank you to all once again.
Thank you very much indeed. May I now request everyone to kindly rise for the national anthem.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे.
And ladies and gentlemen, with this we conclude the inaugural session of ISHTA 2025. Thanking the Honorable Minister, Sir, and all other distinguished dignitaries for sparing their valuable time and for guiding and motivating us. And ladies and gentlemen, the next 2 days promise enriching discussions, impactful insights, and collaborative actions towards shaping a future with health technology assessment. And we now invite everyone to kindly join us for a cup of tea. The tea break is of 15 minutes. The next session will begin at 11:45 sharp. We would request you all to kindly be back in time for the next session. Once again, ladies and gentlemen, inviting everyone to join us for a hot cup of tea and coffee and be back in time for the next session, which will commence at 11:45. Thank you.
to kindly move forward. We are going to be beginning the session in 2 minutes. I request everyone to please come forward and take their seats. We would be starting the session in a minute. Please take the seats. Come forward from the tea area into the conference area.
इधर से भी ये दिखेगा क्या आगे वाले स्लाइड्स?
No. No.
Chairs has to be there, no? Chair and the chairs. You have your phone with you? Hi. Hi. कविता को बोला वो कह रही मैं हैंडओवर करूँगी वर्विंग का कंप्लीट भी नहीं था चेयर लगवा दिया ना
चेयर तो लग गई है 8 हैं
9 लोग हैं ना
यूपी हट चुका है
कौन सा
यूपी इज नो लॉन्गर देयर उत्तर प्रदेश
देखो हम दोनों सर और वो 4 और 5 ये तो 9 है नॉट 8 पैनलिस्ट 5 है
हाँ 9 है तो चेयर
लगा दिया मैंने लगा दिया है
We are ready.
When the last panelist comes, we will go and take our seats also. मिस्टर अरविंद पूछ के आऊँगी यही है ना मिस्टर शाम को 4 बजे सेशन अभी क्यों पूछ रहे हो आप प्रेजेंटेशन होना कहाँ से इन्फॉर्म सारा सेशन नहीं सेशन ब्रीफ में कोबरा करे शुरू में नहीं करना बाद में लास्ट पे चल गया बिल्कुल बट सर नहीं तो कैसे शुरू करें आपको फिल्म चलानी है चला दो फिर आइए अरे बट सर नहीं आए तो पहले तो उनको इनवाइट करना है ना कविता नहीं पहले तो चेयर और कोई चेयर नहीं सर को बुलाइए आप मैडम आ जाएं उनकी जगह
Very good afternoon, everyone. We will start with the technical session 2, Impact of Health Technology Assessment on Affordable Healthcare in India. On behalf of the organizers of the International Health Technology Symposium 2025, we warmly welcome you all to the technical session 2 of the Impact of Health Technology Assessment on Affordable Healthcare in India. We have a very distinguished panel with us today, and I request the Honorable Chairperson of the session, Dr. Rajeev Behel, Secretary, Department of Health Research, Ministry of Health and Family Welfare, and Director General, Indian Council of Medical Research, to kindly come up on the dais, sir. I also request the co-chairperson of the session, Dr. Calypso Chalikdao, Director, Health Financing and Economics, World Health Organization, Geneva, Switzerland, to also kindly come up on the dais.
May I also request esteemed panelists to take the dais. Professor Dr. Urvashi Singh, Deputy Director General, Central TB Division, Ministry of Health and Family Welfare. Shri Sampath Kumar Ji, Principal Secretary, Health and Family Welfare, State of Meghalaya. Dr. Rajan Kobragade, Principal Secretary, Health and Family Welfare, Government of Kerala. Shri Arvind Kumar Ji, IAS from Chennai, to please come on the dais. And Dr. Andres Pichon Rivera, Managing Director, Institute of Clinical and Health Effectiveness, Argentina.
Thank you, and we welcome all the dignitaries on the dais. We would be the moderators. Myself, I'm Dr. Madhur Gupta, Technical Officer, Pharmaceuticals, WHO India Country Office, along with...
I'm Dr. Beena Joshi, a researcher heading the Division of Operational and Implementation Research at ICMR's National Institute for Research in Reproductive and Child Health, Mumbai, and I also look at the ISHTA Resource Hub based at the Institute. Happy to be here. Welcome, everyone.
Thank you to the moderators, Dr. Beena and Dr. Madhur. So with the permission of the chair, we have a video on the impact of health technology assessment, which we would like to play it for the audience. Thank you, sir.
The Indian healthcare system serves over 1.4 billion people. To ensure access to quality and affordable healthcare, the Government of India, under the leadership of the Honorable Prime Minister, has launched several programs like Ayushman Bharat Infrastructure Mission, Pradhan Mantri Jan Arogya Yojana, and Health and Wellness Centers. Taking another step forward, the Department of Health Research, under the Ministry of Health and Family Welfare, has established the Office of Health Technology Assessment in India, ISHTA-IN. It provides an ecosystem for assessing the cost-effectiveness and clinical effectiveness of health technologies. It has a vast network of 6 resource hubs, 19 resource centers, and 10 technical partners spread across the country. It has provided more than 98 policy briefs with recommendations for central and state governments and published more than 272 research articles. It supports pricing and procurement, introduction of new health technologies, health programs, and revision of health benefit packages. For National Sickle Cell Anemia Mission, ISHTA-IN supported the procurement of point-of-care sickle cell screening diagnostic kits and reduced the price drastically. To prevent the spread of HIV and other diseases through unsafe use of syringes, state governments have procured safety-engineered syringes at negotiated prices. It also drives integration of new healthcare technologies like portable ECGs, neonatal hearing screening device, intracranial bleed detectors, telemedicine-enabled otoscopes, point-of-care tests for hemophilia, and color fundus photography for diabetic retinopathy. Thus, ISHTA ensures cutting-edge solutions are accessible to people across the country. Contributing to Atmanirbhar Bharat, indigenously developed efficient health technologies are being promoted by ISHTA. It has also supported national health programs like the National TB Elimination Program by facilitating the adoption of innovative treatments like BPAL-M for multi-drug resistant TB treatment, Psi-TB test for latent TB infection diagnosis, TrueNat for TB diagnosis, Teco Plus for tracking and managing TB health services, and AI-based interpretation tools for TB screening. One of the largest nationwide ISHTA study resulted in price revision of Ayushman Bharat Pradhan Mantri Jan Arogya Yojana health benefit packages. Using cost data collected across 86 public and private hospitals, ensuring each intervention meets the highest standards of effectiveness and affordability. Building capacity in health technology assessment, ISHTA, with hands-on technical workshops and state sensitization meetings further ensures that ISHTA principles are integrated into regional health programs. ISHTA is a powerful tool in providing affordable, accessible, available, and quality health technologies for achieving Viksit Bharat. ISHTA ensures that India is ready to face the challenges of tomorrow and protect the lives of billions.
Thank you, sir. Over to the moderators. Thank you.
Thank you very much. I would like to introduce the chairperson of the session for today, Dr. Rajiv Behel, who's the Secretary, Department of Health Research and Director General, ICMR, Government of India. Dr. Rajiv Behel is a physician scientist with specialization in pediatrics and public health. He is a PhD from All India Institute of Medical Sciences. He has also received an honorary doctorate from University of Bergen, Norway in 2022 in recognition of his contributions to maternal and child health research. He has 30 years of experience leading health research and translating research to public health policy, both in India and at the global levels. Prior to the ICMR, he was also responsible for newborn and child health research at WHO from 2003 to 2012. And he was also the head of research on maternal, newborn, child, and adolescent health at the World Health Organization Geneva office from 2013 to 2022. His expertise includes setting the research agenda, conceptualizing and implementing health research to address key priorities, mobilizing resources, implement research studies with excellence, and translating research findings into public health policy and programs. We welcome you, sir. I would like to also introduce the co-chairperson for the session, Dr. Calypso. Dr. Calypso is the Director, Health Financing and Economics at the World Health Organization Geneva, Switzerland office. She is a visiting professor at Global Health at the School of Public Health, Imperial College London. Before she joined WHO, she set up and ran the Department of Health Finance at the Global Fund to fight AIDS, TB, and malaria. And prior to that, she was also Director of Global Health Policy and a Senior Fellow at the Center for Global Development. She is also a founding member of the International Decision Support Initiative, IDSI. Her work has concentrated on helping governments build technical and institutional capacity for using evidence to set investment priorities to universal health coverage. Thank you very much and very warm welcome to the chairperson, Dr. Calypso.
I would now like to introduce the panelists. We have Dr. Urvashi Singh, who is the Deputy Director General, Central TB Division, Ministry of Health and Family Welfare. She's a clinical microbiologist by training, and has research interest in an array of topics related to tuberculosis. She has over 50 research-funded studies, 5 patents, and 150 peer-reviewed publications, and also she is on several expert committees related to TB. Welcome, ma'am. The next panelist is Shri Sampath Kumar, Principal Secretary, Health and Family Welfare, State of Meghalaya. He has a diverse interest in health and development sectors, and including the gender empowerment across Assam, Meghalaya, and Uttar Pradesh. Earlier, he held the position of Deputy Commissioner and District Magistrate in the state government of Meghalaya. He has steered a number of innovative policies in Meghalaya, including the gender-focused health policies, mental health and social care policies, etc. He has been a founding member in the Rajiv Gandhi Mahila Vikas Pariyojana, impacting over 60 million women and economically empowering 20 million. Welcome, sir. The next panelist is Dr. Rajan Kobragade. He's a clinician bureaucrat and is the Principal Secretary, Health and Family Welfare, Government of Kerala. Prior to this, he served as Additional Chief Secretary, Health and Family Welfare, and he also holds the additional charge as Cultural Affairs Department. Mr. Arvind Manikasagam, he is the IS officer and is the Managing Director of the Tamil Nadu Medical Service Corporation Limited. Earlier, he was the District Collector at Kanyakumari. Welcome, sir. The last panelist is Dr. Andres Pichon Rivera. He is the Managing Director of Institute of Clinical and Health Effectiveness in Argentina. He is a clinician researcher with an outstanding career in public health and health technology evaluation. He has a master's degree in clinical epidemiology from Harvard University and has also been trained in economic evaluations in the United Kingdom. In addition, he is a professor of public health at the UBA Faculty of Medicine and has held vice president roles in international technology evaluation networks. We extend a very warm welcome to the panelists.
This session will address the importance of health technology assessment in making healthcare more affordable and more accessible in India. The session will also highlight the importance of HTA in providing systematic evaluations of health technologies, including the public health programs, and to help policymakers to make informed decisions based on clinical effectiveness, cost effectiveness, and equity. I request my co-moderator to highlight a few highlights of HTA successes in India.
Yeah, thank you, Madhur. To set the stage for this discussion, we would reflect on one of the success stories of HTA in India. And as you all have heard, the success of the point-of-care test for sickle cell anemia detection. So way back in 2022, when there was a political commitment for eliminating sickle cell disease, there was a reflection on considering point-of-care tests for large mass-scale screening of vulnerable populations. And at that time, these point-of-care tests were procured at rupees 350, basically imported point-of-care kits. And an HTA analysis was recommended, which suggested that at 350, it is not cost-effective. It would be cost-effective if the price is reduced to less than rupees 100. And a directive was sent to all the states from the ministry. And meanwhile, there was a ecosystem created, and a lot of indigenous companies also started manufacturing these kits, which were validated by ICMR, and the states could procure these kits at less than rupees 100. So it was a big cost saving. And very recently, there is a directive that 2 vendors have been identified, and these kit costs have now reduced to less than rupees 30. So you can see drastic cost saving for the government, and this has been a process that everyone went through with lot of collaborative effort. So setting this stage, I now invite Dr. Rajiv Bahl sir to deliver the keynote address reflecting on his vision for strengthening affordable healthcare in India. Over to you, sir.
Since I've already spoken in the morning, I won't take too long and would like to basically summarize towards the end. I'd like to hear the co-panelists who are here and who will tell us about the case studies. Except one thing to say, that we see HTA as a support largely to the states, because as was said in the morning, health is a state subject in India, and the procurements are largely made by the states, even the ones in National Health Mission. Essentially, all the technologies are for the states to procure, to have, and it is for us to help. HTA, we see it as a help to the states in India, for you to be able to procure those technologies that you can stand behind. You have evidence that not only are they effective, but they are also cost effective. And otherwise, it is more like whoever reaches people with saying that innovators would, and it also takes away the burden from the innovators. Otherwise, an innovator who has developed a technology and has got the approval of the regulatory approval from the drugs controller, the CDSCO, after that they have to then start this tirade of marketing and go to every state, go to every secretary, ask about this, I have this great product. Then the question is, how good is it? How is it comparable with the ones that we already have or we don't have? Is it really worth buying at the price that is being offered? So we see that all being answered by the HTA assessment. And this is our goal, that all the technologies, starting with the newer health technologies for sure, that we are able to give that kind of evidence and the advice and the backing to the states to make those procurement decisions and at the prices that are cost effective for us in India. So that being the goal, the major goal, I would like to listen to the states in India, also try to understand the perspectives from Argentina and etc. before we can come at the closing. So thank you, and all ears. Thanks.
Thank you very much, sir. Moving ahead, I would like to invite the co-chairperson of the session, Dr. Calypso, for her keynote address on global case studies, HTA's success in achieving affordable healthcare. Over to you, Dr. Calypso.
Can I? Okay. Yes, thank you very much. It's an incredible honor and a privilege to be here. Thank you very much for having me. I remember 15 years ago, invited by then Dr. Sundararaman, NHSRC, we had one of the earlier lectures on health technology assessment in a small amphitheater. Perhaps some of you were there then. About 10 or 15 students had come. And the journey has progressed, and now the theme for my talk is global case studies and learning from overseas. And yet I think the question should be really, what can the world learn from India? It's absolutely amazing what you have achieved. Many congratulations. So about 10 years ago, the World Health Assembly voted a health intervention technology assessment in support of UHC. At the time, I worked for the National Health Service in the UK, an organization which carried out nationally health technology assessments, and we came to Geneva with the chairman at the time, who basically addressed the assembly and said that every pound can only be spent once. I think the Honorable Minister said the same thing earlier. And if it is spent unwisely, then we harm other people whose care will be adversely affected. So this whole process of evidence-informed priority setting is what HTA is all about. And this resolution was indeed a very important milestone globally for introducing HTA as a means of setting priorities for health. HTA is the systematic evaluation of the properties and effects of a health technology. And it looks at direct and intended effects, but also indirect and unintended consequences. And it's about informing decision makers regarding health technologies. And by health technologies, as we've seen throughout this morning, this is not just about a drug, but it can be a test, it can be a whole program of work, a preventative intervention, or a rehabilitation intervention. So it's a very wide definition of technology. Starting with defining the decision, the question, the analysis, followed by the appraisal, the interpretation of the evidence, and then the decision-making process, which is critically important, followed by implementation. And all of this happening in the context of a learning health system. As we heard this morning, HTA needs to be part of the broader ecosystem. And indeed, when we talk about health technology assessment, you can see the circle in the middle of the benefits. It sits right at the heart of the ecosystem in terms of health financing. So it's about raising revenue to finance those benefits, but then it's about the implementation of those benefits as well in a way that it's efficient, equitable, and transparent. And the benefits then of high quality get provided to the population. So priority setting, HTA is very important, but it becomes all the more important when it actually informs purchasing decisions and it informs quality improvement guidelines. And I think this is what the Indian experience has showed us, that you've managed over the years truly to integrate HTA in the decision-making ecosystem and to make it matter, to make sure it has teeth. So it's not just an academic exercise, it's not just about the analysis, it's about informing policy and really improving the quality and affordability of care at the front line. This is an example from the National Health Service. You can see at the bottom right, NICE, the institute I used to work for, the HTA and Guidelines Institute, responsible for looking at health technology assessment, introducing new technologies in the National Health Service. But what really matters, and I think the UK even now, things are not as joined up as they could be, is linking this to the way providers are paid and the way also the center pot divides resources to the regions. So here you see we have an allocation, the NHS has an allocation formula which effectively determines how much money goes to primary healthcare centers, how much money goes to tertiary hospitals, region by region. And this needs to be very much linked into what is in the package or what recommendations NICE makes that the system ought to adopt. And what also matters then when we move downstream is that the way providers are paid, hospitals, primary healthcare physicians, this is consistent with the benefits that the population is entitled to have access to. So closing that loop is incredibly important, and I think this is what PMJY, integrating, endorsing HTA has achieved, and that's why I think this is an important lesson also for other countries. Now, I was asked to talk about examples from around the world, but this is a very important Made in India example. India's cancer grid, which managed through pooled procurement, informed by health technology assessment, really to bring prices down. And I can tell you this is an experience that's been widely shared globally and very much admired and emulated. So this is a summary of the experience so far, 40 drugs, cancer drugs, with a significant reduction in prices. You can see savings ranging by drug from 23 to 99%. And including generic drugs, not just innovators and patented drugs. And so this importance of group negotiation, pool procurement for high-value medicines is really, really critical, especially in times of scarcity. And I think what India has achieved through the cancer grid is really commendable and very important. Another example is what our Thai colleagues have been doing. Thailand is very much a front runner when it comes to health technology assessment, having established HITAP, its HTA agency, several years ago. And I know HITAP is working closely with India, has been, and hopefully you'll hear from the leaders, Dr. Yot, later today. So some examples. One is the HPV vaccine, where again, they've managed a reduction in price, but also rigid intraocular lenses, where again, they've achieved significant savings and therefore increased the availability of the technology for their population. An interesting paper is the one, the bottom, which has been published, which looks at the experience of this agency, the past and its future. And I think it's worth, if you have time to look at it, one of the things that's emphasized is the importance of HITAP also continuing to work internationally. And again, as somebody now working for the World Health Organization out of HQ, I urge you to share your experiences with other countries that are very much in need of this kind of institution and decision-making process. Another example of HTA, where again I had the privilege to work with, is in China. China introduced the national volume-based procurement policy. They've been looking at a number of drugs, more than 270 innovative drugs, including drugs for rare diseases. HTA informed price negotiations and decreased drug prices and reduced in reimbursement of a very large pot of drugs, including innovative drugs, with significant savings, as you can see. This is something that's really important for China. China has recently merged all its health insurance schemes, creating really a very large health insurance scheme, which uses HTA both to identify drugs, but also to look at the appropriate price point at which it negotiates pooled procurement, together with quality guarantees and supply guarantees for its providers. And this is indeed a very big endeavor, and you can see the process they follow. This two-step process. The first step, there's a negotiation, and if the negotiation doesn't bear fruit, the second step kicks in, which is a more elaborate health technology assessment process. I was in China last year, and I was very much impressed at what they have achieved, a very rigorous methodologically process, and indeed access to the latest cancer drugs, which oftentimes are not available to those in the UK nowadays. So very much a very impressive process. I'd have to speak a bit about NICE and the UK. Things have changed since I worked there. Things have become a little bit more complex. One of the things I think that's been an improvement is now NICE is working hand in hand with the payer, NHS England, to explicitly to account for the budget constraint. And you can see on the right-hand side the whole continuum, starting from horizon scanning, priority setting, pre-launch discussions, the appraisal, and then the adoption. And in this process, there's a number of options that NICE has, working with NHS England. And you can see at the bottom, it can perhaps not recommend the product, that's in red. It could recommend it. And the yellow bit is quite important, and that's where the complexity comes in. It could say, well, maybe. And that maybe translates into different access schemes which allow further evaluation and further negotiation of the price with the manufacturers. And I'll give you an example. This is a drug for CML, and you can see over the years, it took about 4 or 5 years, it was first appraised, it was found not to be cost effective, it was not recommended, but it was included in a specialized fund that existed at the time, the Cancer Drugs Fund. Then it was reevaluated when the Cancer Drugs Fund effectively was revamped, and it remained cost ineffective, and so it was due to be withdrawn from the fund. At that point, the company came forward with yet another offer for a better price, which was confidential, which led NICE to recommend the drug for all 3 indications. And you can see when this discount was agreed and the drug was recommended, you see the pickup in volume, which shows us that the drug is now available to a lot more people in need at a lower price. That's good value for the National Health Service. The EU has, over the years, been promoting health technology assessment in a rather voluntary fashion. What's changed is that now, as of January this year, HTA has become, or elements of it, the clinical assessment, have become mandatory for member states. As WHO, working with our regional country offices, we're supporting my home country, Greece, to align with this EU directive. There's a series of workshops and capacity building efforts to make sure Greece is up to speed, and many other EU member states are in this process now as the whole of the European community is gearing up to adopt and roll out HTA. And they stand to benefit, of course, because Greece is a small country, 10 million, benefit from the economies of scale and scope of working with other member states. The economies, of course, that India has plenty given your size and the size of your market, your internal market, which is incredibly important. But here is an opportunity also to engage with the EU in this process of rolling out HTA. And again, I believe the European Commission has a lot to learn from the experience of India, the way you work with states, as the Honorable Head of the ICMR just described. How do you contextualize? How do you make the recommendations relevant and fit for purpose, country by country in the case of Europe, or state by state in the case of India? Now, we are also working, since I arrived, we've started collaborating proactively with our colleagues on global traditional medicines. And we believe that there's a very important role for HTA in the context of traditional medicines. We've started with a protocol to assess a lower limb filarial lymphedema. And in parallel, we're reviewing the methods. The methodologies of HTA need to be reviewed and perhaps revised to accommodate the particularities of traditional medicine. We're very proud to be launching this partnership, and we hope we can scale it as we move forward. Now, I'm coming to an end. I just wanted to say a few more things. First of all, how do you know HTA is working? And already we heard a lot of those elements from speakers in the morning, which very much emphasized the way HTA is actually having an impact. So this is from a recent study that identified 6 mechanisms of impact. The studies need to be conducted effectively, and therein comes the rigor that we heard from Dr. Vinod Kumar in the morning, methodological rigor, incredibly important. Secondly, the use of HTA in agenda setting and policy formulation. So the institutionalization element, and again, Dr. Vinod Kumar mentioned that HTA India is an integral part of the ecosystem. It's an office, a standalone office, and that's extremely important, the legitimacy that comes with a very strong institution. Then effective engagement and external communications. I think that's incredibly important. We've seen some fantastic videos, fantastic material. The people, the stakeholders, the companies, the users of the technologies need to be on board and understand what this is about. Institutional reputation, a negotiating tool for prices, and we've talked quite a bit about that, and then, of course, policy change. And I think HTA India has all of these ingredients, which is what I think makes it so successful. So part of the ecosystem, not just about technologies, but also informing guidelines, informing quality standards. We haven't talked a lot about quality and how we measure quality and how we course correct and we make sure that products are not just made available, but are used in the context of clinical pathways in the correct way, in a way that improves the quality of the service and health outcomes. So part of the mix, part of the ecosystem. We at WHO have been fortunate to be working with a number of countries on HTA institutionalization, and I've offered some examples. And I do think we can serve as a platform on the leadership of the WR here and the WHO country office and the government of India to share the Indian experience with others. India has an end-to-end solution all the way from R&D and early discovery and innovation to regulation, to commercialization, to appropriate pricing, and then to uptake into the market. And this is what countries need right now. Some resources, I hope we can make these slides available. You can find a lot of resources. My team is driving HTA process centrally, and a number of things that we endeavor to update this year, including guidance on costing and our costing database, our institutionalization guide, and then a brand new chapter. I was reviewing it as I was flying over. How can we take into account health economics and cost effectiveness analysis in our guidelines? Because there's no point having our fellow clinical professionals developing guidelines that don't consider cost effectiveness, and then on the other hand, to have interventions being assessed for their cost effectiveness. The two need to come together. I'll leave you with some perhaps less good news. The world is going through what is perhaps the perfect storm, especially countries in sub-Saharan Africa, other parts of the world, very much in debt. Last year, the world's 75 poorest countries will have spent 7.5% of their combined GDP on servicing their debt. That's more than they spend on education, health, and infrastructure all put together. So huge scarcity of resources, which I think makes HTA all the more important. When resources are scarce, identifying good value for money is all the more important. So earlier this year, our executive board considered and recommended to the World Health Assembly a new resolution, more than 15 years since the last health financing resolution. I showed you the HTA resolution, 10-year-old resolution now, on strengthening health financing globally. This resolution has been co-sponsored by 20+ member states, put forward by Nigeria. And you can see explicit references to health technology assessment, inclusive and transparent processes supported by HTA to inform budget and health financing reforms. This is the important thing, the crux of it, HTA as part of the ecosystem. And purchasing of priority benefits packages, again, with a focus on leaving no one behind, the equity aspect. So we're very much keen to work with member states to drive this forward after the WHA. There is a wonderful issue in BMJ, evidence-based medicine, special issue on HTA, coordinated by CGD, our colleague Abba, and it's a really wonderful collation of Indian experiences made available. We will make sure it's shared widely so the world can find out what you're achieving here and how it can learn from you, because this is a time of crisis that really requires this kind of process moving forward. So with this, I will leave you. I think India has shown that when it prioritizes something, it acts on it. This is an example, a very good example of how India's action is changing practice for India and hopefully for the world. Thank you very much.
Thank you very much, Dr. Calypso, for highlighting, the key best practices and the case studies from India, Thailand, China, and across various domains of applications of HTA and how WHO is engaging with different countries and also engaging in areas such as traditional medicine and complementary medicine. Thanks also for sharing the information about the World Health Assembly resolution in 2025, which is going to be coming up in the WHA 2025. Thank you very much for your keynote address.
Thank you, Madhur. I now invite our first panelist, Dr. Urvashi Singh, to share her reflections on the role of HTA in advancing affordable healthcare in TB. You have a presentation.
So good afternoon all. I must thank Dr. Behel sir for having me here. The Department of Health Research, thanks to all of you for, I would like to share how the Department of Health Research and ICMR has actually helped us shape the National TB Elimination Program in the country. I have a few slides, but the points that I brought in have more or less been covered by the speakers. So the role of HTA, how UK, Canada, Australia, Germany led the way, and how in India we have, we have come up with the health technology assessment in India, thanks to DHR, thanks to Dr. Soumya, Dr. Balram, who was who followed in her shoes, and of course Dr. Behel now. HTA for TB, if I may just focus on TB, has actually led us in our strides, and I like to use the word strides because we are making major strides now, because with the TB elimination plan, and the TB notification numbers that our country contributes, we really need to make big strides. So let me start by, of course, everybody has talked about the Ayushman Bharat and the other programs where ISHTA has been contributing. So for TB, what we have initiated under the program is a major screening drive, which has been launched as a campaign and which we expect to continue as a strategy for the program going forward. And let me tell you, the evidence which shaped our campaign came from studies done by ICMR, the prevalence survey, which was led by ICMR along with the National TB program, actually showed us the vulnerable population is more likely to get TB, the smokers, alcoholics, diabetics, HIV, past TB, household contacts, those with low BMI. All this was brought out by the National Prevalence Survey by the ICMR with the Central TB Division, National TB Program. And what we have now focused is to go door to door, find the vulnerable population and screen them using handheld X-rays. Now this is where the role of HTA has actually supported us in a big way. ICMR brought out, along with IPR, a new AI tool, which has been recommended to us after HTA approved it in October 2023. This recommendation came to the program, and program subsequently implemented the AI tool in a few sites. The data that came in was so useful to do further validation, and here we are with a recommendation from ICMR and DHR for an indigenous AI tool that supports us to identify patients in the field, and we've rolled it out, like I said. Few states have been able to use this as of now, and we now plan to cover the whole country. In addition, and HTA for other AI tools was also offered by DHR, where again, some of these AI tools are being used for screening, so that at the ground level, when we're going door to door, the X-ray report is immediately concluded and further tested by a confirmatory test, a nucleic acid amplification test, where again, ICMR's contribution has been immense, starting from the year 2014, when the first TrueNat studies were initiated under the leadership of the then DG and Secretary DHR, Dr. Katoch, followed by Dr. Soumya, who continued the same effort. And today, the network under the program, which is so vast, we have more than 8,500 NAT systems, which again, no other country can boast of. And we are putting NAT technology to the maximum use. So the TrueNat was followed by recommendation of PathoDetect, and today we saw the launch of UL technology. The TrueNat and PathoDetect, of course, are strengthening even the last mile. TrueNats are poised to serve at the PHCs, where battery-operated system can actually be run even when, if at all, the electricity supplies are not there. And we're going from, we're actually strengthening our periphery. The PathoDetect system can pick up, several samples can be done at the same time, can give us resistance to rifampicin INH. Having said so much for diagnostics, I must talk briefly about the treatment, where what we are ensuring for now is NAT testing. Let me complete the diagnostic bit. The NAT testing, we are encouraging our state level, our ASHA workers, our technicians at the PHC and the Ayushman Arogya Mandir level to offer NAT as the universal DST option to all our patients. And let me share with you, so when we started this campaign early December, 7th of December, the launch was there by the Honorable Health Minister, sir, and we have been able to actually enhance the usage of NAT countrywide to more than 70%. So earlier it was, it was at a lower percentage, and the microscopy was used more, but we are quickly progressing to reach 100% coverage of all our patients. So I probably didn't mention earlier, but the vulnerable population, what the prevalence survey showed us was the asymptomatic vulnerables also could be carrying the disease, which we classically call as subclinical TB, and where the X-ray technology, the AI tool, comes in handy to us. Moving on to the role of HTA for our treatment initiatives under the program. So let me compliment and not lose any words when I say ICMR leads the way for program. So the BPAL regimen, when it came in, the ICMR led the study at NIRT Chennai to show the effectiveness of the BPAL regimen. There was modified dosage which was tested, and this was followed by a big support from DHR to do the HTA. In fact, it's only after the in-country evidence and the HTA approval and recommendation did we take it under the program. And last year, we have been able to roll it out across the country. We will soon be able to cover all our MDR-TB patients with a BPAL regimen where the efficacy is more than 90%, and we hope to achieve that efficacy so that we do not lose out on any of our DR-TB patients. There have been several other initiatives where we've had the support of the ICMR and DHR. In the implementation, like I mentioned, amongst the vulnerable population, we look up to ICMR and DHR to guide us for going forward. If the HTA could actually guide us in our strategy going forward. So the strategy I mentioned earlier was the vulnerable population screening, but say in our country, if we go on to do a mass screening for TB, whether we use an X-ray, which is the recommended tool by WHO and has a sensitivity close to 94–95%, or we want to use a NAT test along with an X-ray, we look up to DHR to guide us, using the HTA technology to actually guide the strategy the program should adopt, whether we should go for mass screening. Another HTA support that I must mention here is, again, which is phenomenal and has been launched globally, is the detection method for detecting TB infection. We have traditionally used the tuberculin skin test for TB infection diagnosis, which was followed by the IGRA's, interferon gamma release assays, which were quite expensive. So we had in indigenous technology, SciTB, which included the same two antigens used by the IGRA technique, on the same principle as TST, which again was recommended to us by DHR after the HTA technology. HTA was put in place, HTA assessment was done, and we have rolled it out to our the last mile. The SciTB test is being used to test for TB infection after TB disease is ruled out, and it's based on that we are instituting the TB preventive treatment. We have the state-of-art 3 HP available in surplus all across the country. All states have adequate 3 HP and 1 HP for PL-HIV. So thus far the journey, we are thankful for all the hand-holding that DHR and ICMR has offered to the program, and going forward, we look up to you, sir, for your guidance in our bigger plans as we move forward. With this, I thank you for the patient listening, and thank you to the organizers again.
Thank you, ma'am, for highlighting all those key takeaways from the TB program that HTA has helped contribute, and expanding it to the TB elimination program in India. We now move on to the next panelist.
Yes, I have pleasure to invite the next panelist in the session. And we have Mr. M. Arvind, who is the Managing Director of Tamil Nadu Medical Services Corporation in Tamil Nadu. And as we know, the Tamil Nadu TNMSC is a role model procurement and supply chain agency since many decades in India. Thank you very much, and over to you, sir.
A very good morning to one and all. Thanks for the invitation. From Tamil Nadu, my health secretary was starting, but for some preoccupation, he is not able to attend. And the success story which we are going to present here in this conference is our experience from Tamil Nadu with respect to the public procurement through TNMSC. That's a success story which we have planned to do it here. Basically, this is a framework through which we'll be going through, which briefly why TNMSC, when was it started, what do we do, that's first we do. Then there are 3 activities we generally do in TNMSC. One is drug procurement, the other one is equipment procurement. Then we have the medical services, especially diagnostic and radiotherapy services, which we offer in TNMSC in all the government hospitals. So in each of these 3 sectors, how health technology assessment is being done, and how we take the departments along, and how we finally make the tendering process, procurement done, and how things are getting supplied. That's how I have structured the presentation. TNMSC was established in 1994, Tamil Nadu Medical Services Corporation. In 1994, about 30 years back, It started with drug procurement, then we slowly moved to equipment, and now we are into managing a few equipments, running, not managing, operationalizing and functioning the MRI and CT scan machines, even LINAC machines, and the other radiotherapy machines in the state of Tamil Nadu. So totally, the government hospitals depend upon TNMC for about 95% of the health supplies. We cater to all the primary health centers, secondary care hospitals, medical college hospitals in the state of Tamil Nadu, and basically our funding sources are from the state government of Tamil Nadu. Then all the NHM programs, the procurement is done through TNMC. Then we have the World Bank and other external projects also. The funds come, and that is also done through TNMC. So TNMC has stood through the evaluation process, and or any international agency, funding agency, are very much comfortable with the procurement process and the transparency which TNMC offers. So how we are operating is, we have about 5% from the state government's drug budget, which is used for our complete operations. This is a basic institutional mechanism within which we operate the procurement. We have a board where the health department secretary and the other user departments are members of the board. Then we have a tender committee which finalizes and approves the tender, various procurement tenders in the TNMC. Then we have a drug committee which plays a very important role in finalizing the list of drugs which will be procured by the TNMC for all the needs of the state government hospitals, be it primary health centers, secondary care hospitals, or the medical college hospitals. The drug committee plays a very important role, and that is a major health technology assessment partner in the complete scheme of things, where as TNMC MD I play a moderating role. Then Directorate of Medical Education, Directorate of Medical Services, Public Health, Family Welfare, ESI Director are all members of the drug committee. So this is the institutional mechanism for the enlisting of essential drugs and surgical sutures materials, as well as specialty drugs in the state of Tamil Nadu. Fine. Yes, how we go ahead about the drug procurement and assessment is, generally, I mean, as you all know, TNMC does only generic drug procurement for all the drugs in the state. We have two lists of drugs. One is called the essential drug list, and the other one is the specialty drug list. What we do is, every year we go for an annual tender separately for the essential drugs and separately for the specialty drugs, where all manufacturers are we have about 200-220 manufacturers who participate in the tenders. And it's a complete centralized form of procurement. We have our own warehouses in each of the districts, where the supply comes from the manufacturer to that particular district in a decentralized manner. And most of the medicines which we procure are single molecule specifications, which ensures cost effectiveness, and multiple supplies are available, as well as it's a patient-centric administration is ensured. How the list, as I already told you, the list of drugs, be it essential or special drugs, are arrived at by the drug committee. Drug committee is at the state level, but the feedback comes from the various field hospitals. Various experts keep getting us the feedback. Every year, this drug committee discusses and finalizes a list based on which the tendering process starts. So new drug technologies are assessed with respect to their efficacy and the cost efficiency, and they are compared with the already existing drugs. In case a particular new drug is to be incorporated into the list, then experts study and see the cost effectiveness with respect to the budget availability. So all these things are taken into consideration before including a drug or deleting a drug from the list. So this avoids personal preferences of any particular doctor, since the experts from the particular department come for the drug committee. The personal preferences are neutralized. For other NHM programs, specialists in state NHM team, they work out the specifications as per the requirements of the Government of India, as well as the requirements of the field, and they arrive at the specifications of the drugs. As I said already, it's an annual tender. Only once we go for a tender in the particular year. Based on that, the rates and supplies are fixed for the entire list of drugs. And as per requirement, every month we place purchase orders. Since we have TNMSC managed drug warehouse in all the districts, we are supposed to maintain about 6 months of stock in each of these districts. Based on the drawal, the demand and consumption, the stock falls, and let us say 1 or 2 months stock has left the particular warehouse in that particular month, then the next month we get the purchase orders are generated for that particular shortfall alone. So that's how we go ahead in placing purchase orders. We have a very computerized system called the drug distribution management system, where the complete inventory management, the issue of drugs to the institutions are all managed, are all available. So based on that, we are able to do an efficient way of placing purchase orders. Apart from that, during the tendering process, we have the drug manufacturing facility is also assessed. What we come across in when many states come and visit TNMSC during for learning how our practices, etc., is that what we do at our level is, during the tendering, if a particular vendor comes and participates for the first time, then we generally go, a team of drug inspectors goes to that particular facility and assesses the particular drug manufacturing facility, whether they follow the GMP practices, whether they have due licenses. We also look at the process, actual manufacturing facility, etc. And based on that, we take a call whether to accept or reject that particular bidder. So that has played a major role, and this happens every 3 years. Mandatorily, we do this every 3 years. That has played a very important role. It's also part of our technology assessment. And once the drugs are received in our warehouses, every batch is randomly tested. I mean, every batch, let us say it is supplied to various warehouses. One particular batch is supplied to 3 or 4 warehouses. All the warehouses sent to our headquarters, sample of that particular batch. Randomly, one is picked up and it is sent to an NABL accredited lab, which is again across the country. And the lab tests and provides us result online in the same DDMS portal. And only after quality test getting cleared, the batch is available for issue to the hospitals. So the quality of drugs in the complete TNMSC warehouse are ensured, after which only the hospitals can be issued with these drugs. And drug, as I told you before, drug storage, TNMSC manages about 32 drug warehouses in the complete state. And the management of the inventory, the 6-month stock, is to be ensured by the TNMSC. And we have this DDMS portal through which drug is distributed. One nice mechanism which we have, which has been working very well in Tamil Nadu, is that in the state, we don't determine how much quantity of a particular medicine has to be drawn by a PHC or a government hospital. What we do is we enlist only the list of drugs. And as per the budget allocated by the directorate to the particular hospital, it is converted into a passbook. So what we have is a online passbook system, which, let us say 10 lakhs is allotted to a particular hospital. It is given as a passbook to the hospital. So the hospital management, let us say PHC doctor or any CM medical officer in the GH, can keep on drawing as many drugs as per his requirement, as per his local needs, against a passbook value. So it's simply like a normal bank passbook. So what it offers is a pakka budgetary control of by the government. Whatever budget is provided to the particular hospital is under control, which is managed through the passbook system. It offers a complete flexibility to doctors to get issued as many drugs as per his requirement. But another advantage is that the restriction, he cannot go and purchase any drug from the of his own. It has to be within the listed drugs as approved by the drug committee. So these 3 advantages are there in the passbook system, which has been working very well till now. And coming to equipment procurement, equipment is a little more complex, since as you all would be aware, a lot of additional features might be available in a specific vendor, which is not available in others. So how we go about this? Technology assessment is basically done at the, depends upon the level of the institution. Primary health center, secondary care and medical colleges would be requiring different levels of technology with respect to equipments. Procurement is based on generic technical specifications that allows widest participation amongst the market standing forces. We Okay, what happens is the equipment, let us say there are two kinds of procurement generally we do for any equipment. Either it is a NHM funded project or could be an externally aided project or generally from the state budget. So in case it's from a state budget, the specifications are arrived by the Department of Medical Education, not by a particular medical college. So in that way, the experts in the Directorate of Medical Education, they take a call with respect to the requirement of specifications. In case of a World Bank project or JICA project, again we have experts from the World Bank and even coming from the private sector, which they analyze and come up with the specifications for the equipments. So user department alone doesn't determine the specification as per their requirement or as per their biases. So there again we try to neutralize the prejudices and biases. Again, after the specifications are received from the department, we do an internal analysis with respect to the specifications and the availability of models in the market. We also discuss with our prospective bidders. We have a team of biomedical engineers in TNMSC in the headquarters who call up and check up whether these specifications, whether their models correspond and they will be able to supply against these specifications. In case there are some issues, we try to get back to the department to alter the specifications or not. Through which we have been able to understand the wide range of features that are available, which features are the core features, which are only additional features, which if eliminated could actually be more cost effective. These come up very well through this pre-tender analysis which we do inside the TNMSC head office. After that, we start the tendering process. During tendering process also, a lot of pre-bid discussions happen. Vendors keep on asking for their own features to be included or excluded, and there's a lot of debate that happens, especially in high-end and advanced medical equipment. All these inputs are taken, we get back to the department concerned, and as well try to analyze whether a new feature requested to be added or deleted makes sense to the department as well as to the budget. So all these factors are taken into consideration before finalizing the specifications, and the corrigendum accordingly are issued. Then after which we start the technical evaluation and demonstration process. Most of the doctors request for a demonstration. Generally all equipments we have a demonstration at our own facility or in any hospital also, where doctors sometimes ask for a using of the equipment, putting it to use for a patient and getting it tested, by which certain features which are just a delta better than the other things can also be analyzed by doctors. So this has actually improved HTA in a long way. So the procurement of equipment depends on the end use requirement. We have to see whether the infrastructure is available at the hospital or not, whether the required specialists are there to operate a particular equipment or not in the long run, not just for the immediate use. Again, it also depends upon whether equipment can be procured, depends upon whether...
Sorry, you'll have to wind up in the next 1 minute or so.
Yes, ma'am.
Thank you.
Based on the load that is in the particular hospital. Again, we generally go for a 3 years warranty and 7 years maintenance contract. So the complete life of the machine is taken care, and the supplier, whoever is who supplies to us the particular equipment, is in contact with TNMSC for the entire life of the period. Again, these are some cost benefit analysis based on which we have we keep doing our procurement. Lack of time. One of the major things which we have learned a lot is through the external funded projects. With lot of interaction with JICA and World Bank, what happens is we get to fine-tune our procurement process, as well as come to learn about the advanced technologies available in the other hospitals at the world level, and incorporate accordingly within our state. So these are the CT and MRI scans machines which TNMSC operates on a daily basis in all the government hospitals. And these are LINAC machines which we are operating. Currently we have about 1/3 the CT scan machines, MRI we have about 43. Again, radiotherapy, LINAC we have about 10, brachytherapy units about 7, telecobalt units about 11. See, what has happened because of this intervention in radiotherapy and CT MRI scan centers in the state is that the rate at which private is doing the scanning or radiation has come down a lot. We offer our service at 500 rupees per CT scan. So that's the rate at which we are offering. So this has played a big role in the private market also. So, and all these scan centers are available in all the medical colleges. CT scan machines are available even in the secondary care, sub-district hospitals also. So this has played a very important role in the market. I think with that, I close. Thank you.
Thank you, Mr. Arvind, for highlighting the insights about the TNMSC model and how important a role in Tamil Nadu the entire model has been playing. Thank you very much.
I now invite Dr. Rajan Khobragade to share his insights on leveraging HTA for affordable healthcare, challenges and opportunities.
Good afternoon, everybody. I was a bit relaxed because during the introduction, the sequence was something different. So I was telling Sampath, it is your turn. But now our moderator asked me to present. I will also change the way we are presenting the importance of HTA. I will go to the last slide usually presented to give some kind of a suggestion at the national level and also at the state level. That I will cover first. Sir, usually at the state level, we are a little bit apprehensive to go for the HTA because there is always apprehension that if we do HTA and if it gives the insight which tells us your programs are, not delivering as per the expectation, then everybody feels that the questions will be asked and then we will have to do a lot of explanation. So there are two buckets. The way we look at it, there are two buckets. One is ongoing programs and what you do regarding these ongoing programs. And second, whatever the new technology and technology-led programmatic proposals which come to the state level and at the national level, we need to look at both the things. Because Dr. Calypso has very rightly, even at the global level, there is a resource crunch. If that is the scenario, it will percolate down at every level. And at grassroots level, it will be more intense. So we will have to take a look at both these things. So while doing this, I feel that HTA is giving a lot of input, but at the same time, because I'm going to tell some of the example, it should cover more areas looking at, after doing the sensitivity analysis, which are the factors which are going to get affected, and therefore your programmatic output may be costly over a period of time. That should definitely, cover. So anticipating and mitigating unintended consequences, that area also need to be covered. Perhaps in some of the HTA it is getting covered, but I would request that we need to have some thinking. Because the yardstick what we use, usually the national GDP, and if it is less than that, then we say that it is cost effective. Whether that is true for each and every intervention, that need to be looked into, or programmatic and also the geographic specific, what is the contextualization, and based on that we can come out with this cost optimization indicator. Second thing is, it need not be a one-time effort, because if I am doing a program HTA and it gives me all feedback and I'll continue that program. But because of the technology are advancing so fast, there is a forced obsolescence, and if the newer technology is cost effective, that should be adopted simultaneously, concurrently. So we feel that HTA should not be a one-time affair by the practitioner and also the policy maker, policy initiator, but we will have to do it at the intervals when the newer technologies are coming into picture. Third specific thing, as our Honorable Union Minister has already said in the morning, that sickle cell anemia diagnostic test from 300, we have brought it down to 30 rupees or even less than that. We have also done the similar thing for hepatitis C. In HIV program, when we were struggling with the hepatitis C treatment, it was in lakhs, but because of the national program, it has come down to less than 30,000. I think Dr. Parmesh is somewhere here, Director TMH. Cancer Care Grid has done a fantastic thing in our country, and because of that, there is a cost optimization for both equipments and the drugs. With a very open-ended tender condition, even the non-member, if they are giving the order, it has to be given at the same cost, which is something fantastic, and that is my colleague from Tamil Nadu as just now mentioned. I am having a two specific requests at a national level. They should take a look at all hemoglobinopathies, especially in hemophilia factors. If we have to do something by aggregation and also the discussion with the providers, I think we will be definitely bringing down the cost of this thing, because otherwise our patients are really under huge duress and every state government is under enormous pressure to ensure the continuity of this treatment. Second is rare diseases. Rare diseases, we do acknowledge that it requires a lot of input from the innovative molecule, the providers. But at the same time, instead of doing it at a state level, in a disaggregated way, numbers are very less and the costs are humongous. In fact, one injection costs more than 1 crore of rupees. Such kind of a thing, in fact, there is a challenges in terms of a competing demand, what you do. Because you need to do a safe water supply scheme in a rural area. At the same time, in fact, the 1,000 times costly drug you need to provide to only one single patient. Some of the drugs we will have to supply them lifelong. So that is one of the area. We are the largest market in the world. Definitely, Government of India, Department of Pharmaceutical, my colleague Amit is, I think, perhaps coming in the afternoon. He was there in the morning. Also, Health Secretary, ICMR, and the Commissioner, Patent and Trademark. We have to do something related to this. Otherwise, this is a totally untouched area. Only in a minuscule way, state government is doing. In Kerala, we are doing in a little bit, better way. But my sincere request, sir, these are some of the things which we can take it up at a national level and we will coordinate. Now, with respect to ISHTA, we are having a Shri Chitra Tirunal Institute of Medical Science and Technology, and Dr. Biju Semun and his team, they are our partners. The way we do health technology, the way we do any health program in the state, we build partnership. In case of any of our other indicators also, we will have a excellent, we are already having a very good partnership with our key stakeholder. So they are always helping us. So I will tell 3 programs very quickly, which we have implemented. And as I said, there are 2 buckets. One is an ongoing program and second is a newer program. So ongoing program, we have launched this diabetic retinopathy program, which is what we have done is non-mydriatic camera fundus photograph what we have taken. And those fundus photographs have come to our RI, Regional Institute of Ophthalmology, to diagnose whether that patient is having diabetic retinopathy. Now, what we tried to do is, we implemented it at a family health center level. That is our PHC nomenclature, what we use. We have transformed our PHC into, afternoon OP. There are 3 doctors, 4 nurses, also 2 pharmacists, and 2 lab techs. So this FHC scenario, we are doing NCD, fixed day, fixed time clinics, and this diabetic retinopathy screening is happening. Now, after doing the health technology assessment, it was informed to us that we need to expand the services to make it more cost effective. And based on this input, then we have, done the further expansion. After doing HTA, it clearly gave us ISER, which is a minus 717. So there is a cost saving because, the latter date treatment cost is also getting avoided. Early diagnosis is a better treatment output. And we have scaled it. And our cost for the scale up is around 16 crore. So our government had taken a conscious decision and we are going ahead with this by adding some of the other conditions. So we have identified, in fact, this is some of the data which will clearly reflect that we are going in a right direction. But the point here I would like to mention that the sensitivity, if we see that what is the uptake per camera what we have now given in the periphery, whether we need to do horizontal expansion or whether we will have to have another innovative approach to have some kind of a mobile unit so that the idle capacity can be reduced and the coverage can be increased. Now this will come if we concurrently do another assessment, because first assessment has given us a guidance and we have gone ahead. So this is one of the important point. Now second program is a Ridhyam program. Ridhyam program deals with the congenital heart diseases and operation on a 1 day or 2 day old babies also. So what was happening if we see this graph on the right corner, our infant mortality rate was all for more than 10 years in a double digit. Then there was a detailed analysis done that what are the causes of the death of infant. And it was realized that the majority of babies are dying because of congenital heart disease. And therefore, if you see in 2017, this conceptualization was done, and this intervention through Rudyam program was done to do an operation in the center of excellence who are providing this cardiac care, including the 2 private hospitals, not only government hospital, but even private hospital were empaneled. And on a unit cost basis, all these operations are done. If you see, on an average, there are around 2,000 operations happening. And because of that, now our IMR is in a single digit. Now the challenge before us is that when our IMR is 6, to bring it down from 6 to 4 or 5 to 4, what are the other causes? Other causes is again a congenital disease. So if that is the case, then we will have to do a ISHTA, that whether we will go for a efficacious prenatal diagnosis and then have a cascading kind of a testing and do a huge counseling effort, marriage counseling, etc., also family counseling, and thereby we will be able to tackle. So again here it starkly comes out, here also if our prenatal diagnosis, other diagnostic interventions are coming forward, then we will have to shift our strategy. Because then with the counseling itself, we will reduce this burden of, the serious diseases. Third intervention what we have done is for the COPD, that is our SWAS program, and it is for improving chronic respiratory disease cares at the, again, we do all these things at a FHC level. So we are having a fixed day, fixed time clinics there, and we conduct all spirometry and other tests, and based on that, our identification, early diagnosis has improved drastically, and also the treatment. We have done the ISHTA, and ISHTA has given us a clear indication that ICER is around 24,882, and the budget impact which comes around 8.8 crore, and therefore we should continue, and based on this we are doing. But having said this, there are certain indications which ISHTA is giving it to us, that if we go to the first diabetic retinopathy intervention, what is the real world validation? In fact, that we need to see, because only from the pilot and replicated, we will have to have a long-term and a broader rollout, then we have to see. Then device utilization, like I said, if there is idle capacity after doing horizontal expansion, the cost is going to go up. So therefore, we have to constantly see that what is the service uptake, how we will improve that, based on that we need to do. And of course, adaptability of the evolving technology. If we take a look at Riddham case, I have already mentioned that our prenatal diagnostic is improving drastically. In fact, it is very fast, it is improving. So therefore, we have to have a concurrent analysis get going, which will give us a lead. If we take a look at SWAS, we have to see that what is the adherence, because based on the assumption, if we calculate, our projected quality will be always, positive. But we will have to really do the further assessment. What is the treatment adherence, and what is the severity of disease among all these various patients. So these are some of the things. And the last slide, what I wanted to mention to Bahl sir, that I already mentioned. So I look forward to ISHTA to, strengthen the platform at the state level. And we should have this principle, because in medical science, everything we do on the evidence based. After doing diagnosis only, we say that this is the treatment for that particular disease. So similarly, for each and every program, when we want to roll it out at a larger scale, we should say that this is a non-negotiable one thing, either prior to program, if it is a short of time, because the budgets and that announcement has to happen. But we need to inbuild that system that we will do the ISHTA, so that we will get the technical input and perfect it going forward, and use our scarce resources meaningfully for the reason for which all of us are striving. Thank you very much.
Thank you, sir. Thank you very much. And congratulations to the state for having such a wonderful collaboration with the HTA Resource Hub and your insights into all the studies and suggestions given to the HTIN. Thank you, sir.
Thank you. And we now moving ahead, I request the next speaker, Shri Sampath Kumar, the Principal Secretary, Health and Family Welfare, State of Meghalaya, to give his insights and share the role of HTA in strengthening the state health systems. Over to you, sir.
Yeah. Okay. So, good afternoon to good afternoon to all of you. In fact, I was listening to the speeches of my colleagues. In fact, a senior colleague and a junior colleague. Senior colleague is from Kerala, so and Dr. Rajan, and also Mr. Arvind from Tamil Nadu. So I'm from Meghalaya. So I think you all aware India is a union of states, and health is a subject of states. So just like I wanted to, when they were explaining, I just want to quickly give some insights. We went to Tamil Nadu, learned about a lot of things. One of the things that what we have learned is about setting up of this importance of having a very efficient drug corporation. And we started this a year ago. And in fact, we reduced our expenditure on drug procurement by 40%. And we are ensuring the drug supply to everywhere, like every hospital. In fact, one can go to the online, everyone can see in every hospital whether the EDL, what we mentioned, they are there or not, citizens can see. So something that I wanted to say, that similarly, Kerala, when we went, when Dr. Rajan was the health secretary that time too, so we learned about the importance of decentralization, why it is so important. So I just wanted to say a few things, like, and I'll start I wanted to say how actually the, Meghalaya, we have been trying to do. We're an experimental state, I would say. For the last couple of years, we have been experimenting on few things, and I would like to share some of those ideas with you. So we are using this life cycle approach, for solving complex health problems. So this is something that I wanted to share. We wanted to simplify and make it like, a very purpose-driven work. So when, the human beings, they're born or, they die. So these are the 4 stages that actually we put everyone in this space. And how actually we are intervening in each of these spaces is very important. So as like, Kerala has single-digit IMR and MMR, but we don't have. In fact, we are one of those, poor health outcomes in the country. So basically, our challenges are like still, a lot of mothers are, dying. How actually we can save those lives? Still, a lot of children are dying. How actually we can reduce that IMR? So how actually we can use? So we are using this entire life cycle approach. Just I wanted to show you this, and the early childhood development mission that I think you would be seeing. We are also putting a lot of focus on that particular period and bringing a lot of multidisciplinary action on that. So to really unleash the full potential of the child, because the 90% of the brain growth happens during that period. The research is there, but we are trying to utilize the research, how actually we can really change the systems. So this entire complex, problems identified under life cycle approach is being addressed through a state capability building model. Just I wanted to share it with you. This is actually before started this experimentation in the state. We wrote this paper, understanding how to actually address this issue systematically. And we came out with this 5-pillar framework. I think I would like to share this one with our respected secretary, sir is here, from DHR. So what we have been doing is that, to address, because the health problems, we need a multidisciplinary action. So how actually that is important? The whole state, which is, as I said, health is a state subject. We have a full responsibility to ensure that, like, we, increase the life expectancy and reduce this IMR and MMR. So we are using this interesting framework. Essentially, one, how actually we are strengthening the citizen-state relationship, because we are a state with indigenous population, 85% of the population is indigenous population. How actually we are building the trust about the health systems. And building the local leadership is so important. So that's again a lot of focus on that, how actually we are building that local leadership, the purpose to, save lives. And the third one, of course, effective use of, research and data. That's something. And addressing systemic issues. And building the political supportability to sustain this entire change that actually we are trying to build. So we started with, as I said, in the first pregnancy is such an important thing. I want to share some, we started a rescue mission. And this is something that you see, Meghalaya is a beautiful state, but it's a very difficult state. The reason is that every village works in a very autonomous way. So you need to really go and negotiate and talk to each of these communities to take any intervention, every intervention. So, and also you see, this is very interesting, so 30% of the villages are hard to reach villages, and most of the deaths occur from these villages, and a lot of transit deaths. And so again, I wanted to tell you, that all of you know, again, what the data says, what research says. You require a 30 minutes reach time to reach the nearest health facility to have a safe delivery. How can we ensure safe delivery, when you have such kind of challenges? Okay. So what we did, we came out with this entire problem-driven iterative adaptation approach, a method that we have been using. And we started actually understanding how to, instead of implementing the programs, we started actually working on how actually we can solve the problem. So when we started doing that, a lot of new things have come up. What we started doing is that, we require a lot of autonomy at a facility level, the decentralization. So what we started doing is that medical officers managing these primary health centers were actually given that autonomy to save lives. So basically there is a new additional, funding was provided to them so that they can really set up some transit homes, bring the pregnant mothers at least, 2 weeks before their expected date of delivery and ensure safe delivery. And also making sure that, they go proactively, to reach out to these communities and, build that trust that is required. And we also set up a very interesting that cross-department sector teams. We have this one, but we try to make each one giving a role and, and ensuring that everyone plays that role. It's it's not only the medical officer who is important, it's also that, CDPO who actually manages the nutrition program of the state, and also there is a lot of this community mobilization that happens through the rural development department, where the self-help groups and and also involving that entire district administration. So this is something that we gave that kind of as a team how actually they can solve the problems, and this and also we used a very real-time data, like a mother, application. Now in the state, we can actually track each and every high-risk pregnant mother, and also we can track every high-risk pregnant mothers. And using this entire building that local leadership, and we could able to see that, we could able to address that supply side issues in terms of providing the services more effectively. At the same time, we also realized that demand side also we need to work on. So we have come out with a concept of elected health councils. So village health councils, and they are again, this is the way actually they are structured. I think you would like to see the structure. We have integrated this entire self-help group network into the, there is a 3-tier structure is there, which is built across the country in, today. And that structure we brought into the health, thing with the traditional institutions. So this is something that actually, resulted, in the kind of a results that what we have seen, a significant reduction in the maternal deaths and significant reduction in the infant deaths. In the last, you can see the data. So this actually, of course, I just wanted to, in fact, since it's an important health research conference, there is it's everyone's problem. There is a publication. I think maybe someone like to scan. You can scan it. This is published in the Annals of Global Health about the work that is happening. So, but still, despite all that, I would say still, in 2024 alone, we have 1,668 infant deaths occurred. Our goal is how actually we can reduce it to the single digits, like what Kerala has done. So this is where I think we are now looking at, I would like to say some of the experiments under HTA. In fact, Indian Institute of Public Health, Shillong, is our regional resource hub, and Dr. Sandra and her team, they are working with us. So one of the tasks is that how actually we can reduce this infant, deaths. So we came out with this, study that actually found to be very, very interesting. I think some of you must have seen in the outside. So the thiamine supplementation can actually reduce, our assessment is that 25% of the infant deaths in the state. That's the kind of an assessment that actually we have come out. So what the state, the study that has been done has been showing is that, and also it's very clearly it is coming up. It is, one is that, the dietary practices in the northeastern India, especially in Meghalaya, the way actually people consume the betel nut and consume, different fermented fish and all, they actually reduce the thiamine, there is a thiamine deficiency in the pregnant woman. So basically we have come out with a concept of how actually we can actually introduce the supplementation across the state. So that's something that, we are actually started, this research actually we are using it for ensuring that every pregnant mothers and and also they get this the supplementation. So this is one, and then second thing I also wanted to share with you how actually the ISHTA has worked in Meghalaya about providing universal health insurance, universal health coverage. We have the Meghalaya Health Insurance Scheme. It started way back in 2013, and which is perhaps one of the first state with a lot of vision to provide, universal health coverage. We started, and then again when we have gone again with using this HTA approach, how whether the money that is being spent is actually, is very effective or not. When we did this study with the IIPS Shillong, we could see that there is a disproportionate share of the budget is actually going for curative medical care services. And we also felt that how, and also there is a lot of expenditure actually is being, basically not properly classified. We could not able to really understand what, where the money is being spent. So with this, using this, we again revamped this entire Meghalaya Health Insurance Scheme. Today, actually, I would say it helped us a lot. In fact, we have increased the entire coverage. We're almost like a near universal health coverage that we are achieving. That's about 90% of the households in the state actually covered under health insurance program. We also understood the importance of providing the preventive health care. So that's where we put about another 30,000, additional coverage for every household in the state for the OPD. And in fact, this helped in improved antenatal checkups and improved, the preventive health checkups. So this is also happening in the state. So this.
Sorry, sir.
So this, yeah, I'll come. So this, I just wanted to say is that there is a tremendous, importance of research. How actually we are able to use the research for, achieving the purposes that what we wanted to achieve. And there is an institutional mechanisms are required to really provide that kind of a support to the states. I think that's where actually the Meghalaya is trying to do. In fact, we have set up a SHSRC also recently to strengthen that implementation systems. And we also have this, we have this RRH, thanks to DHR for providing that RRH through Indian Institute of Public Health, Shillong. So this institutional mechanisms are also helping us. So just one thing that I wanted to share, before leaving, you might have in the presentation, what I tried to explain is that there is a state has a, basically a lot of role to play. In fact, they have tremendous capacity. The institutions are there. In fact, we spend almost 50% of the budget on the human resources. So essentially, there is a lot of need for innovation and building the state capacity to address a lot of these complex problems. So just thank you for giving this opportunity for sharing some of our work. Thank you.
Thank you, Dr. Sampath, for sharing the state capacity building model with us, the whole life cycle approach being followed in the state, the rescue mission, and also the adoption of digital technology in the state. Thank you very much.
May I now invite Dr. Andres, Managing Director, Institute of Clinical and Health Effectiveness, Argentina, to share his experiences from Argentina. Over to you, sir.
Hello, good morning. A long morning. The good news is I am the last one, I think. Okay. So, first of all, thank for the organizers of this session. It's really a pleasure for me to be here. And, well, I came from Argentina in Latin America, and in Latin America, almost all countries have already established HTA agencies. There is a network of HTA agencies called REDETSA, with 42 agencies from 21 countries. And HTA started in Latin America more than 20 years ago, and the experiences have been diverse, with many success stories, of course, but also failures and lessons that can be useful for other regions and countries in the process of establishing HTA agencies. So I would like to take these few minutes to discuss three key considerations. One is the link between HTA and decision-making that is as important, if not more important, than HTA itself. The second one is regarding economic evidence, and the third one is regarding the role of HTA in healthcare systems. So, this is something that is happening in Latin America. For example, many agencies in Latin America have focused on the assessment component, but have neglected the link between HTA and decision-making. And as a result, many HTA agencies in Latin America, yes, they have developed very good methodological guidelines. They have produced a lot of HTA reports, very sophisticated. They have trained staff, but in some cases and in some countries, they are quite irrelevant in the decision-making process of the country. Maybe they produce HTA reports that do not fulfill decision-maker needs, or they are producing HTA reports that are not taken into account in healthcare decision-making. And this is why it's crucial to establish a strong link between HTA and decision-making. And I think that Professor Vinod Kumar Paul said this morning that HTA requires strong institutions. And I think that India, in this sense, can make really strong contribution to the Global South. In Latin America, a good example maybe is Brazil. In Brazil, there is a federal law that mandates that before making a decision, before including a new technology in the benefit package, there must be HTA information on the effectiveness and cost effectiveness. And this is an excellent way to ensure that HTA is part of the decision-making process. My second point is regarding economic evidence. Again, in Latin America, unfortunately, still many countries are making coverage decisions or benefit package inclusion decisions without knowing the cost effectiveness of the intervention. And yes, I know, of course, that conducting cost effectiveness studies is something that is complex, that we lack high-quality data in many low-middle-income countries. I know that many countries do not have a cost-effectiveness threshold, that we lack trained personnel, that conducting cost-effectiveness studies is time-consuming, but none of this should be an excuse for not considering economic evidence when making resource allocation decisions, because you know here, well, in India, you put a strong emphasis on cost effectiveness. I think that is something that is very good. But how can we negotiate if we don't know the true value of what we're purchasing? Or how can we improve health if we know the opportunity cost of our decisions? So economic evidence is crucial. And of course, I also understand that it's impossible in low and middle-income countries to conduct a full HTA with a complete economic evaluation for every decision. However, this does not mean that economic evidence should be disregarded. More and more, there are rapid methods and approaches that allow countries to at least obtain a preliminary estimate of the probability of a technology being cost-effective in the context of that particular country. And these methods are known as adaptive HTA. You are probably aware of this. And these methodologies and processes are adjusted to the availability or to the available time and data at that moment in order to provide the best possible information. And the first one here is a guideline from IDSI and the Center for Global Development on how to conduct adaptive HTA. The second one is a document that we produce in Latin America for the IDB. Also, it's a methodological guideline to apply adaptive HTA. And my last point is regarding the role of HTA. I think that maybe you know that HTAI, Health Technology Assessment International, is the scientific society of health technology assessment, and the society organizes every year an international meeting. The last meeting last year was in Seville, Spain, and the keynote speaker was the Harvard professor Rifat Atun. And he asked us if HTA can transition from being just gatekeepers, to be health system changers. And I will provide my interpretation of this question, and I will show you a brief example around infant mortality. I just choose infant mortality because it's something easy to understand and to measure. So here I am comparing the European Union on one side and Latin America and the Caribbean in the other side. So the infant mortality in the European Union is 4 deaths per 1,000 births. There are some countries with 3 or 2 deaths, but in general, the mean in the European Union is 4 per 1,000 deaths. And we can imagine that it's not exactly this, but we can assume that these deaths are due to health problems for which there are currently no effective treatments. Rare diseases, severe leukemias, genetic diseases, etc. So it makes sense in high-income countries that the industry seeks to develop new treatments, new devices, new diagnostic technologies for health problems that currently have no solution. And of course, HTA agency must evaluate these new technologies and interventions. And of course, in Latin America, we also face these same deaths caused by health conditions that currently have no effective treatment. And of course, HTA agencies must also evaluate these new drugs and interventions that are developed each year in an effort to provide solution to these unresolved health problems. Of course, also patients and doctors demand access for these new treatments. However, in Latin America, there are other 12 additional deaths per 1,000 because infant mortality in Latin America is 16 per 1,000, not 4 as in the European Union. And these additional deaths are for avoidable causes of death. Technologies to prevent these deaths have been available for years around us. So what should be the role of HTA be in these cases? Should HTA focus only on evaluating new technologies? Is that enough? So perhaps we need to question, at least in Latin America, the current emphasis of HTA on just new technologies. And I think that HTA has a lot to say, and we can help to improve healthcare system, we can help to build more efficient and effective healthcare system, and also more equitable healthcare system. So these are some of the discussions that we are going to have this year, the Health Technology Assessment International meeting, will be in Buenos Aires, in Argentina, in my home country, in June. So I really hope that you can join us and discuss these very important topics together. Thank you very much.
Thank you, Dr. Andres, for that very lucid presentation and highlighting all the initiatives taken up to institutionalize HTA in Argentina and also the challenges that you face, the role of adaptive HTA and also the role of HTA in country-specific issues, not only the ones that the developed nations have addressed. Thank you very much. We now would like to invite, with permission of the chair, Dr. Soumya Swaminathan, ma'am, to the dais to share some of her reflections on the topic that we are discussing on affordable healthcare role of HTA.
Good morning, and thank you very much for this opportunity. I will be brief because we've had an extremely interesting session. I just wanted to make 4 brief points. Firstly, after congratulating Secretary DHR and all the stakeholders, particularly the team in DHR, because I was there at the very beginning and I know that it started with just an idea. It started, of course, also with conversations that we'd had with IDSI. Calypso was involved from the very beginning. WHO as well as ISHTA in Thailand. So I think the importance of having partnerships both domestically, nationally and internationally to seed new ideas, to strengthen something that we may have as a seed but which could actually take shape, and learning from organizations like ISHTA that we thought were quite relevant for us considering they're a neighboring country in Thailand, and thinking about what the future needs are going to be. The concept of HTA actually was even in the 12th five-year plan. So even by 2012, 2013, India had started thinking about HTA, but it took a few years and it took quite a good amount of convincing, talking to stakeholders, bringing together people, having consultations with states, with others, with industry, with academia. And at that time, the capacity was limited. I think today we have 18 regional resource centers. Many of them are here doing an excellent job, but we still, for a country like India, we can't say that we have all the capacity we need. And as Professor Revere was saying, I think there are many issues, especially around the economic analysis, where I think we can also learn from each other, and a more South-South collaboration would be really very critical at this point. So capacity building is something that has to continue, and I would like to see every state in India actually having institutionalized a resource center for health technology assessment, because I think we saw excellent examples from Kerala, Meghalaya, Tamil Nadu, but the needs are huge, our states are huge, and we need many more groups working on this. We have so many good institutions across the country, both in the government sector, private NGOs, who can actually play this type of supporting role. But it's very important that the governance of this should be with government, and therefore it's really excellent that DHR ultimately was the home for this exercise, because there were a lot of options initially when this was being discussed. The second thing I would like to suggest is that we talked a lot about priority setting, and we've come a long, long way, I think. And some discussions we were having this morning, including with Secretary Pharma, the issue that came up is that there's government support for many schemes and programs. For example, the Department of Pharma now has a very big scheme for supporting innovation in the private sector through both equity as well as loans. Now, they would benefit from knowledge of what the public health needs are for this country, rather than fund a company to do some product which does not have a big demand at the moment. It would be much more efficient to focus on those health needs, and therefore the priority setting that is already being done by both MedTech Mitra as well as by the HTA teams, I think if that's made publicly available, it would drive innovation also to address those gaps where we still don't have the, at least the affordable and cost-effective technologies to be used. I also hope that we'll be focusing more and more on prevention and health promotion in addition to having devices, diagnostics and vaccines, because a lot of our health issues, actually we do need to also work on prevention. The third point is around implementation. I think the examples we've seen from states today have been leaders and have been very proactive, but quite often it comes down to one health secretary or somebody within government who's extremely motivated, understands, takes it forward and really makes it happen. Ideally, such a thing should be institutionalized so that even when people change, and people do change in these positions of leadership, you have this going forward. So I think DHR could take the lead really in networking with states, raising the awareness and getting that kind of political commitment so that HTA is very much institutionalized, and also, of course, the resource centers also will need to, and I think learning from each other. I think NHM already has that kind of platform where states learn from each other. I think HTA could also have a platform where states can learn from each other and adopt the best practices. No need to keep reinventing the wheel. And finally, I think that India is now in a very good position to lead this, as others have mentioned in the sessions this morning, to support other countries. And particularly, I think we've heard from Latin America. We know there are big gaps and needs in Africa as well as Southeast Asia. So perhaps with CRO, with WHO CRO, and with DHR, ICMR, they could really build a regional platform to begin with, or a South-South platform where we can use the concept of adaptive HTA. So that we did that during COVID. We created regulatory networks that did not all have to keep on repeating the same assessment. As long as your context is similar, you come from similar background, and your economic status is similar, I think an assessment done in one country could be taken and quickly adapted and adopted in another country. And that would speed up access. And ultimately, we're all focused on universal health coverage and getting equity and access to the appropriate health products and improving health outcomes. So with that, I just want to thank also Dr. Bahel for giving me this opportunity to share my thoughts, and I really am delighted to see the progress that's been made, and I hope that we can go from strength to strength. Thank you.
Thank you, ma'am, for the insightful thoughts and also encouraging us to do more. Thank you very much.
Thank you, ma'am. And moving ahead, we've had an extremely rich discussion, and may we now invite the chair, Dr. Rajiv Bahel and Dr. Calypso, to share their reflections and insights from what we have heard from the panelists. Thank you.
Thank you very much. I just want to say once more, many congratulations to you for what has been achieved in India, and that we as WHO are HQ under the direction of the WR here, and we are at your disposal. It would be a great honor and a privilege to work with you to share the lessons that India has learned and the innovations, methodological, institutional, and policy innovations to share with others. And I can tell you that in my experience, short at WHO, especially at this point in time, there's huge demand for support from southern nations such as India, who've gone through this process. And it would be really adding value to the lives and livelihoods of people all over the world if these lessons can be shared and learned. Thank you.
Thank you. Just that we will have to soon wind up and go for lunch and the next sessions. But this was a fantastic panel where we heard global examples from Dr. Calypso from India, Thailand, China, UK, Greece on HTA. Then we heard from one of our most important national programs, the TB program, as to how they are using health technology assessment and health technologies in general to really enhance the program in our rapid acceleration towards TB elimination, following which we heard 3 key states, Tamil Nadu, Kerala, Arvindji, Rajanji, and Sampatji from Meghalaya. So 3 states experiences very different, and then eventually Argentina, the Latin American perspective, and then Dr. Soumya's very brief suggestions. I just want to say a few things on the issue of TB. Today, the Honorable Health Minister launched the HUVEL Open Kit for TB. Now, this was a dream even 2 years ago for me, that we will have a NAT test for $1. And I had this discussion with so many people when I said, in order for us to be able to do active case finding of people, we need 3 things. We need a handheld X-ray, which is cheap. At that time, it was about 2 to 3 times the cost that it is now with the indigenous development. The second was AI, that we will be able to read the X-rays by AI, just to say they are normal or abnormal, very quickly. And the third was that we would have a very cheap $1.5 test. 100 rupees was my target, that we would have a test, not 700 rupees a test, but 100 rupees a test. And we are really proud that we have achieved all these 3 within this period of 2 years. We have a handheld X-ray that is now costing something like 12 lakh rupees, which is something like $15,000. And it can take X numbers, the digital X-ray, it can take so many X-rays. We have AI, we have more than 1 tools that can actually very predictably, nicely, with very high sensitivity, read and we have HTA on all of them, on the handheld X-ray, on the AI, and we have the NAT. And we don't only have the closed systems which cost something like 500 to 700 rupees. We also have this one, which will be closer to 100 rupees, hopefully. So this gives this kind of opportunity for something which Dr. Rajan, you were talking about, that it is not about HTA, which is one time. It is about how we are progressing. We want an ecosystem of innovation. And I also want to address what Dr. Andres said. It is not a duality for us that we have to do new technologies which are new only for rare diseases. But things like TB, things which are available, but now much lower cost. So that is the motto that which the Department of Health Research is moving towards, is to make technologies not only the newest technologies that are expensive, but also the technologies that were available, but were available for 700 rupees. Before TrueNat, they were available for 2,000 rupees. We made it from 2,000 to 700, 700 to 500 PathoDetect, and now 100 to 150. So that will change the way the programs can afford to do what they intend to do. I also think that the 3 states were fantastic. Tamil Nadu, you gave such a great example of drug procurement, equipment procurement, and the systems you follow and how you go ahead doing that is an example for us to actually write down and share with others. Calypso was asking me if we could share such examples globally with people to say, how do you maximize the resources and procure the healthcare technologies that we need? Dr. Rajan, you raised the question of rare diseases. We are seized of that issue. We want 3 things to happen. We are enhancing research investment so that we can get indigenous solutions to the same problems, but also handhold our innovators to develop those and help them with the regulatory strategy, help them with evaluation, de-risk their effort by reducing their costs, by doing the government supporting the preclinical studies, the clinical trials, the evaluation, so that then they can come to guidelines and finally to the HTA. And that process is what will lead us to this. The other point you very well made is, which is, we don't want HTA to be rigid. Whenever we do an analysis, we do an ISA, although there are both sides of the aisle people, but I tend to be on the side that says that we must be flexible. The interpretation of that ISA is not one that we have to have this cutoff and below this everything is good, above this everything is bad. That doesn't work. There is context, there is interpretation, there is who is using that technology, private sector, government procurement. How are we going to do that? There is a lot more to the interpretation than just being binary in our recommendations, and certainly we are taking very big steps towards that, as you will see in the policy. I really like the Meghalaya life cycle approach and the way you have taken local solutions like thiamine supplementation and done its HTA or the health insurance scheme. So these centers that we are building are not only the central government at DHR. We have built these centers. Currently they are only 24, Dr. Soumya said, but my target is within the next 2 years, there will be 100 centers in India. Every state will have more than one, not only one, but more than one, between 1 and 4 centers, which the state government can directly interact with, but also feel free to interact with the department, because we also have this network, because whatever we learn from one state, we want all other states to learn from that. And that is only possible if we are able to have this platform that Dr. Soumya was saying, which we are building. I also want to share with you that you made a very important point, Dr. Andres, that the HTA must be linked with decision making. And unless it is an academic exercise. And we have done everything we could from the time that Dr. Soumya set it up under Dr. Paul's leadership and the Honorable Prime Minister's leadership and their guidance, that this must be part of the ecosystem of our healthcare. And I am also very happy to share that the Honorable President of India earlier this year made health technology assessment allocation of business for DHR, which means it is now enshrined in the business of this department in the Ministry of Health, that HTA will be done and will be used. And we don't have a law for its use. I don't want anybody to feel that this is a gatekeeper, as you were saying, that we are trying to restrict somebody, some state, to do something which they want to do, even go beyond. For example, you went beyond, Dr. Rajan, usual causes of child mortality and went into congenital heart defects. Because of your context, you were already at a 10, 12 infant mortality and you wanted to go low. So all those things should be feasible to do. We see HTA as a decision-making help, as something that will help you change for the better, for making use of all the technologies, whether they are today available, whether they are less expensive and more affordable, or they are completely new technologies. So I'd like to just end with that, saying that this has been a fantastic experience to hear all of you, and we really look forward to. We are also working with all states. We have had multiple state engagement workshops with so many different states, and to see states like Uttar Pradesh. I'm not surprised that Tamil Nadu and Kerala and other such states, Karnataka and others, but Tamil Nadu, but Uttar Pradesh, Rajasthan, all the states have shown very keen interest in taking forward the use of HTA. So I really look forward to that. Thank you all very much. Thanks to our partners, WHO. Thanks, Dr. Rodrigo, for being, and Dr. Calypso for being here. all the other partners that are here and have traveled from far and wide. Thank you very much from within the country and outside. Thank you, and let's hope that we will have even better discussions as we go along. Thank you.
Thank you very much, sir, the chair and the co-chair. And I would like to also thank all the panelists for a wonderful session. And I request now Dr. Rajiv Behel to kindly give the mementos to our panelists and the co-chair. May I request Dr. Rajiv Behel to kindly give a memento to the co-chair, Dr. Calypso. Also to Dr. Rajan Khopragade, our esteemed panelist from Kerala. Also requesting to hand over the memento to Shri Sampath Kumar, Principal Secretary, State of Meghalaya. To Dr. Andres, who's the Managing Director, IECS, Argentina. And finally, to Professor Urvashi Singh, the DDG TB, Central TB Division, Ministry of Health and Family Welfare. And last but not the least, we have Mr. Arvind, who's the Managing Director, Tamil Nadu Medical Services Corporation. And I request the chair and co-chair to kindly come forward for a group photograph. Also requesting Dr. Beena to kindly hand over a memento to Dr. Rajiv Behel. Please, ma'am.
Thank you, Ji. Thank you very much. Thank you very well. Thank you. Let's quickly go to the producer.
Hall. Requesting everybody to assemble back in the conference hall. We will be starting with our session 3.
But that's not
Let me just see. Because we should call them to, oh. Can we all settle in for the next session, please? I think that was enough time to have a quick lunch.
Kavita, it's Dr. Shri Kumar Rahul is around from Punjab. I'm just speaking to Kavita. Otherwise, what we will Good afternoon, everyone. It would be great if you can all take your seats. I'm also asking Shri Kumar Rahul, Principal Secretary from Government of from Punjab, if you can join us on the dais, please.
We shall leave it to our co-chair for the entertainment when we come from the co-chair. Yes.
All right. Good afternoon, everyone. Thank you very much for being here in the hall. In the interest of time, we are going to get started. I am Sandra Albert. I am the Director of the Indian Institute of Public Health in Shillong. We are not going to read out long CVs here, so rest assured. We're going to, in fact, try the impossible. At a policy meeting, we're actually going to try and shorten the session time because I think we've run way over time. What we will also do is, not as a general rule, that we will not read any bio sketches. I think they're going to be coming up on the board up there on the LCD screen, and you could all have a quick look at each of them. We have a slight change in our program. Dr. Soumya, who was supposed to be the chair here, had to leave early, so we have now got Dr. Sangamitra Pati actually replacing, and stepping in rather, in that role of chair. Dr. Sangamitra will actually make some concluding remarks. What we're actually going to start with, I mean, we have a chair and a co-chair, and then we have, I think, now only 3 speakers. Because one of them couldn't get here in time. So we have 3 speakers, so we have enough time. Nevertheless, even though if you have time, we are going to request each speaker to just stick to maybe 5 to 6 minutes. Maybe 7, since we have 1 less speaker. That's the last, that's a maximum. And so keep your comments so that we have a little bit of time for discussions, if that is possible. Is that okay with everyone? Yeah. So as I said, our chair is going to be Dr. Sangamitra, but we have Dr. Rodrigo Offrin from the WHO, who is actually going to be the co-chair and who's actually going to give us the first keynote address. Over to you, Dr. Rodrigo.
It will not be a keynote address, because I think we have had very good inputs from the inaugural and the previous session. I think that what's important is to just summarize what this session aims at. This session highlights the importance of health technology assessment in integrating innovative technologies into the health system. So what good is an innovation if it is not used? Like your talent, if some of you can sing, what good is that if the world doesn't hear it? Countries that effectively use HTA ensure that new technologies are both cost-effective and beneficial to patient care. Health technology assessment serves as a critical bridge between innovation and access in the realm of emerging health technologies. By providing a systematic evaluation of new medical interventions, HTA ensures that innovations are not only clinically effective and safe, but also cost-effective. Most importantly, they have to be answering national and even local health problems. We also saw and learned that from the previous session that you do not invest in HTAs that have the least impact in your health indicators. So just a few questions for everyone to think about, and we're doing this fast so we can engage you to ask questions to the panel. What role do policymakers play in the integration of innovative healthcare technologies through HTA? How can real-world data and evidence be effectively utilized in HTA for emerging health technologies? How can health technology assessment be utilized to accelerate innovation in health systems versus being a gatekeeper, as we saw that question posed to us, while ensuring cost effectiveness, patient safety, and accelerate achievement for national health priorities? I think I'll end there and hand over again to the moderators so that we can hear from our panel. Thank you very much.
Thank you. That was super quick. Thank you very much, Dr. Opran. I'm actually going to hand over to my co-moderator, Dr. Somin, to say a few words and invite the rest of the panel.
Sure. Thank you. I'm Dr. Somin Sa. I'm a professor at Indian Institute of Public Health, Gandhinagar, and I head the Health Technology Assessment Hub. So as was discussed in the morning, we have done several studies, including the AI-enabled chest X-ray, which the Secretary Sir was talking today morning. And also, we have done the portable ECG facilities, which was initially introduced in Ahmedabad district of Gujarat, and based on the ISHTA results, have now been scaled up across several districts of Gujarat, as well as other states, including the 8 northeastern states, which has now rolled it as part of its public health program. So with these things, let me invite Dr. Sangamitra Pati to be the first speaker. Thank you.
I think we will start with Dr. Manoj Jhalani, because I would be summing up in the end, and having said that, since already Dr. Somin told my name, so yeah, I would hand over to Dr. Manoj Jhalani ji. So he would be speaking on how to achieve universal health coverage through strategic health technology investment. Can we show his slide?
Yep. So can someone put the slides of Dr. Jhalani while I probably introduce him? He is the Director of Health Systems Development, WHO Regional Office, Southeast Asia, New Delhi. He has been in the past served as the Joint Secretary to Government of India and later as Mission Director, National Health Mission, while holding the post of Additional Secretary and Special Secretary to the Government of India. So with this, I will hand it over to sir. Your slides should be there. Can we ask someone to put in the slides of Dr. Jhalani?
Can we have the...
Yeah. Thanks. Good afternoon, colleagues, and good afternoon, Chair, Moderator, and panelists. So my topic for the post-noon session is achieving universal health coverage through strategic health intervention and technology assessment investments. Now, just to, this is something that you must have seen so often in terms of the classical cube. You would see everyone, everywhere can receive quality health services they need across the life course without financial hardship. So you want to ensure that everyone, means the entire population, gets covered for all the services, and then the out-of-pocket spending is minimal, And we monitor the progress of UHC, which is the overarching target within the SDG 3 goal around the service coverage index, which is coverage of essential health services, and we try to capture it through tracer indicators under 4 different categories of RMNCAH, infectious diseases, non-communicable diseases, and service capacity and excess. And on the financial protection side, for financial hardship, we look at incidence of catastrophic health spending, which is about proportion of households that face more than 10% of their spending, out-of-pocket spending on health care of their annual budget, annual consumption. And you also look at impoverishing health spending. Now, the World Bank and WHO have come out with a new definition, which is likely to be accepted by the UN Statistical Commission, which is talking about proportion of population with out-of-pocket household expenditure exceeding 40% of household discretionary budget. The discretionary budget is essentially around total consumption expenditure minus the societal poverty line. So this is what will then be able to, one effective measure to capture the impoverishing health expenditures. Out-of-pocket expenditures for poor can be really significant and catastrophic, and this new indicator will capture that well. Now, so if we have to advance this, we need to move on both these fronts. Now, what we notice is globally, this is a scenario that our progress on the service coverage has been slow. It's not fast enough to reach the SDG target of 80 by 2030, and also uneven, you know. And around financial protection, the situation has only been worsening, right? From 2000 onwards, the catastrophic healthcare spending has been increasing in terms of proportion from globally, for our region in Southeast Asia, from about 12.7% to about 16.1% between 2000 to 2019. So this is an area of concern. And the WHO consultative group on equity and UHC, they proposed 3 criteria in terms of priority setting for this UHC. One is around cost effectiveness, but also around priority to the worse off and financial risk protection. So it's not just the cost effectiveness part of it, which is of course a very critical element of health technology assessments. So what we feel is that unless you advance progress on financial risk protection and providing priority to the vulnerable sections of the population, the progress towards UHC cannot be accelerated. So what has been happening on the ISHTA front from WHO globally, 2013, way back, CRO, even ahead of the global thing, came out with a resolution in 2013, and then in 2014, World Health Assembly came out with adopted a resolution around health intervention and technology assessment, giving the WHO a mandate to support countries to develop health ISHTA mechanisms. And then WHO has been endorsing this evidence-based approach. And we heard, and I'm sure, I mean, I don't need to repeat, in terms of there's a multidisciplinary process and collaboration is the key, and it's basically an evidence-based approach to support prioritization of new health technology interventions for accelerating progress on UHC. Now, we had this kind of survey in 2021 just to get insights around status of health technology assessments in our region. So what you see there, does it provide? Yeah, so this, the last one, which is around qualified human resources. So most of the countries indicated that this is a key barrier to promoting HTA. The other area was around institutionalization of HTA, and then you had lack of awareness and advocacy around the importance of HTA. So this is the basis, major barriers that were communicated by the member states in terms of why HTA is not progressing, in terms of lack of capacities and qualified human resources. Institutionalization of HTA is a challenge in many countries, and there's lack of awareness about the importance of HTA. And then in terms of what's the kind of support that they needed for HTA, most of the countries indicated that they needed higher education. So in terms of the lower one, if you see what is the support that in the order of priority that countries asked for in our region of Southeast Asia of WHO. So they asked for higher education masters, and also in terms of support for courses and seminars and workshops, etc. And incidentally, I mean, excepting DPRK, almost all countries of our region had indeed responded to the survey. So it's fairly good representation of our region. Now, in terms of HTA scope, and so I've given one example around priority listing of medical devices or essential medical medicines. So it's not limited just to one type of interventions around, say, medicines or vaccines or medical devices, but also a variety of interventions, including population-level interventions like health promotion, prevention, etc. And what does HTA consider? It includes not only the safety and clinical effectiveness aspects of it, which of course are looked after by the regulators, but also economic consideration, budget impact analysis, organizational impact, equity issues, ethical issues, feasibility consideration, then acceptability to healthcare providers and patients. Now, just from a sense of, say, for medical devices, etc., in terms of, so you'll have a priority list, WHO comes out with those priority medical devices list, and then you have the regulatory approvals, which look at the safety and quality and performance. And building on that is the health technology assessment, which looks at both the economics, clinical, legal, social, and ethical aspects there. Now, WHO in 2021 came out with this guidance, which is fairly good and relevant for countries at different levels of journey. So institutionalizing health technology assessment mechanisms. This is more of a how-to guide, not so much on why part of it, which people are convinced, but more in terms of how-to guide. So for fragile states and low-income countries with low coverage, or middle-income countries with low coverage, and high-income countries, depending on the strength of their health systems, there are recommendations. So, but countries need to have a long-term strategy for institutionalizing HTA mechanism to adapt to the increasing strength of their health system and the fiscal space available. And HTA mandate and complexity can really evolve according to their status. Now moving forward, so this is, I'm just quoting the WHO resolution, regional committee resolution in, way back in 2013, where the countries were requested for institutionalizing HTA mechanism and developing methodological and process guidelines for HTA, integrating HTA into their national policies, resource allocation and benefit package decisions, research, education, and also strong political and financial commitment, which is critical. And WHO has been, is ready and has been providing the support to the technical support to the member states to strengthen HTA mechanisms, supporting capacity building and exchange of information. And also there are a large number of networks who are being supported, including the one on Decide, Health Decision Hub, which is hosted by the WHO itself, but you also have HTA International and ISHTA and HTA Asia Link, etc. So thank you so much for your attention.
Thank you, Dr. Jalani, for taking us through a bird's eye view from the WHO's perspective on how HTA can contribute to UHCs, to also discussing about the barriers, challenges, and also way forward, and how WHO is supporting HTA for its member countries, at least in the Southeast Asian region. So moving ahead, now I have a pleasure to invite Professor Naresh Bhatnagar, Dean of Indian Institute of Technology, Delhi, to talk from an R&D perspective about what are the challenges in integration of HTA in decision making. So Professor Bhatnagar is the Dean at IIT Delhi. His area of interests are wide, from biomedical implants to biomaterial processings and a range of other things which you can see on your screen. But without any further delay, I would invite Professor Bhatnagar to deliver his talk. Thank you.
Okay, thank you very much. And it's an honor to be here, and it's on behalf of IIT Delhi, I would like to present some of the understanding and inferences which I have gathered today about HTA. We can divide the three words: health, technology, and assessment. Health, all of us understand, okay, good health, bad health, and hospitals, and medicos, and so on. So everything comes under that domain. If we talk about technology, yes, we are quite ahead in that terms. We understand what are the various engineering disciplines, how technology gets evolved from one discipline, and what are interdisciplinary technologies to come up with. Then comes the assessment. So assessment is something which is a matter of a tool or a policy where the guiding principles have to be laid down, and on that basis any technology can be assessed. Generally it happens at the back of the envelope calculations for most of the industry, how to assess what is the return on investments, and that's how they talk about in the engineering world. But here in terms of healthcare, it becomes slightly little complex. So if I just think about SWOT analysis, what are the strength, weakness, opportunities, and threats? So if on these 4 points, if I just would like to put my thoughts, I think the strength, we have the best possible doctors, number of doctors all over the country. Very highly competitive examination is there through which they come to do the studies, and they are also highly motivated. And we have now in the last 10 years um, what we have seen that because of the move by the leadership of our country, Honorable Prime Minister Narendra Modi ji, we have seen that every district is going to have a hospital as well as a medical college. That means we are going to work on the health aspects, definitely. So it's a huge strength for us. Every district will also have a dental and allied healthcare professionals. We also have the best of, let's say, engineers and scientists being produced in India. Let's say so many IITs now. Initially there were 5 IITs, now it is 23 IITs. We have Indian Institute of Science, and now there are several ISHTAs. So we are able to produce best of the talent at a very young age. The weakness is there. If I just look at the scenario, the medical education somehow lacks training of research. All the medicos do not learn by training how to do research or how to get involved in research, because their courses are so vast, anatomy, physiology, all those, then surgery, and then everything comes, and it's a 5.5 years plus another specialization, 3 years, 9 years, 10 years. They are always involved in the medical education, which becomes little taxing for them, and they have to remember everything. There is no choice. But research and innovation, which is required to get an understanding of thinking about a new technology, little bit it takes on a backseat. That is a weakness in our system, because most of the medical institutes are away from the engineering institutes, and both of them do not talk to each other because there are 2 different ministries governing the 2 education system. And we do not have universities abroad where the medical school and the engineering school are housed in the same campus, and there is a cross-pollination of each one of them. This is a weakness. And most of our engineers and scientists, if you just visualize for a moment, they don't go and get immersed in an operation theater of a hospital. Until unless somebody is sick, then only they see a hospital or the ward, otherwise they are not exposed to it. So they really don't know what is that they can do in a hospital, how they can develop something which is required, even for a shifting of a patient from one bed to another bed. Until unless they see for themselves, they will not get another idea that how we have to shift. As simple as that. So this is some weakness, but there are opportunities. We can train most of our doctors as well as engineers by educational programs. And these educational programs can be devised on the basis of policies, on the basis of thinking process of the government as well as the institutes, that we should provide them with a holistic view of health, first of all. I'm also happy to see that after COVID, thanks to COVID, that many schools have now started gaining momentum in biology sections. Before COVID, it was on the decline. Some schools which were having 4 sections of maths and biology each started declining to 1 section of biology and 6 or 8 sections of mathematics. Because everybody wanted to become an engineer, because it's a 4 years of education and then you are on the job, you can start earning, whereas medical education, it will take almost 10 years to begin with. But after COVID, we can see that there is a rising. So it's a very good sign that young kids are coming to do medical education. So these are opportunities, and we have to create such platforms, possibly by the government at the state and at the center, where a lot of R&D investments can go in, so that those platforms can bring a doctor and an engineer on the same platform to think about a problem and solve it. And that's where the new technologies will come, and they will be the real technologies for the people, for the masses, not only in India, but for global world. So a beginning is already made by ICMR, DST and DHR to find interdisciplinary research, and this was not possible 10 years back. So we are happy to see there are several things which are going on now. A lot of funding is being provided for interdisciplinary research projects and large funding to solve many problems of the nation. One of the threats coming to the SWOT analysis is that the Indian industry is still not on board for R&D investments. It is the thing only for the government to put in money and to see how it can reduce that expenses, but at the same time the industry wants to get a thing which is fully cooked, and then the technology can be taken from a technologist or from wherever interdisciplinary research is going on. But they would not like to become partner from the day one. So this is where the threat is there. They have to come on board. And if you just look at the amount of R&D expense of any of the Indian companies in medtech sector, you'll find that it is hardly comparable to the Western world, where you can see, for example, companies like Medtronics, J&J, and others can have R&D expense to the order of 10% or more, but Indian industries will be less than 1%. So this is a big threat, and they have to come on board to see that there is a growth in this direction. And because I have been working in the medical devices sector, a lot of medical devices were designed, developed, and so on. So I can see that almost 80 to 90% of the devices are imported, and particularly the implants. And these are something which can be made here by our own people, and the cost will become very affordable, because otherwise it is not affordable. For example, if just off the cuff, if I just talk about a heart pump, which is required for a particular patient if the muscles atrophy happens, it will cost nothing less than 25 lakh. Even the rich people in India will not be able to afford it. And these are technology costs, R&D costs, regulatory costs, and so on. So a large population is bereft of the latest technologies, and when we want to do the healthcare technology assessment, we have to also ponder into these aspects, that whether it is affordable and whether it is being manufactured in India or not. As far as IIT is concerned, IIT Delhi in particular and other engineering institutes, there is nothing impossible. We are in a position that we can make any implant, any device, any medtech point of care device, which is possible. And we are seeing some of the examples, like M-Pragati is one of the example of IIT Delhi, supported and sponsored by ICMR, where we can do the design, we can do the prototyping, we can do the fabrication, we can do the complete testing for its life, and it is clinically ready to be deployed. And then the technology becomes, whether it's a hip joint, knee joint, mandible joint, or elbow joint, or a dental implant, or a cardiac stent, or a heart valve, any of those things are possible to be manufactured at one place and deployed. And we have also taken a stride to start some new educational courses. For example, IIT Delhi is the first one to start a course, MSR, postgraduate course, only for the medico people under the Center for Biomedical Engineering. So we have the first MSR course where MBBS doctors, BDS doctors, MDS, they all can come and do research and be on the same platform to do innovative, cross-cutting solutions which they want to. And particularly AI is one of the sectors where most of the medicos are looking forward for the next 10 years. So we have also...
Professor Bhatnagar, may I request you to summarize in a minute?
Yeah. So I'm just 1 or 2 points. We have more than 80 projects being done along with AIIMS Delhi. And this is a MFIRP projects, and all the R&D investments are from internal revenues. So that means 80 such projects are also going on, and we are able to assess those technologies. And in future, we shall look forward to School of Public Policy, which is also existing at IIT Delhi, to bring out the new direction based on use cases of other institutes as well as IIT Delhi, and can be submitted to the ISHTA for further evaluation and implementation. So thank you very much.
Yeah, thank you, Professor Bhatnagar. You have now nicely summarized the strengths, weakness, opportunities, and threats from an R&D point of view for technology integration, and also listing down a few key initiatives that IIT Delhi have been doing in this direction. So now it's a pleasure to hear from some of the international experiences again. We started with the WHO perspective in the Southeast Asian region. We are now going back to invite Professor Aluyam Swantika, who is the chair of HTS Center unit at the Indonesia. Okay, Professor Aluyam, he is professor at the Department of Pharmacology and Clinical Pharmacy at the University of Padjadjaran, and have an expertise in pharmacoeconomics, health economics, and HTA. So welcome for your thoughts. Thank you.
Thank you. Good afternoon, everyone. My name is Aulia. I'm the chair of Indonesian HTA Committee. So on behalf of the Ministry of Health Republic of Indonesia, I'm going to share our experiences in terms of using HTA to integrate innovative technologies into health system. Maybe I will start my presentation from the background. So in 2021, during the pandemic situation, our president initiative to launch healthcare transformation program in Indonesia, which is in line with the president's vision to develop a healthy, productive, independent, and equitable society. So in that transformation program, we have 6 pillars. The first pillar is primary care. The second is referral service. The third pillar is health security system. And then the fourth pillar is health financing system. So in the next slides, I'm going to emphasize the importance of HTA to support this pillar. And then 2 other pillars are human resources and health technology. Yeah, so in 2014, our government launched the social insurance or national health insurance. So since that time, and then we realized the number of participants and the cost of program services tend to increase annually. So the government targeted the universal health coverage can be achieved by 2019, but up to now, we have not yet reached the target. But if you can see from this slide, the progress of our coverage is increasing significantly. So until now, our national health insurance coverage reached up to 96%, which is equivalent to 268 million population in the country. And then at the same time, the expenditure on national health insurance services has continued to rise. So considering these numbers, there is a need to make the health outcomes to be improved efficiently. So in that case, the government realized that the health technology assessment is very important part. Considering that health technology assessment is a scientific approach, the government has prepared several legal bases in terms of HTA can assist the Minister of Health in making decisions regarding technology adoption in the National Health Insurance Program. So in 2018, the presidential regulation was launched concerning NHI by emphasizing that HTA should be the quality control to evaluate the National Health Insurance Program. And then 1 year before, the Ministry of Health, for the first time, launched the HTA guidelines in more comprehensive way. And then last year, the Ministry of Health also launched the new business process of HTA in the country. And then since that time, we also have the new HTA committee with the new roles and responsibilities. So currently, the role of HTA in the country is not only to evaluate new or innovative health technologies to be included in the benefit package, but we are also active to evaluate the existing health technology or standardized therapies or services. So the HTA is playing a significant role in listing and delisting all programs in the benefit in the benefit package. Yeah. So this is the summary about the role of HTA as the key part of our health transformation. As I mentioned before, that our national health insurance was launched in 2014, and then 1 year later, we conducted 2 HTA studies, which were for HD and CAPD versus APD for patients with terminal renal failure, and then the second topic was about sildenafil for patients with pulmonary arterial hypertension. And then 2 years later, we launched our first HTA guideline. And then since the beginning of our health transformation process, the government is also trying to create a new HTA business process to enhance the role of HTA, HTA as the quality control. So under the support from international donors and support from many strategic partners, and then we started to initiate the development of new HTA business process in 2022. Yeah, so now we already have the new HTA business process. We launched it last year. We divided this business process into 2 stages. The first stage is evaluation, and then the second stage is about implementation. So in Indonesia, we have now a single platform for drugs and medical technology submissions. So for your information, in our HTA committee, we have 2 subcommittees. The first subcommittee is for drug, and then the second subcommittee is for medical technology. Medical technology include medical devices, medical procedures, promotive and preventive services, and also community health program. So for the evaluation stage, we open topic submissions for regular and stakeholder-led submission. So for regular, any stakeholders, any parties can submit their topic, their proposed topic. And then at the end, the committee will evaluate which topic will be selected as the priority topic for HTA studies. And then for the second one, we have stakeholder-led submission. It is a new mechanism for those who already have full HTA studies. So the difference is regular, you can only submit topic, but for SLS, you need to submit the full or complete HTA study. So to facilitate those 2 mechanisms, we already have a single platform. And then the committee will assess, and then we also consider price negotiation through value-based pricing in terms of extending the HTA study to achieve the most optimal cost effectiveness and affordability value. And then at the end, after all HTA agents have completed the HTA study, the committee will do appraisal. And then we are moving to the implementation stage. After we do appraisal, and then we will make a recommendation. Recommendation made by the HTA committee will be delivered to the Minister of Health. And then the decision will be made by the Minister of Health. And then after that, there is consolidation of decision, and then we will implement if it is selected or if it is if the decision is already made by the Minister of Health. And then we are also conducting monitoring and evaluation. So what we can conclude from our new HTA business process that was launched in 2024, we have 5 innovations. The first is single platform for drugs and non-drugs. And then we have the new mechanism, stakeholder-led submission. And then we have rapid assessment methods. So learning from the experiences from other countries, now we are applying adaptive HTA. And then we also use value-based pricing for negotiation. And then we also encourage patient involvement. So in general, talking about the number of HTA studies in the country every year, the number is increasing significantly. So at the beginning, we only have 2 studies to be evaluated. Now, in average, we already have around 95 HTA studies per year to be evaluated by the HTA committee. I think that's all. Thank you very much.
Thank you, Professor Aulia, for taking us through the journey in a very short time from how you started it to where you are now and the business cases. And actually, for those of us in India who are working in this HTA domain, this is a very good comparison that we can make with our own effort as we are adapting to these new technologies of HTA in technology integration. So with this, I hand over to Dr. Sandra for the next process.
I think it's now time for our chairperson. Do you want to make comments and then open the floor to questions?
Yeah, maybe we could take some questions first.
So
and,
I'm just going to ask Dr. Sangamitra Pati, who's now very kindly stepped into the role of chairperson, and she's the additional DG of the ICMR. So over to you, Dr. Sangamitra, and then you could use the next 5 minutes perhaps for discussion.
Yes, thank you. Thank you, Sandra, and thank you all the esteemed panelists. I think since morning, all of us have been listening and also now well convinced the importance of HTA. And to start with, what Dr. Ofrin told is that how HTA makes innovations accessible and at the same time becoming a driver of equity. So when we see HTA from the perspective of health system, it is not only protecting against out-of-pocket expenditure or not only conferring financial protection to all our citizens, but at the same time making sure that every citizen, irrespective of where from they are and what is their socioeconomic status, they do avail of the same technology. And that is the principle of health system, any health system, that accessible, available, and affordable healthcare. And HTA is going to be the means for that. And we also heard Sri Jalani ji, wherein he highlighted how HTA can not only protect against financial risk, but also it is the means for universal health coverage. All of us know universal health coverage has got 2 pillars. One is financial protection, another is comprehensive primary health care. And he highlighted how health technology can inform the health system towards developing packages for comprehensive primary health care, be it diagnostic, be it drugs, be it treatment modalities, be it prevention models, or be it any therapeutic and rehabilitative services. We also heard our esteemed professor, Professor Bhatnagar from IIT, wherein he highlighted the importance of collaboration. All of us agree. In fact, this whole audience today is nothing but the conglomeration of diverse disciplines all together unified for the goal of making health technology accessible to each one. And herein we do have technologists, we do have insurance agencies, we do have policy makers, we do have researchers, and we do also have people from the health system and health development sectors as well. And also, when we look at health technology assessment, there are 2 major challenges, but very nicely told by Professor Bhatnagar, the SWOT, strength, weakness, limitations, and opportunities. But 2 challenges which are common, which every innovator might have experienced, is that how do I navigate the whole journey of making my innovation getting taken up by the program. And it's a long journey, and it's a journey which we call it valleys of death. Many a times that innovation may get lost in its way when it's being adopted by the program. And also, we heard from the very interesting case study from Indonesia, our neighboring country, and they have already documented standard operating procedures. There is a definitive protocol in place how a new technology gets into the program. And all of us, when we see or when we look at all the presentations, there are 2-3 common principles which are being enshrined. The most important is that health technology is time that health technology assessment gets institutionalized. That is the first thing. And most second thing, health being a state subject in India at least, we require state ownership, policymakers' ownership of health technology. How do states seize that the health technology which is affordable makes it available and accessible for each one through our state procurement system. In today morning sessions, very nicely told by the Tamil Nadu Medical Corporation how they are making procurement informed by health technology. And second most important is that how do we build a HTA capacity building framework? Because each one of us has got our own set of limitations when it comes to HTA. So how do we bring that capacity building framework so that all of us are at least on the same page? So these are the two, key takeaways which I feel is that one is institutionalizing HTA. Second is how do we build capacity across policy, program, researchers, innovators, and clinicians and technologists for HTA. So having said that, I would thank once again, but thanks everyone and thanks the audience. All of us to understand the critical time period of post-prandial listening, but all of you have been amazingly, I would say, great audience. Thank you, thank you. I think a big round of applause to all the audience first for being a patient listeners and making our moral boost. We can take now a few questions. Dr. Orphan, do you think so? Yeah. We should take some questions? Yeah. Or you want to say a few words before you go to?
I think questions first,
Okay.
then I can
So can we have few questions for the panelists?
Okay, I can start off if there are no questions from the audience. One is to Professor Bhatnagar. Although your interest is actually medical devices and you say the engineers don't really come inside the operating room, would it be possible to bring your engineers to health and wellness centers and primary healthcare centers and district laboratories also to see where innovation is there? And the other question is to Professor Olia. You have put together a very well-set system of HTA integrated into the health system. Do you see that some people actually look at it as a gatekeeping, taking from the previous presentation? Is it too difficult, too protocolized that there is not much openness to request for an HTA for a possible technology? We can start off with those two questions, Professor Bhatnagar.
Yeah, it's a very good question. And in fact, we have already made a beginning to induct our students, particularly from the 3 bio entities. We have a Center for Biomedical Engineering, School of Biological Sciences, and Department of Biotechnology and Bioengineering. So their students, whether it's a BTech, MTech, or PhD students, we are asking them for 3 months of immersion in any of the hospitals before they decide their thesis or a project. So that way they are, and we also emphasize more on a co-supervision between one faculty from IIT Delhi and one from any of the medical institutes, so that the problem can be defined and they can take it, and the 2 faculty members can also write a project and which we are going to fund it internally. So that is a multi-institutional faculty research program. So in this way, we are moving further, and this has also got a traction from several institutes that large projects worth few crores of rupees, all that research has been initiated, and we are working on that and trying to solve many problems.
So talking about the gatekeeping process, so let me provide a brief information about the reason why we try to develop the new business process of HTA in the country. So previously, many stakeholders realized the importance of HTA study, but at the same time, we also realized that HTA study is time-consuming and then not transparent in some process. And then we tried to develop the new business process by involving all stakeholders in the country can participate actively in the whole process. So now all stakeholders can submit their proposed idea, even though they already have the full HTA study or complete HTA study, they can submit it. So in order we can accelerate the process of HTA, and then at the end, if we can process the accelerate, and then we can make more accessible for the community to innovative healthcare technologies. Also in terms of gatekeeping, in this case, we are trying to optimize the process can be more efficient.
Yeah, can I ask one question? It's pretty impressive and interesting. In fact, today morning while in the exhibition, the pharma secretary was asking us, how do the innovators know that this is the device I should make? I mean, for health technology, I mean, how do the innovators get the idea that we should do our health technology in this direction? Be it sickle cell disease, be it antihypertensive, be it stroke. So do you have a set of priorities for medical devices and diagnostic which is open in the public domain so that the innovators are aware that we need to go in this direction?
Yeah, so in Indonesia, we have several criteria for new health technologies to be considered as the priority in the country. So one of them is should be in line with the current government programs or priority. So, for instance, our current president has several priorities. The first is TB elimination, and then the second one is free screening for all population. So the president is trying to give a gift for all citizens as their birthday gift, a free screening. So using this as an example, and then many innovators are trying to submit their idea. So one of the important criteria is in line with the current government program.
Yeah, I think we...
Okay. Thank you very much, the chair, co-chair, and the panelists, particularly for your contribution, for being here, and for keeping to time. So I think we will bring this to a close. May I ask Srimati Anunagar, Joint Secretary DHR, to hand over mementos to all our speakers, and may I ask all of you to just step forward so it's easier for her to do that. Thank you. Thank you all. For the moderators. Thank you.
अभी कितने हैं इसमें सेशन में? 6 लोग हैं, 6 हैं। So 2 पीछे कर दो। हाँ, हाँ, एक उधर से कर दो, और रिकॉर्डिंग पीछे ही रख दो। ग्रेस को आगे करो, छोड़ो। इसमें ये फिट है, नहीं आया ना, एक साइड से और मिलेगा। नहीं, ऐसे नहीं आएगा। ये बोर्ड दे दो, इसमें डालो। हाँ है। वो एक नाम से तो थे, वो देखते रहना कौन कौन से हैं। पंकज कुमार, ग्रेस का इधर लगा दो। यहाँ पे शंकर आ रहा है। हाँ, लगाओ। शंकर हो गया।
Hello. So let's begin the last session of the day today, and I hope that you all are awake and all of you are there with us, and we hope to make some good discussion during this last session of today. We've heard a lot of deliberations over the course of the day today, where we've heard different speakers, both from international settings, talking about global experiences, and from within India, who've spoken about how to set up HTA systems, and how to showcasing some of the best practices. This is a session where we are going to talk more about the kind of application of HTA in one of the niche areas, which is around pricing of drugs and devices and also services. So we have a very exciting panel here with us. So we have Ms. Anu Nagar, the Joint Secretary, Department of Health Research, chairing this session. And we have among the panelists with me Dr. Pankaj Kumar Arora, who's the Director at the National Health Authority looking after the Ayushman Bharat Pradhan Mantri Jan Arogya Yojana. We have Dr. Grace from the Technical Officer, Health Financing at the WHO Country Office for India. We have Dr. Michael Kempur, who's traveled from Philippines to give us a bit of insights into the kind of applications of HTA which we have in PhilHealth context. And I have my co-moderator with me, Dr. Abha Mehendireta, who is the non-resident fellow at the Center for Global Development. So without much further ado, I'll first hand over to the chair for the opening remarks. Over to you, ma'am.
So a very good evening to you all now. It's almost evening. And we've had wonderful discussions today. And one of the important niche areas, like Dr. Shankar said, is pricing and procurement. And at the health technology assessment, this is the most common question that comes to us from the state governments, from the central governments. And this is primarily where they have seen the importance of HTA. So there are other issues also and other benefits also, but primarily the focus of the user agencies is on pricing and procurement. And we have a wonderful panel here and experts here, and especially the use of HTA can be elucidated by them. So this is all I'd like to say in the beginning, and I'll reserve my comments for the end. Thank you.
Thank you very much, ma'am, for those opening remarks. So we actually had one of the speakers who's the chief of the Center for Global Development, Javier Guzman, who was supposed to travel to share the kind of global experience on using the HTA evidence for pricing decisions across different countries. In his absence, I'll request Dr. Abha, who's my co-moderator, to actually present his slides and share the learnings that we were supposed to have with his presence. Over to you, Dr. Abha. Dr. Abha, as I mentioned, is the non-resident fellow at the Center for Global Development, where she's actively promoting evidence-based medicine and informed decision-making, and she's been actively engaged at different forums within India as well as outside. Over to you, Dr. Abha. Thank you.
Thank you so much, Dr. Shankar. Thank you for the introduction. Good evening, everyone. I'll try to keep it short, and I hope we can take some questions at the end of the panel and have an engaging session. So I'll be talking about value-based pricing, and we've been hearing that word since morning. And value-based pricing is really a pricing strategy that aligns the price with the value of the intervention, considering factors which includes clinical outcomes, impact on patients' quality of life, as well as the economic impact. And we all know that not all health technologies are equal, and that's why it's really important to generate this evidence so that you can give more information to buyers and payers so that they can make better decisions. And then, of course, as I described it, since there are people who want to sell that, and then there are buyers and purchasers on the other hand, it involves negotiation, it involves regulation so that we can get it procured, particularly in the public health system. So how does value-based pricing work? As I mentioned, the key components of when we are looking at value, we look at the impact of the technology on the actual patient outcomes. Does it really improve survival? Does it improve quality of life? Whichever outcome that is of interest. But you also want to look at the dimension of cost effectiveness, which we've been hearing since morning, in terms of how much cost per additional quality adjusted life year is gained with this technology.
And you may have something which is very cost effective, but you may still not have a budget to afford it. And we heard that example from Kerala where they looked at cost effectiveness, but they also looked at their budget impact to be sure that whether they can procure that particular technology. And I think a very important dimension which may not have been discussed a lot today is also that you also need to look into social and ethical considerations. And we heard about rare disease in the morning from Secretary Health and what can be done maybe to subsidize so that you can actually bring them in the market. And all we are actually aiming for is to get fair pricing and to have a mechanism which allows these two parties, the pharmaceutical industry, which is very important, which is doing a lot of innovation, which we do want to enable and increase access to our patients, but also keeping in mind this is government spending and we want to ensure that every rupee spent brings value. And how can that fair pricing we come together, and I think health technology assessment, as we've heard since morning, is a very important tool to make that happen. So I'll be briefly talking about some country examples. We've heard a lot about what's happening in India, and Dr. Shankar, my co-moderator, will be talking more about the Indian experience along with Dr. Pankaj. So looking at Thailand, so Thailand has the ISHTA agency, which is called as HITAP, and it's important to know that all medicines which are included in the National Essential Medicines list need to go through an HTA, which assesses the value of the drug before it's added into their national list of essential medicines. They have a cost effectiveness threshold, which varies between countries. In Thailand, this is around 160,000 baht, approximately about $4,500 per quali. We have a different threshold in India. And you can see as an example over there that it has allowed for both an enormous amount of saving, budget saving, as price negotiation has been linked with the use of HTA to increase access of drugs within the National Essential Medicines list, which has allowed more and more patients to be able to access these important technologies, the important drugs in this particular instance. And of course, there are challenges. There are challenges with availability of data. There are challenges with being able to manage stakeholders, particularly industry pressure. But it's an evolving thing, and it's found to be a very important tool. The second example I wanted to give is of Brazil. So they have a collaboration between CMED, which is their regulatory agency for medicines, and CONITEC, which is their HTA body. And they have a three-stage process which they have been following since 2004, so for nearly 2 decades now. So CMED determines the maximum market price, which is based on the health benefit, the clinical benefit. But then the HTA agency, CONITEC, it produces evidence which allows to understand what the coverage and pricing decisions should be for the public sector. And price negotiations with ceilings are established in both these steps that what CMED does as well as what CONITEC does. But again, there are challenges. This is not easy, as we're going to be talking, and Dr. Shankar will be elucidating more about challenges and opportunities. But here in Brazil, one of the main challenges is judicialization, legal challenges where patient rights come in and patients put in PILs and say, we need to have access to this medicine. And there is this litigation between patient groups, legal compliance, and that has been a challenge to make sure that the HTA recommendations can actually be complied. And secondly, when we are having medicines which are being considered for orphan drugs, where orphan diseases, where the benefit may be uncertain, there may be lack of lack of treatment options, as well as lack of price comparators, and it's challenging to do it in that context. So I do want to refer, if you're interested to know more about the example from Brazil, and there are other countries like Peru, as well as more information about how HTA informs price negotiation. We collaborated with IDB to develop a MOOC course. It's available in edX, which illustrates these examples in more detail. But just wanted to, maybe just 2 slides from that course I wanted to mention is, when they're looking at the medicine, they're looking at whether it brings therapeutic gain, as I mentioned earlier. So it could be 3 scenarios. Either it could be that there is greater efficacy compared to the existing medicine on the market for the same therapeutic indication. It may be that there is equal efficacy, but the side effects or adverse effects of this drug is less. Or it may be equal efficacy, but there may be a significant reduction in the overall cost of the investment. And this information generated through health technology assessment then helps feed into the price negotiation. And you can see over here that over a period, and it's quite a substantial period over a few decades, which has led to a very significant saving in the budget, with a reduction of the entry price of new medicines decreasing by about 87%. And these are direct savings for the Ministry of Health, and that's a great opportunity as we are talking more and more about the use of HTA for price negotiation in India. The third and last example I wanted to give is of the Benelexa initiative. So this is unique because it's a multinational collaboration between 3 countries in the EU. It includes collaboration between Belgium, not 3 actually, now it's become more. The acronym was made with 3 countries, but now I'm seeing it's Belgium, Netherlands, Luxembourg, but also now includes Australia and Ireland. And they jointly conduct the HTA and they negotiate the drug prices together. And with the goal that, with increased power of bargaining, when these countries come together, they're better able to negotiate with the pharmaceutical companies. And this also helps create greater transparency on price. With challenges, of course, different countries, different circumstances, different costing structure and standard of care, so coordination is an issue. And of course, the industry may also resist to have collective negotiations. Earlier in the day, we were hearing about the Sierra region and the potential for India leading the way, especially in the region. And then I do see there's an opportunity for other countries in the neighborhood who can actually maybe join forces and use some of this evidence and come together to do more collective price negotiation and purchasing. And I do know Grace is going to be talking a little bit about the challenges and opportunities of doing that. So the pros and cons of value-based pricing. I think some of the pros are very clear. It improves health system efficiency and sustainability, improves affordability and managed access, and of course, the market signal towards health benefit. Purchasing that is blind to opportunity cost sacrifices the money that could have been used to save lives, and it's really a waste of money. Having said that, it's not a panacea. It's not without challenges. It is very difficult sometimes to accurately assess value, and sometimes requires a strong legal mandate, as well as a substantial amount of time and effort to be able to do that. There can be disagreements between stakeholders on how value is defined and measured, and there can also be equity concerns. There is not one size that fits all, and certain medicines and populations might require different rules, as we heard earlier about orphan drugs and rare diseases. So I just want to conclude with this slide. Dr. Calypso was kind enough to show this earlier. So we've done a collection of articles in the BMJ Evidence-Based Medicine. And I want to specifically mention 2 articles. One is a study that we did called iPros, where we looked at the evolution of India's HTA journey from 2016, a year before the HTA agency was established in 2017, to where we are 2022. And we looked at 3 important elements. One, in terms of the ecosystem that has been set up in the country, the enabling factors, and there's been a huge amount of investment by the government of India, where we have now an attached office and a huge amount of resources with more than 100 people across regional resource centers across, I believe, 19 to 20 states. So really that ecosystem has been a significant amount of change over the last 7 years. We also looked at inclusion and exclusion of interventions, and we have found that between 2016 to 2022, a large number of policy decisions have been based in terms of what to include or not to include using HTA evidence, and we heard a lot of the examples in the morning as well. One opportunity that we did find was about the use of this in price negotiation and procurement. And while there are examples with the sickle cell diagnostic kit that we heard earlier, as well as the safety engineered syringes, but there's a real opportunity to do more of this. And it was very heartwarming to hear Secretary of Pharmaceuticals saying, we need to use this more, and to have so many state secretaries saying we want to use this more in decision making, including pricing and procurement. So we had the Tamil Nadu Procurement Agency present. And secondly, there's an article on the vision of HTA for the next decade. And there also, there was a very strong recommendation that really how can HTA evidence be, the value that is there, be used beyond just coverage decisions and inclusion decisions to using it for price negotiation and more affordable medicine. So with that, I'll thank you, and I'll hand it back to the moderator. Thank you very much.
Thank you very much, Dr. Abha. Thanks for that initial enlightening talk and giving us a broad landscape. So from that global overview, now let's shift our lens to the Indian landscape and hear from Dr. Pankaj Arora, who's heading who's the director at the National Health Authority, looks after those decisions around inclusion, exclusion, and use of HTA into policy making. So I welcome Dr. Arora to give your talk. Besides being a surgeon by background, he's also done a master's in global health from the London School of Economics, and is an extremely prolific administrator by all means that I know of and by my personal experience as well. Thanks, Dr. Arora.
Thank you. Thanks a lot, Dr. Shankar, for the nice words. We will be going through some things which we do at NHA at present. National Health Authority is the authority set up by the Ministry of Health and Family Welfare for implementing the Pradhan Mantri Jan Arogya Yojana, which is the largest completely public funded health assurance scheme in the world. It gives 5 lakh assurance to the beneficiaries which are being deprived of other ways of several benefits, so that they have decreased out-of-pocket expenditure. And we are also been entrusted with developing policies and operational guidelines for the same, and also the standard treatment guidelines and quality protocols. We also are been entrusted with formulating and revising the health benefit packages, which are important for the providers which are giving services, and we make them kind of balanced so that government is also happy and the providers are also happy. As you know, we have been delivering the service through a public and private partnership, and a lot of private partners are there which make the providers. Nearly 40 to 50% of them are from private sector. And earlier, as you must be knowing, that STIN was not taking requests from the private partner. They need to go through a public entity, and government departments could only raise those requests to the STIN. So we were getting a lot of requests from the hospital, clinicians, pharmaceuticals, the private sector, as well as government for inclusion of several technologies. And we needed to have the kind of expedited evidence synthesis for the same. So that led to the setting up of a health financing and technology assessment unit at NHA. There we are taking requests from the industry, the associations, doctors, and all, and they would be in this private sector entities as well as the government sector will kindly combine and give nominations for this technology, and there is a team which was set up for going through those requests with the kind of checking on the documents and the research and evidence which has been given by them, as well as we go a step forward to do horizon scanning and see what are the evidence already available in the literature. So the ISHTA unit will do the evidence synthesis and share the details with the STIN, which will the secretariat will kind of send it to the tag. This is the different units they have, and that committee the committee will then send the results back to us, and our unit we will see that and see what are the kind of negotiations required, and the price negotiation and strategic purchasing committee will go forward and request and deal with those healthcare providers and technology providers, may it be drug, may it be any other technology, to get those prices which would be cost effective for implementation and inclusion in the Ayushman Bharat Pradhan Mantri Jan Arogya Yojana. We made it easier for them to go and put it on the portal, which we made, and that new inclusion portal was very easy for applying, and for making it easier, we just made some QR code, which NHA, being a digital kind of digitizing everything, went up step forward. And why it is needed, why the economic evidence is needed in PMJ, that is important. It definitely helps in rationalizing the health benefit packages which we have. It helps us to decide that we should include that technology or we should not kind of go forward, depending on the cost, the effectiveness, clinical effectiveness first, and then the cost effectiveness. So as it was discussed, the budget is important again. So if even it is, some rate is coming and that amount of people, we have to see the data, the base for which that product will be used, the people who can get that amount of disease, they're getting that disease. So we have to calculate the budget also, the impact it is causing on our budget, and can we include it in our system for those patients. As well as it has been used for revising the standard treatment guidelines. I'll give you the examples afterwards. But yeah, for increasing the cycles of something which is already there or decreasing them, in any which way we can go forward and do it. If the cost increases, then we have to kind of think about it. If the cost decreases with time, we change and increase the cycle if it was cost effective. As well as setting of the prices, like the costing study of health services in India was very helpful in getting over with the anomalies which we had earlier. So that was the price which were used then for devising the recent health benefit packages released in 2022. So I'll just go through what we do, what we did in 1.0, then what we changed for a betterment. So there was a technical committee which includes so many partners, the ministry, the Niti Aayog, the other government, the other state representatives, the experts from the financing and the clinician world, and the development partners, the academia, and as well as the industry. They were in the technical committee, and they reviewed the existing evidence on prices from the government-funded insurance schemes, which was finally, the thing was sent to Niti Aayog also for review, and final consultation was done with DHR to review the market rates, and the consultation then was done with the health expert and private sector. And finally, the result was made, and then the first package was launched in 2018. The package rate really were inadequate, actually, and they were duplication of packages. There were some nomenclature issues. Procedure were overlapped. Some high-end procedure were not there. So that was done away with by using the CHSI study, which was commissioned by the ISHTA, to kind of decide on the packages and the prices of the PMJ. So they gave us the referencing cost, and after that we kind of made a final decision on those things, those study which included a lot of hospitals, kind of 40 of the public sector hospital and 22 private sector hospital. There was a lot of, it was a very, very detailed study actually. It went deep into what nursing cost is, what hospital infrastructure cost is, what medicine cost is for every packages, and that was finally used for making those packages and revising those rates. So what basically it can be a different kind of a circle, but usually it is the same. There has to be something which should be institutionalized, and the process and structure should be there. So we kind of select the topic right now and evaluate the evidence. I think it's visible or not? Yeah, I think there's some issue with the slide. So we basically do the holistic review, and we do not restrict ourselves to new technologies or inclusions. We go forward, do the horizon scanning also, and it's a dynamic process. And we finally see the budgetary impact and then give the recommendation. After that, the states are also being consulted because they also have to feel the impact. Being Ayushman Bharat being a central sponsored scheme, so states also contribute 40% and 10% in different areas. So finally, the decision is taken, and the packages are changed. In 2022, NHA went forward and enforced the differential pricing, in which we have given different rates for different tier of cities, and also the differential pricing included the secondary and tertiary care packages, which were different for surgical and medical specialties. So incentive of nearly 50% for a surgical package in a tertiary care in a tier 1 city was there. So if it is 100 rupees, it was rather 150 rupees in a tertiary care for a tertiary care surgical package in a tier 1 city. And similarly, for a medical package, nearly 25% was the increase of rate. So that way, at least the wages which are higher and the infrastructure costs which are higher in the tier 1 cities were kind of taken care of, as well as the resources which are required for a higher tertiary procedure were kind of also taken care of. Because I've got less time, I knew, so I'll just close it in next 3 slides, and it will be very fast. So just giving an example, how did we decide on inclusion and exclusion? So there was a study, there was a request for including one drug with in combination with a drug which was already in use, and we used the combination was found to be having even not cost effective at the discount of 95% of the cost of the drug. So unfortunately, that was rejected, and the qualities we gained were not that sufficient to include that in the study. Similarly, for the packages, we increased the packages also as per the standard treatment guidelines. Tranzumab was one of the drugs which were only given, the 4 cycles were only given as per the cost effectiveness study earlier. But over a period of time, the again study was done, and 8 cycles were allowed, that is up to 6 months. And it increased the access and to the treatment to these beneficiaries which we have in PMJ. So after that also, recently we have seen that the cancer drugs prices go down. We did the horizon scanning, and we found that of the prices also then found that the prices have gone down. We are going to reduce the prices and increase the cycles more for the people who have diseases which are complicated and may require more cycle in Tranzumab. It also helped us in decreasing the cost to the government. And for example, there was an average increased use of fractions for a breast cancer. Nearly 10 fractions more were given, which were required. 16 was the fraction regime, which was found to be sufficient, but they were getting more than 20, 25. You can see up to 50 also in the bar graph. So and also the post this operation or MRM radiation was not required in N0 cases. So these things reduce the cost of nearly 105 crores for us. So I'll just conclude by saying that health technology assessment is an important part of any country, and it should be taken seriously and should be collaborated with the other countries as well. We learn good things from different countries. Thailand is one of the examples we have learned from, and this really helps in getting treatments which are required, and government can provide them to the people by including them through the health technology assessment. ISHTA has been very kind to help us reach that, and we are very thankful for ISHTA and Anu ma'am and all the team who have been very, very cooperative. Recently, we have got 3 drugs which have been given a cost-effective price. So we are going to first time negotiate and do the strategic purchasing for those drugs if the industry is helping us to provide them to the public. Thank you. Thank you very much.
Thank you very much, Dr. Pankaj. I think that is exactly what perhaps we would like to see, more and more evidence getting into decision making at the NHA. I think perhaps one of the most critical departments for us in terms of uptake of HT evidence, given that there's a large decision making on allocation of public resources that goes in at your office level. So I think with those encouraging illustrations from the Indian case study, we'll move on to the context of Philippines, and I'll invite Dr. Michael, who's a health system expert at the Asian Development Bank for the Build UHC program, who's also the founding board member and the president of the Philippine Society for Public Health Physicians, to share his experience on the kind of price negotiations for value-based pricing in the Philippine context. Over to you, Dr. Michael. May I request if you could please stick to the timeline, around 8 minutes or so. Thank you.
All right. Hopefully, and thank you. I'll try to make it short and kind of be more direct to the point on what message we want to convey. So firstly, I'm thankful. Thank you for allowing the Philippine Society of Public Health Physicians to be joining this auspicious convention that allows us to discuss HTA. So the topic that I was given, I tried to make sure to provide a more practical point of view on how HTA and its pathway towards decisions will be able to provide alignment to real UHC priorities. And I take for example, what's happening within the Philippines. Next slide, please. Oh, sorry. So some of the key aspects for value-based drug procurement within the Philippines, there are 3 main documents that allows us to utilize HTA into the procurement processes in the country. So first and foremost, the HTA provides the methods. We have the methods process, and it's quite new for the Philippines to actually apply HTA, despite the fact that HTA knowledge has been around since 1970s within the country, trying to apply multi-criteria decision-making over health procurements. And then another instrumentality is the Philippine National Formulary, which is the document that allows us to know the essential medicines list that is the basis for tailored procurement of medicines in public health facilities, as well as the reimbursements for health packages within the Philippine Health Insurance Corporation. And then, of course, the Drug Price Reference Index. So coming from the formulary that utilizes the HTA information, these medicines or drugs are studied further and to be included within the Drug Price Reference Index, which is the tool to benchmark the price for essential medicines, allowing for comparison between brands and also be the basis for a lot of the government procurement tenders that is being utilized by various local governments in the country. So the fundamentals towards value-based pricing began with the understanding that a lot of the drugs within the Philippines was actually expensive and from the utilization of branded medicines. And the Cheaper Medicines Act provided the basis for establishing a maximum retail price for drugs and medicines and encouraged competition in the supply and demand of affordable medicines, and also provided government regulating prices for certain market failures. So certain companies that actually have a control over the prices have been entered into agreements for cutbacks for the prices of these medicines. And then the basis for value-based pricing comes from the idea that it's not just the cost that should be the basis. It has to be within the presence of a clinical evidence for robust clinical demonstration of efficacy and safety, public procurement process where there has to be a transparent bidding process that utilizes the information coming from the DPRI and also the submitted documents of the drug companies, and also the generic drug promotion where those distributors are encouraged to make sure that generic medicines are prioritized and also indicated in all prescriptions. So how does HTA enter into the selection of what comes into the formulary? So there can be major, minor, or exemption inclusions. And the major inclusions would be medicines that have new indication, new formulation, and new route of administration. And there has to be a full HTA review. There can also be minor inclusions if there are changes in dosage, net content, and immediate packaging. And those that have exemptions where, for example, it's for urgent and emergency life-threatening situation that provides a 1-year provisional exemption. So these are things that necessitate HTA information for them to be entered into the formulary. So just for example, in the newness of how the Philippines is utilizing HTA just in 2021, where we started monitoring the ISHTA recommendations or the HTA Council recommendations, we have about 48 recommendations, which includes a lot of them are COVID-19 vaccines. And then in 2022, there were 25 recommendations for 10 drugs in particular and 11 vaccines. 2023, 18. And then 2024, we just had 14. The process of HTA submissions is centralized within the HTA Council, and that's the reason why part of the challenge is the bottleneck, because there are only a few people who are capable to and are mandated to screen through the information. And this is just an example of the decisions that were created by the Department of Health coming from the HTA recommendations. And for example, these are the range of medicines and drugs that were included into the formulary. Just like the other countries, another important criteria is that it's part of the priorities of the country. So for example, the Philippines has been more focusing on the acceleration of HIV/AIDS infection within the country, and that's the reason why a lot of the inclusions there are about the inclusion of new formulations for HIV medication. This is incomplete. I had other slides. Oh, all right. In any case, I had actually I had 3 more slides that were included, but I guess one of the things that I wanted to point out is that within the idea that HTA in its format is already for value-based pricing and procurement and value-based decision-making, what then is the problem when it comes to actual decision-making? Part of the reason why it fails is that a lot of the decision-making platforms are from non-technical people that are creating procurement decisions. And these are trickled down towards local governments, for example, in the Philippines, where they are not necessarily HTA users. They can be having some decisions, but part of the limitations as well is the access to the particular recommendations. For example, there is a recommendation for a particular medicine, and it's not present within the islands. Then the decisions will have to be made on the basis of availability and not anymore on value-based decisions. So the technical decisions that get the technicality of the decisions that have to be made at the local government level, and also the access to the various medicines that are being recommended for by the PNF and also the the prices that are recommended by the DPRI are not necessarily happening within the local government. So that's a challenge. So part of the alignments that I'm proposing is that we have to, within the country, have some re-centralization of the devolved procurement process, and also allow more technical people to get into the bids and awards committees that are actually able to utilize the HTA information for the decisions that will be value-based and also that appreciates the information that are being provided. And then another thing is with local governments procuring, part of the alignments that also have to happen is the integrity of the supply chain management. Any decisions for which central-based procurement that are justified have to trickle down to the farthest mile, and especially the underserved. And by ensuring that there is integrity of our supply chain processes, it will allow us to be more confident that value-based decisions are translated into actual provisions within local governments. And these are some of the alignments that I'm proposing as well within the country. Thank you.
Thanks, Dr. Michael. I think one of the key points that emerges from this, from the Phil example, is the fact that how potential legislation which backs up the decision making is useful for the functioning of some of the institutional structures that have to engage in these activities. So I think with that we'll move forward, and having heard 3 speakers before, we've definitely understood that there are several important stakeholders which are involved in such decision making and any kind of strategic purchasing. So I think it's an apt time to invite Dr. Grace, who's the Technical Officer, Healthcare Financing at the WHO Country Office for India, to share her experience on these, how to negotiate with the stakeholders and what could be the way to engage with these stakeholders for having a much more effective action. Thank you.
Good afternoon. Dr. Shankar, may I request for 10 seconds to request everyone to stand up and stretch, please. Just stretch. Okay, thank you. Please sit. I wouldn't be WHO if I didn't do that. Okay, so good afternoon. Yeah, thank you to all the organizers of this conference. It is my pleasure to present to you a bit of guidance on how we can incorporate or integrate health technology assessment in value-based pricing for equitable access. And I think this is an important topic. We've had the whole day about why HTA matters. And we've seen countless examples across the world, including India, of the benefits of including HTA and the drawbacks, as Dr. Andre, Dr. Calypso, and also our colleague from Philippines alluded to, when we don't do it as well as we would want to, what those drawbacks can be. So here is a document that WHO produced in 2021 around the institutionalization of health technology assessment, and I'll be drawing largely on that, giving us a bit of a headline view of how we can go about it in order to ensure that we produce quality HTA, but also it influences evidence-based decision-making. So why is HTA's impact, what is HTA's impact on equity? A lot of that has been said before, but I would say why we have to include HTA is really because drug pricing has implications for what is invested in and what is not and who it impacts. If we invest in drug A for tuberculosis, in an instance of resource scarcity, it means that this breast cancer drug may not be available for this particular lot of people, and so there are issues of equity there. How do we ensure that we are getting the maximum value? Secondly, HTA is a scientific process that at least enables us to bring issues of evidence on benefits and other societal values that we can gauge technically to bear within a pricing discussion. Most of the pricings go along the route of the return on investment and on the cost, but HTA enables us to bring in the benefit to society, which I think is crucial, especially when we are looking at equitable decision-making. And then the last thing is a procedural justice issue. Really, it enables for fair pricing procedures. Rather than a back-of-the-envelope discussion or a backroom discussion, it enables us to bring, within a deliberative process, different stakeholders together to discuss different values, and if well done, how we can come to consensus on something that works well for society. Okay, so this is a framework that was included in this document, really looking at the system around the inclusion of HTA within value-based pricing. And the issue is to have a transparent, fair HTA process enshrined in the law or the legal framework that is within that context, resulting in evidence-informed decisions, in efficiency, and lastly, better health outcomes. So the inputs that we really need to look at in this system are what is the mandate of HTA, and from then on, then build the system. And we'll look a little bit later into that, the legislative requirements, the governance arrangements, the assessment and appraisal committees, and the resources needed, all building into activities that allow us to assess, to appraise, to engage stakeholders meaningfully, and to do things around horizon scanning, to look out for emerging technologies that we want to bring to the value-based pricing discussion, and also how to deal with appeals. What is the output of this? Ideally, you want to have reports, recommendations that are put in a report that is well communicated and can speak to even stakeholders that do not speak the technical language, speaking to the issue that our colleague from Philippines concluded with. Some of these people do not understand what you mean by a quality. How do you make it that a policymaker, especially for instance, like in India, someone who has come from an engineering background and now is MD, NHM, how do you help them to be able to use this evidence that you've produced? And then, of course, you are able to project your needs, the gaps in the measures. You are able to ensure that whatever you have produced has an impact on financial protection, increased coverage, and greater access to health services. So we'll touch a little bit on the process components, although I'll build a bit on them later on. Within the process components, you want to be able to have that capacity to conduct the assessment. And of course, HTA is data hungry, so you need to have the data, and that data may include the results of clinical trials, the costs, you know, post-market surveillance, and so on and so forth, how you compile that and analyze it. But also, the assessment qualifies or describes the relation between the intervention and each criterion. So if you have a criterion on effectiveness, you must have evidence on effectiveness, you must have evidence on cost, you must have evidence on feasibility or sustainability of the intervention that you want to put in. You're looking at the drug and so on and so forth. And then, of course, you must be able to appraise the evidence. You must have a system for looking at the assessment report to assess the rigor, the quality of the data. You must have the inclusive engagement of stakeholders, and very important, to have local values, contextually relevant values explicated within the process so that everyone knows how they are dealing with it. And with good deliberative processes, you can't even weight the different criterion so that you know that if we are saying we are going to put 50% weightage on effectiveness and 30% on cost, 10% on equity. If it fails dramatically on effectiveness, that one then may not pass. And then lastly, you must be able to make the recommendation and to know whether it is a binding or non-binding decision, depending on the context as well. So the institutional prerequisites. So WHO recommends, one, you need to have clarity in the mandate. What do I mean? For many countries, value-based pricing, first of all, is one of the many tools within the pricing policies. So it could be done in addition to discounting prices, in addition to maybe external reference pricing and all. And so the role that the value-based pricing has in the country will determine how much weightage you're going to give in terms of investment in the HTA process. Secondly, what is the role of HTA in value-based pricing? Is it just one, the results that come out of it, are they just one of many different factors that are being considered within that deliberative process? And so again, that also affects how much effort you put in. Critically speaking, you need to look at the legal framework, and if you see the example of Philippines and Indonesia, they talk a lot about the regulations, the guidelines, the acts that are underpinning HTA. In setting up your HTA mechanism to inform the value-based pricing, you must be mindful of the different laws that are affecting the way the country works, constitutional law, administrative law, what's the balance of power between the states, for instance, in India, and the union level, what can be feasibly relegated to the states, what should be done at the union level. You need to think about public health law, you need to think about international law, especially because with pharmaceuticals, big pharma is transnational. There are free trade agreements that go into that, so you have to be mindful of some of those things. You need to identify the different roles and responsibilities for the different stakeholders, again, within the legal policy framework there. Why do you need to do this? You need, because it gives HTA relevance and a voice within the country if it is embedded and is working with the laws. So process-wise, you need to have a review of the laws and address any gaps that you think may hinder any processes regarding your HTA. As you do that, we advise that clarity is very critical. Clarity in terms of the process and the selection criteria, the principles and values that you want embedded in your HTA process, the mandate, like I alluded to, the clarity of responsibilities, the laws and regulations in the field, the clarity of the interactions among stakeholders, and the financial consequences of the decisions. The other element to look at too very quickly is the issue of governance and institutional arrangements. If you've been listening very closely, the HTA is configured very differently in some countries. In some countries, like in most of sub-Saharan Africa, it's a committee that is absorbing a lot of other HTA products produced elsewhere and bringing that to bear within a committee discussing many different values, including cost effectiveness. While, for instance, in UK, in Australia, when you're looking at pharmaceutical pricing, for instance, in Australia, the pharmaceutical benefit schedule is determined primarily by the outputs of the HTA assessments. And so when you look at that, they have a full-on agency that is looking at that, the Pharmaceutical Benefits Advisory Committee, that is supported by a network of institutions. And then in the UK, you have NICE, a single agency that does most of the work around HTA. So the way it is configured will depend on the context, the socioeconomic circumstances, the availability of data, the ability to conduct the assessment, and so on and so forth, including the mandate. So some of the things to think about is do you want it to be a centralized entity like in the UK? Do you want it to be more decentralized like the Indian model? You need to be able to separate the assessment and appraisal processes, need to be able to explicitly manage conflicts of interest amongst the people that are involved within the assessment and appraisal processes. You need to consider inputs around HR and financing, as well as identify the relevant stakeholders to bring on board. Another element is you need to build in a mechanism for monitoring and evaluation from the very word go, to be able to monitor, one, the outputs of the HTA, but two, you need to be able to monitor the way you are also conducting business as HTA. How frequently are we putting out HTA products? How responsive are we to the market? So on and so forth. And of course, there are some good indicator models that are there. Philippines has some. WHO also within this very document puts out some case studies that you can look to, and you need to be able to communicate these. On the human resources, I think this is the biggest stumbling block for many countries, particularly low middle-income countries. And so there is a need to identify what technical skills you need and to build the capacities. And here I think there is a role for in-service training, pre-service training. As we are training different public health cadres, I think we need to be able to institutionalize HTA in our courses. When I look at some of the universities that I've interacted with, for instance, in India, not much is being done on the HTA side, and I think that is something that can be built into. But this is something, again, as has been spoken about by Dr. Chalkidu and other speakers, the South-to-South collaboration really here will come into to help how we build human resource capacity that is easy, quick to turn around to help countries to do that. So you need to look at human resources around the prioritization and selection of topics, the ability to collect and to use the data, to manage and prevent conflict, to interpret the data, but also to facilitate the deliberative dialogue. You need to be able to manage your data because HTA is a very data-hungry assessment process. So the capacity to manage data is important, and transparency in the data inputs is very critical. We also need to have a discussion on financing. Most of the countries that have institutionalized HTA are actually doing so by financing the system themselves. When you look at the UK, you look at Australia, they put in funding. I know Australia puts in about $15 million at least a year to ensure that HTA is going. I believe in India it's the same thing. It is largely publicly financed. Some countries have also collect fees from for assessing the different inputs or submissions made by pharmaceutical company. I know Australia does that. I think also New Zealand does that as well. So that is another mechanism for ensuring sustainable financing for the HTA scheme. So in a nutshell, to institutionalize the process, you must be able to establish an appraisal committee that is inclusive of all relevant stakeholders. You must be able to scope for to scope what will be included in the HTA, explicate the criteria and values that underpin the HTA process, establish a reference case. I know India has a reference case, has some guidelines for how to do HTA. Other entities like NICE in the UK also has. Australia, the Pharmaceutical Benefits Advisory Committee has. This gives the industry, the pharmaceutical companies, an easy way to know if I'm to submit and I want my submission to be approved, it must comply with these guidelines, and also helps the appraisal committee to make their decisions much quicker and easier. You must be able also to have the appraisal committee with the criteria that they are working with well explicated and where possible weighted, so that they are able to judge between different values.
Dr.
And lastly,
Grace,
to communicate.
If you could conclude in the next minute or two.
I just have one more slide.
Thank you.
Yes. So with the stakeholder engagement, why we need to have stakeholder engagement is because, one, values differ. Two, what we care about also differs in terms of we can all agree on a certain value, but I'm more interested in breast cancer. Another person is, for instance, interested in ensuring that HIV drugs are on the table. So how do we make sure that everyone's voice is heard in a fair and deliberative process that fosters buy-in and also enables us to make use of potential evidence that is available? And so the mechanism for improving stakeholder engagement is to have an explicit value framework, and to be able to incorporate all the relevant stakeholders across the entire HTA process and institutionalization process. Identifying them early is critical. And there are different mechanisms for engaging different stakeholders. I'll speak to two. For instance, for experts, you bring them in committees. But when it comes to the citizenry, for instance, in the UK, they use things like citizens' councils, citizens' juries, where you bring different people together to be able to collect the evidence. Lastly, I'll just say that WHO India has produced a global review on value-based care. We did this in discussion with colleagues with NHA. This is really looking at bringing together lessons on value-based care, and within that report, we also make the case for looking critically at health technology assessment for value-based pricing as a critical input in improving value-based care in India. Thank you very much.
Thank you so much, Dr. Grace. Thank you for reiterating the point that there needs to be a very clear institutional framework across the continuum from the generation of HTA evidence to actual value-based pricing decisions, and the need for governance, the need for explicit policies and processes so that it can move beyond one-off decisions to something which is consistently applied. And you also mentioned every country has its own unique context, and we'll have to develop what is fit for purpose context and model for India, considering health as a state subject, and also highlighting that we need to think about monitoring and evaluation and take all the stakeholders along with us throughout that process. So thank you very much. So with this, I invite Dr. Shankar, my co-moderator for the last presentation of today. Professor Shankar is Professor of Health Economics in the Department of Community Medicine and School of Public Health. He was also formerly the Executive Director for HPQA at the National Health Authority. He is trained in community medicine, but also has a degree in economics from the London School of Economics. And his main research interest is really about costing of healthcare services and analyzing impact of health financing and conducting economic evaluations. So Dr. Shankar will be talking about the challenges, but also the opportunities that exist in bringing about value-based pricing in India. And I hope that will open up to a lot of questions, and we will open up for Q&A briefly.
Sure. Thanks, Dr. Abha. And I think my job is made quite easy, specifically with the last presentation by Dr. Grace, where you've already emphasized quite a lot in terms of what needs to be done in order to put some of these systems in place such that there is a better translation of evidence to policy. So I'll just try and summarize also some of the things that have been said, but not at the risk of too much of being repetitive. But just to say that there are two ways of actually achieving value-based care. One way is that at the time of design of your program, policy, scheme itself, you try and choose interventions that are more cost-effective, and that's on your left side. So whatever the HTIN is trying to do, whatever it is trying to do in order to engage with the stakeholders and user departments is more towards trying to ensure that whatever interventions that get within the health benefit package, they are the ones that are the more cost-effective ones. So that's bringing in value at the time when you are designing your healthcare programs. There can be another way in which you could bring in or infuse value into the healthcare system, and that is by perhaps incentivizing performance, and that's on the right side. So once the services are delivered, thereafter, how you pay your providers is different between the ones who perform better versus the ones who do not perform as good. So this, the snapshot that you have there is of a policy that the NHA had put in place on transforming from more of a volume-based to a value-based care. But predominantly what we'll be discussing and what we have been discussing during the entire day is the left-hand side of the picture, and we'll not get into the right-hand side of the picture as much today. But just to say that what exactly are we trying to do? We are basically, through all the assessments that we are doing, we are trying to eventually determine whether an intervention is cost-effective or not cost-effective. If it's not cost-effective, is there a certain price point at which we can perhaps negotiate with the manufacturer, with the service provider, etc., that if the price comes down, then it can become cost-effective. And that's essentially what we are trying to do. So we're trying to determine that price that represents the right kind of value that we feel is fit enough or worth enough, or we are willing to pay that much amount of money in order to get that much of benefit. But in order to do this, what we need are institutional structures, something that I do not need to emphasize. Dr. Grace, through the different documents that have been published by WHO and the other learnings that she showed, she did emphasize quite significantly on the kind of institutional structures that we need to put in place. But I'll say that these institutional structures need to be put in place on 3 pillars. And I'm looking at these institutional structures not from the point of view of generation of evidence, but from the point of view of use of the evidence for policy making. The first is, you need to put in structures in place for engaging in that kind of a price negotiation. And this is not a very easy job to do, because what was being referred to in terms of stakeholder engagement, we also perhaps may need to manage a lot of conflicts of interests. We need to also make sure that the decisions that are made are based on those criteria that are the criteria for you to make those choices. We saw that in the morning, the Secretary Pharma perhaps made a remark in the presentation, that in his opening remarks, that we value the cost effectiveness, we also value reduction in out-of-pocket expenditure, we also value improvement in equity in outcomes. So I think putting those criteria on setting the values are going to be fundamental when we institutionalize such mechanisms. And this would eventually translate to putting in more robust systems for strategic purchasing in terms of what to buy, from whom to buy, and at what price to buy. But finally, all these 2 things predominantly are still within the space of more of a public procurement, or perhaps in the context of a payer agency like NHA. But there's also a lot of scope of perhaps bringing in the application of this value-based pricing in the context of, let's say, pharmaceutical industry and the job that the National Pharmaceutical Pricing Authority does in terms of price regulation. And that is again a point which is going to be fundamentally important, because the implications of anything that the NPPA does is much beyond the coverage of the beneficiaries or the services that a payer is offering to the population, because whatever the NPPA sets as prices becomes the kind of pricing regime for the entire market. So, but we need such institutional structures that can drive these processes. But to say that this is easier to do, it's going to be, there are still some fundamental problems and some contextual problems that arise in the way that we organize our systems of healthcare financing and paying. And I'll give you just one simple example. The example is in the context of a scheme like PMJY, for example. We have a payer. The payer actually sets a price, which is a bundled price. Now, this bundled price represents the price of the product and the service. It includes the cost of the hospitalization, it includes the cost of the surgery or the procedure, includes the cost of medicines, drugs, diagnostics that are given as part of that hospital stay. What we are actually informing through our ISHTA assessment is the price reduction in terms of the drug, the diagnostic test per se. So which means that now the payer has to perhaps, but you are not actually defining the prices separately for a drug, separately for a diagnostic test, or separately for an equipment. You are defining the price for the entire package of services that the beneficiary is receiving from the hospital, and the hospital gets paid a bulk amount. And so you might suggest a 30% reduction in price, and you, based on that, one option is you cut 30% of the bundled price. Now that becomes a challenge. You can't cut 30% of the bundled price because that's the price that also includes the price of the service as well. So which means that if you really need to, and the other problem with this is, you're shifting the entire burden or the risk sharing for the cost on the service provider, whereas the developer of the product or the manufacturer of the product may not necessarily get affected by that price regulation, because he continues to pay to the provider the product at the same price, but the payer pays to the provider a price point which is much lesser. So that becomes a challenge. So which means that you need to only perhaps consider a price reduction based on this evidence from ISHTA on the product price. And that brings us to the challenge that you need extremely good data, cost data. So which brings us again back to the point that Dr. Grace was raising, and I think the previous speaker, Dr. Michael, also raised. We need good data. The entire business of ISHTA is contingent on the foundation of good data. Now, what can we do in order to mitigate this problem? Because we can't just raise problem in this forum, we also perhaps need to suggest some solution. Now, there can be solutions, some which can be theoretical, but not practical. For example, the first one. So for example, we ask the NHA to also engage in the business of supply chain, which means for all the set of patients that are being treated under PMJY, the drugs, the implants, the devices are supplied to the providers for the set of patients that the PMJY beneficiaries are receiving. But then this is going to be a huge ask, because it's going to be a humongous task. So this is kind of something that goes off actually in the first place. So the next what we need, and this again brings us back to what Grace mentioned, is that we need extremely active stakeholder engagement and a consultation across stakeholders to say that this is the price point that we are bringing the service, the price down to. But this means that we need to bring down the price of the product as well by a certain commensurate level. And so each stakeholder within the transaction of that entire service commodity, which is the manufacturer, the stockist, the drug, the retailer, etc., and the service provider, need to recognize that if the price is being brought down, then who is the one who is really supposed to bear that reduction in price? The provider, the manufacturer, the stockist, at what level do we need to bring in? Or alternatively, there can be other different mechanisms of bringing in some kind of cost sharing or risk sharing for cost between the manufacturer and the payer. And those would involve certain innovative financing solutions. And one of those potential innovative financing solutions are some kind of patient support programs. Now, patient support programs means that, for example, the manufacturer agrees, okay, if you include this into the package, we would basically offer a certain number of fractions, for example, free of cost, and some fractions are being paid by the payer. Now, there is going to be a catch or a potential problem in this also, and that potential problem arises as a result of some kind of international reference pricing that these manufacturers have. And those international reference pricing are things that are more open in the public domain, and what they would then require, I mean, this is from the industry perspective that I can recognize, is that they would like some kind of confidential pricing if there is going to be a price reduction. But the pricing that the NHA has is explicit. So you explicitly report that this is the price that we have brought the service down to. So that's where perhaps we need some greater engagement between these stakeholders, bringing the payer, bringing the product developer, bringing the service provider together to discuss and come out with solutions on how we can perhaps safeguard some interests of the industry in terms of non-disclosure of some prices if that is the case, but also at the same time ensure efficiency is equally rewarded. There's another challenge, and that's more of a challenge regarding in reference to perception. So we talk about in policy making the role of perception and ideas. One of the common, often critiqued, the pushback on for any kind of a step that you want to take on value-based pricing, specifically that involves some kind of price reduction, is that it might rather discourage innovation, it might rather discourage industry to go away and perhaps not engage in production of that product which you are trying to bring down below a certain level. But the point is that it is not actually entirely correct, because value-based pricing actually incentivizes genuine innovation. So we heard the Secretary Pharma speaking in the morning saying that, in their recent endeavors, they're trying to think in terms of specifically for those products which offer health benefits, can they even incentivize by setting a higher price? So it is not necessarily that value-based pricing is always about reducing prices, but it is also about offering the right compensation if the product, the service, or the drug, for example, offers better health outcomes. And this is just a kind of a suggested framework for value-based pricing in the context of medical devices in particular. So, and this is typically, something that is drawn from Indian context, where we have the medical devices classified into scheduled and non-scheduled devices, etc. And then the ones which are scheduled devices, the ones which are homogeneous and non-homogeneous. There are many different mechanisms of, price regulation that the NPPA uses in order to set the prices, which could include ceiling prices for those scheduled medical devices which are completely homogeneous, or it could be a trade margin regulation for all those scheduled drugs which are kind of, Me Too type of drugs and devices which do not necessarily offer any additional benefit, but they are new products that come into the market by a given manufacturer. But there's a subset of those scheduled medical devices, and the same case happens in case of drugs as well, where there is a substantial jump, or these are innovative therapies, these bring in additional benefits in terms of health outcomes. That's one area where perhaps we could consider application of HTA-based decision-making rules for value-based pricing. And even if we want to kind of take baby steps and not really jump into too big, initial kind of mandates, we could restrict that to just the Class C and Class D kind of medical devices, which are the ones that are the high cost and the ones that are the invasive ones. And this would constitute a very limited set of total medical device portfolio, but which is significantly important both in terms of costs and in terms of the health outcomes. And there is significant state of readiness also in terms of the different stakeholders, the level of activities that they would have to do, whether it is NPPA, CDSCO, or the HTIN at the DHR. I think the kind of ecosystem right now is ripe in terms of what each of these actors and stakeholders need to do in order to bring such a system of value-based pricing a reality in the context of medical devices or drugs. We've heard these examples that Dr. Pankaj has already said. I just also wanted to highlight that this particular case of the example that he showed of use of HTA evidence for PMRT does also bring in improvement in terms of quality of care. And that's an important aspect. And this is something that is unique in terms of opportunity only with a stakeholder like NHA, that they can really enforce the standard treatment guidelines because they can make payments linked to compliance with those standard treatment guidelines. Because unless that is there, we all as doctors know how much compliant we are to even a standard treatment guideline that is put in place. Compliance is the biggest issue. The payer has that key to perhaps ensure compliance by linking the payments to those treatments. So finally, to kind of summarize, I'll say that broadly speaking, we need to have we need to recognize two things. One, we need these institutional structures in place. And secondly, we need, given the kind of different problems that I have also illustrated, we need more contextually relevant interventions and solutions to apply the HTA evidence such that the value-based pricing using HTA evidence becomes a reality. Thank you very much.
Thank you so much, Dr. Shankar. Thank you for highlighting not only the problems, and some of them were very contextual to India with the national insurer giving bundled payments, but also solutions to them on how you can bring all the stakeholders together and agree where exactly for what product the price needs to be negotiated and brought down. And also bringing forth that actually constraint actually facilitates innovation. So this perception that this will actually stop production is a myth, and this is probably going to give more innovative technologies, as we also heard earlier in the day from Secretary Health. And also you brought forth a very important point that we need an institutional structure. Really the time is right. You really have all the important stakeholders actually were part of the symposium, and to bring them together, this is an opportunity to create a fit for purpose, as I mentioned earlier, contextually appropriate solution for India. So with that, shall we open up for maybe one or two questions, Doctor, with the permission of the chair? Yeah. So wanted to ask in the audience if you have any questions for any of the speakers. I see a hand raised. Could we have a mic given to sir? Would you like to come up and share the question, sir?
Is 40% of the MRP, the maximum retail price. And the wholesaler then gives a further discount to the individual pharmacies, which they sometimes choose to pass on to customers. As a general rule, do you think that it would work for an approximation of for price discovery in the bundle of services provided?
I think this is for you.
I think that perhaps none of the solutions would be a perfect solution by any means. So whether it is fixing a ceiling price for the essential drugs by considering the kind of prevailing market prices, or whether it is the kind of example of trade margin regulation that you have suggested. One of the things that I can definitely suggest and potentially could be a way forward for the NPPA to consider is that in the context of ceiling prices, they generally consider the mean price across all, which is perhaps the problem. I think mean price is subject to gaming very significantly. Okay, you have a point as well. And by the time you grab a mic, for the trade margin regulation, I think that there's another possibility that could be there is that there is a possibility to have some kind of a differential trade margin regulation. So,
okay, I was suggesting more of if you debundle the cost.
Your voice is not audible, sir. I think the mic is off. Could we have a spare mic again shared?
Hello? Yeah,
yes, sir, it's working. Please,
okay.
Go ahead.
So I think I can make the first point about price discovery rather than margin regulation. The second point was that the earlier drug prices control orders were formulated on the pro rata basis, in the sense of cost of goods and cost to manufacture, and then a markup on that. Something happened in 2011 that the entire mechanism came to this central tendency does not exist. I can tell you from several surveys that there is no mean retail price. So this has to go out. Something has to be done out in the DPCO itself.
Yeah, that's a very valuable point. I want to open up and ask if there are any other questions in the audience. Yes, Dr. Sitanshu, could we have a mic shared with him at the back? Okay. Excuse me, behind.
Yeah, you can hear you well.
No, we definitely want to hear from you, sir.
Thank you. It was really an exciting session. And I have a question for Dr. Pankaj. So, sir, when you discussed about the horizontal scanning of prices of interventions, how often do we do it? And the second point is, suppose you find that one intervention is not coming into the health benefit package, it's possible that over a period of time the price can go down or can go up. And then in that case, what is the solution or what is the decision that we take and how often it is done? Thank you.
Thank you, Dr. Tanshu. Actually, that's what we did recently, and it is for sure, especially for the cancer drugs, the prices, with the new introduction of new drugs, the price of the previous drug go down. And if they are a part of the packages which have been made earlier, they might be having more rates. So they need to be revised. Can be gone through every 6 months, but yeah, yearly must be revised. And yes, the rates can go up for the other drugs, not the cancer ones. If the new innovations are not coming, you have seen that for the antibiotics and other drugs which are less for profit for the industry, as well as they have a lot of cost which is involved in developing those drugs. They are not being taken up by much of the medical manufacturers. But the cancer drugs, being the mere margin of the profits they generate when they're innovated and the patent is there, they have been introducing new drugs. The advantage to that is that the previous drug gets cheaper. And that's why the rate needs to be revised by the authorities like us or any other country, because otherwise there will be a loss to the exchequer. So yes, it has to be done, and several drugs rates go down, few of them go up also, and that needs to be considered. And the horizon scanning for the rates, you're saying, has to be done at least on a yearly basis, maybe earlier if the new technologies are coming in that field. So I'll suggest that should be done with every country, not India only, because it leads to a lot of money which can be saved and can be redistributed in the different diseases other than those drugs where the cancer is there. Yeah.
Thank you so much, Dr. Pankaj. I saw a hand raised by Dr. Biju Soman at the back. Here. Could we have a mic here? Yeah. So this is the last question, and then over tea we can have more questions. The faculty will all be there with us.
Thank you. This question is to Dr. Princha, actually. Again, the issue of costing. Actually, right now, SPB, health benefit package, is coming with the bundle cost. But rather than go into the detailed supply chain costing, can we come up with some general costing, like for room rent, for ICU, for surgery, for example, theater cost, anesthesia cost, and also that kind of general costing, if you can come up with, then that'll be much more convenient, no? In a country like India, where there are a lot of regional differences and all. For example, when we were trying to do some sort of costing for one of the state-run insurance mechanism in Kerala, actually we found this bundle cost very inconvenient. We were thinking about if we have much more detailed costing, need not be that detailed as you were suggesting supply chain, or not all those things, but some general listing, like for anesthesia, local and general, this one, for theater cost, for room rent and all. So that can vary from state to state also, and whether that is a possibility?
I think, yeah, so Dr. Biju, the point that you've made is absolutely right, and I think that while the final price looks at a bundled price, but the cost data that gets inputted to eventually derive that price actually uses individual kind of cost per bed day, how much it is, and then considers the kind of length of stay of a given procedure, etc. And these are all that are at the level of specialty rather than at the level of the entire hospital also. The catch is that while if you say that we try and estimate some very generic prices to make it relatively more easier, the stakeholders on the other side, who are the hospitals and the service providers, they are rather asking to make the pricing even sensitive as per patient characteristics, what to talk of just the specialty, just stratifying by specialty or something like that. So it's a debate, but eventually the whole intent is in the current pricing system that is there. The current pricing system does try to take into consideration all the kind of supply side characteristics of a given hospital that can likely influence the pricing or the costing structures. The current pricing does not is not sensitive to the kind of patient characteristics. That means a given package, let's say a hernia surgery or let's say a CABG patient may come with different comorbidities or complex or complications, etc. The price is a single standard rate that is paid for a CABG. So actually the work that is being done by the NHA as a way forward is rather to make the pricing even more sensitive to patient characteristics. So I think the move is rather more and more fine to go more as much as fine in terms of the costing and the pricing.
Yeah, ultimately we have to move in that direction, no?
Thank you. So with this, I invite the chair, Ms. Anu Nagar, for her concluding remarks.
So we've had a very enlightened and an expert panel here, and I feel constrained that what I might add after all of you have spoken, and Dr. Shankar, Dr. Pankaj, Dr. Michael, Dr. Grace, Dr. Abha, you've had a very nice presentations, and like you raised, Dr. Abha, that we need to have a mechanism for fair pricing when we talk about value-based pricing. So what is fair pricing is an issue. So what is fair for a patient is not fair for the industry, and we really need to have good stakeholder consultations, or another word, stakeholder engagement or consensus, like you said, and mechanisms for that. And Dr. Shankar rightly mentioned what could be the mechanisms for stakeholder consensus or engagements or different kinds of pricing that you've really talked about. Dr. Pankaj has told everybody about NHA and how NHA is utilizing HTA. For us in health technology assessment in India, NHA is our biggest client, and we feel so proud working for NHA, which is the biggest insurance scheme in the world, and we are happy that you are able to uptake HTA recommendations, and there has been revision of lots of packages. And about trastuzumab, it was really heartening to know that we've been able to save about 66,000 per patient and rupees 11 crores per year. So that is the kind of example that we want to set, and we really want that we should really go ahead with more HTAs in NHA. And we've really tried a sincere engagement with us. We have a dedicated nodal officer just looking after NHA's HTA assessments. Dr. Michael, we were very happy to know about the Cheaper Medicines Act and how legislation has helped in providing really the cheaper medicines. You've been very direct about it. Dr. Grace, we totally agree with you, the institutionalization of HTA and through the HTI in India. So we have kind of institutionalized HTA. Now it is a responsibility of the Department of Health Research. It is one of the business allocated to this department, and institution has been created. Now we need to equip it, build the capacity, and really take it forward. We've seen examples like pricing of sickle cell, wherein we've really been able to save thousands of crores of money for the government of India. Safety engineered syringes, wherein government of Punjab has benefited. TB, latent TB tests for TB, we've been able to reduce prices. So these are a few examples that we've been able to quote, but this number is very limited, and I urge all our resource centers who are sitting here to engage with the state departments and really to take up good topics which can And they're waiting for you to actually take up these topics and help them out. So we've been talking about cost thresholds. Cost thresholds have to be differential. We can't have the same cost thresholds for government systems, for hospitals, for patent medicines, for rare diseases. So we've been trying to work on a system which is an Indian system, which follows the basic principles of HTA, but we have our own rules and own mechanisms. We talk about provisional HTAs, adaptive HTAs. We are flexible and we allow our innovators access into the health system. So we've been working on it. We know data evidence is a problem. We'll have this session later in the year, later tomorrow also. So thank you very much, all the panelists. It has been an eye-opener listening to you. I have been noting down your points very methodologically, and I'd really like to take this forward through the HTA system that we have. Thank you.
Ma'am, a big round of applause for the chair of our session who's concluded this so comprehensively, and for all the panelists. I think everybody's tired. A big round of applause, please. Then we'll all go for tea. I think we need to celebrate that. So with that, I want to invite Dr. Sangamitra, who is the Additional Director General at ICMR, to please come and felicitate the chair, Ms. Anu Nagar, Joint Secretary, Department of Health Research, with a memento. And now we invite Dr. Pankaj Arora, please come forward. Sangamitra ma'am, if you can please felicitate sir with a memento. We are very thankful for your participation. Now invite Dr. Michael. Ma'am, please if you can felicitate Dr. Michael. Big round of applause, please. Thank you. Thank you for being a patient audience and listening to all of us. I now invite ma'am to felicitate Dr. Grace. And now, ma'am, please if you can felicitate Dr. Shankar Prinja. Nice, good. Thank you. Thank you, ma'am.
And if you can now felicitate Dr. Abha.
Thank you.